morning, dear colleagues. We start. It turns out we have a lot of people, and during the last year, nothing has changed. I mean, we have not become official institute. We didn't have round-robin messages, but we have Telegram channel where we have more than 3,000. We did not collect abstract, but we have quite intense agenda. Well, it seems that it is our particularity. We have interesting presenters, high level of preparation. The whole year we spent with the raccoons and even had these raccoons with us. Well, it is not my choice. This year we have more than 200 offline presenters. We'll have translation here. We will have international speakers. For the first time, we have 3 nurse sections. And thanks to Elena Borisova, they are very interesting. And we have 38 senior nurses who came here. We have 2.5 sections dedicated to oncology. It's for the first time we have special session for safety, radiation safety. We have here PhD in biology. It's new for us. We have traumatologists, pretty rare experts who are dealing with peripheral vessels, and we have a whole session dedicated to it. I do hope that for the first time Alexei Fedorchenko will come, our big friend. He has never been to our events, though we're always here in Krasnodar region. We are waiting for Badmo Bashankaev, the head of State Duma committee. At the last moment, he said he has urgent business trip. He's coloproctologist. He learned in the US, and he supported us. And we got the support of Russian Scientific Society for Intervention Cardiologists. We have these scientific status. It was Mr. Kokov initiative. We will share the prizes, the books that are signed by him. We wish you all luck, and we have very intense agenda. Thank you. Well, good morning. I'm happy to see all of you. It's high time we start on non-state network of PCI centers from Ulyanovsk. Good morning, dear colleagues. My presentation is the first, and I'm quite anxious about it. Thank you for the possibility given to me. I would love to share the experience of PCI centers and helping people with CHD. This network of PCI network was established back in 2015 when the first center was established in the town of Ulyanovsk. Then the network expanded, and we had 5 centers in Ulyanovsk, Bratsk, Pavlovo, and in Biysk. The coordination of center work is managed by a managing company in cardiology, radiology, and intensive care units. Analyzing our work in 2023, we see that total number of patients was more than 8,000 patients. Mainly these are patients with acute coronary syndrome. Also selected angiography, thromboextraction, pacemakers, and stenting. As I mentioned already, the main part in our work are patients with acute coronary syndrome, with ST elevation 1,867 interventions, without ST elevation 1,320. Mortality ratio in acute coronary syndrome are quite positive. It was only 4.2%. Selected coronography is also very common. It is performed in the day stationary, more than 2,000, and in stable angina, 849 patients. At this slide, you can see total results of our work. Total PCI 4,033, stents implanted 4,598, interventions on the main trunk 195, intravascular ultrasound 176, IFR 85, blockaders 189, and Rota Pro 3 persons. The structure of the center: cath lab, PRIT, day care, and stenting. Or all the centers are in their profile institutes, and here you can see the scheme. The patients who are driven by emergency are accepted, examined by cardiologists and PCI experts. Then the patient is sent to PCI center. If needed, PCI with stenting is performed. Since 2022, we can perform intravascular visualization. Starting from 2024, we started implementing rotablation in severe calcification. If needed, we organize telemedicine conferences and offline multi-board meeting. More than 278 consultations were organized in 2023. If there are no indication, patients are sent back to cardiology department of city hospital and to the second stage of rehabilitation. The legal status is justified by the orders of healthcare departments and by the order of patients' routine for invasive diagnostics and treatment that is performed by consilium with the physicians of Central City Hospital. Here we can see the scheme of routine of the patients. To each center. As I mentioned, we have two centers on the left and on the right riverbank, and we have more than 800 patients that are served by our centers. Here we can see well that Ulyanovsk region is one of the leading regions if we talk about angioplastics, and urgent angioplastica is taking 75%. We also see that accessibility for the patients is quite high, 192 per 100,000. With ST elevation and without ST elevations 42 and 36. As for cardiosurgical interventions, it is not that good, but urgent bypass was performed also in our center with good results. Keeping in mind urgent cabbages, we have the system of ranking of threat and urgent personal invitation. According to the documents that we have medical record. We have also developed and implemented high technological means that is synchronized with recent guidelines with high level of algorithmization. When the patient is accepted, immediately we see the tests that are to be performed. When filling in the form, we see the code of the disease. It helps a lot when we record the medical history of the patient, keeping in mind also the requirements of the insurance system to prevent any fines. To implement the strategy of risk control and risk management, Mr. Shlekhto developed this strategy, and we have the Office of High Risk Diagnostics with pharmacological and treadmill test. It is performed on the first stage and on the diagnostic stage if we have acute events and rehabilitation. You can see here stress echo office with special equipment, and all the staff was trained well. Total number of the tests increases every year, and Ulyanovsk has been using this method since 2018, and we have performed already more than 900 events. It is also used in Bratsk and in the town of Pavlova. To conclude, PCI centers demonstrate the efficiency requirement and efficient cooperation with state medical centers. They efficiently become part of state system. They increase the availability of highly technological help without additional financial resources, adopt different requirements, and we see very good dynamics. The issue is only the reporting system, and PCI centers should be integrated into regional information system to have coordination of medical help. Thank you for your kind attention. Thank you. Thank you so much. Any questions? Thank you. And thanks for this great result, really good result. Your biggest problem is that you don't know where to send the report. I hope this will remain your biggest problem. Well, short comment first. When the help for the patients with acute coronary syndrome is organized, for the patient, it's absolutely doesn't matter whether it's federal or private center. It's important to get the help. My question is, when you demonstrated what happens to the patient with ST elevation infarction, only after multi-board consultation you can transfer the patient to the cath lab. Why do you need this multi-board meeting? If it is ST elevation segment infarction, you can send him immediately to the cath lab. Well, the practice is there. Two legal persons require particular cooperation. The point is that we meet before the patient is arrived. The emergency informs us. We have cardiology of central hospital, our anesthesiologist and radiological surgeon. You mean the surgeon is not in cath lab? We have two of them. One participates in the meeting for particular situations if there are some excess issues. What happens if cardiologist, so the endovascular surgeon says, no, we're not doing it? I don't remember these cases. Cardiologists do not always agree, but we always try to help, even if we doubt. Thank you. Great. It is really good organized, well organized. Well, thank you. Thank you for your presentation and good organization of help. Well, we have to have quality, right? When the patient is already here and we do everything we can do. And the other thing is the availability. And you demonstrated that per 100,000 of population, you have 190 PCI. So it would be 1,900 per million. In our country, our average figure 1,100 or 1,200, and you have 1,900. It's very good result. You have result that is similar to European. Well, it was the institute evaluation. It is not our digit. I think that in Ulyanovsk, the availability of the help for the patients with acute coronary syndrome is very high, and we're following standard guidelines. Unfortunately, we don't have a lot of time. We have only 7 minutes for the presentation, 2 minutes for questions and answers, and we invite the next presenter, Mr. Solovyov, intravascular ultrasounds in patients with STEMI. The patients who have PCI will appeal to you. Okay, good morning. I would love to talk about IVUS in patients with STEMI. Today, we do understand that we have to use IVUS and we need to systematize this data. Garimid's analysis help us a lot. And you know that at the endpoints, IVUS group is better than the angiography group, and the conclusion is that IVUS should be used on a routine basis, especially in high-risk patients. But if it is ST elevation, till 2023, there were not many studies. The result was that IVUS group has less mortality, but there is also Korean study that demonstrates good result. In IVOS group, the mortality was double low, but at the end of 23, two big publications appear. Outcomes of intravascular ultrasound guided percutaneous coronary intervention among patients with acute coronary syndrome, and in the group of IVOS, there were 40,000 patients and 560,000 angiography group patients. And in hospital, mortality was higher in angiography group. The biggest study here included 300 million patients. 3 million patients were in angiography group. In non-STEMI group, there were no difference, while in STEMI group, the mortality in IVOS group was 1.5 times lower. Why do we use IVOS in STEMI? We see the morphology of the plaque. We can evaluate neuroflow risk, and in selective patients, it is the definition of stent implantation point and optimum results of PCI. We analyzed our patients. They were searched since June of 2022 till now. We took all the patients, 347 patients were operated with angiography, and out of this group, we excluded the patients with cardiogenic shock because definitely the mortality was high in this group, and IVOS was not used in these patients. It turned out that in 35% of cases, we used IVOS in patients with STEMI. We compared these patients in clinical functional characteristics. There was no difference, and intraoperation characteristics. IVOS was used when the lesion was in anterior intraventricular artery. In angiography group, it is right coronary artery. The frequency of post-dilation was higher in the group of IVOS, and the result that we have, as for TIMI blood flow, no difference. But in angiography group, post-dilation was performed in 32% cases, and IVOS post-dilation was performed in 83% of cases. And as in hospital mortality, in IVOS group, it was lower. These were the same patients operated by the same experts. And one clinical case, it's our everyday practice, the patient that was accepted 3 days ago, the patient with thrombotic subocclusion of right coronary artery. First, we introduce the probe, and we check the morphology of the lesion. Considering the place of stent implantation, we perform predilation. Nitroglycerin, and then we can perform IVOS to define their implantation point. We see the distal point of implantation on the side branch point and proximal point, decide what are the references. We implant drug-eluting stent, control IVOS. We see that the stent is not fully expanded, but we know the size of the artery, and we can perform post-dilation. It is 3.75 balloon, 26 atmospheres pressure, final IVOS. And after we see that we achieved the optimal stent criteria expansion, we check MSA to the distal reference, and then we finalize the procedure. This is final angiography. To conclude, we can influence the endpoints such as all-cause mortality, secondary occlusion of our patients, and IVUS is the way that gives us this possibility. Thanks for your attention. Thank you. I'm afraid we're behind the schedule. Just one short comment. I think you will not understand me, but why you perform all this manipulation in the patients for STEMI, but mortality decreases. Mortality decreases. There is OCT method, and I think we will speak about that. Alexei Yurievich, who will talk about OCT and acute coronary syndrome. Good morning, dear colleagues. It is a clinical case how we use OCT in patients with ACS. A patient, 63 years old, with spine disease. Once she felt the pressing pain, she checked her pressure, 180 to 120, and she took some drug, but next night she had the same pain. She addressed the physicians. Troponin and ECG were taken, and patient was hospitalized, and she was sent to the cath lab. Coronarography was performed urgently. Diffuse lesion of anterior intraventricular branch was seen, and subocclusion of circumflexion was seen. On this stage, angiography was in line with the clinical picture, but nevertheless, when we performed angiography, we see the defect of proximal third. It was defined as thromb, and we see about 50% of stenosis. As a result of coronarography, we see it is multi-vessel lesion, and we started following principle of heart team. It was decided to perform endovascular treatment, as this is circumflex branch. The first solution was to perform stenting. After angioplasty with balloon catheter, stent implantation was performed with fine result. But immediately after that, the question was, what's next? Do we stop or do we continue? At the moment, there are no randomized studies that would compare the efficiency of full revascularization with infarct-associated artery. The last analysis of non-randomized study demonstrate the advantages that was reflected in the guidelines. Coming back to our patient, to understand that the lesion of right coronary artery is not obvious. Angiography is not enough. When the picture is not straightforward, according to the guidelines, we need to use intravascular imaging, including OCT. Depending on the results, we decide on the following tactics. It is well known that there are many reasons for acute coronary syndrome. All in all, it was decided, as we don't understand whether the lesion is stable and angiography does not allow us to see it all, and we have a view from the other side, and that's why we performed OCT. We saw the thromb in the vessel with very thin cap plaque, and it was unexpected to see this plaque with dissection in the middle third. Together, this coronary artery lesion was considered as unstable, acute, with a high risk for the patient. The next stage was right coronary artery stenting. On the OCT data, stent was chosen and it was implanted with fine angiography result. Immediately, control OCT was performed. We see that stent position is fine. And to conclude, I would love to say, in the clinical practice, we see quite often patients with dubious lesion, and OCT helps to choose the following tactics. That's all from my side. Thank you. Thank you for the presentation. When you have 2 stents implanted, the reactivity of thrombocytes was taken into consideration. Do you know the creatinine level? Was there contrast? How did you control the safety? During the surgery, about 150 milliliters of contrast was introduced, but kidney function was preserved totally.
Well, the women was under investigation. Sorry, the question was of the muck. Brilinta, well, the patient got Brilinta. She was hospitalized. All right. We're slightly behind our schedule. We need to move on. The next presenter is V.Mayskov. The theme of the presentation is unknown. It's marked here as Beware the Pattern. Well, I don't have IVUS. That's why, how can I surprise you, all the people present here? Well, I looked at what we have, and it turns out that over the last year, we've been working with the new term, which is just a calc from English. Well, that means pattern, that's the term we use, and that means a combination of elements which combined will allow you, with a certain percentage of confidence, say how we are going to see the development of events to make the situation predictable. Well, there are some electrocardiographic situations which are not detected by a large number of patients who are hospitalized with infarction and even acute MI, and EKG patterns are things that we knew before. We just described these EKG patterns. Well, we just passed the knowledge from specialist to specialist, and that means there are changes that may be behind the small informative EKG changes. If they're not detected in time, if we did not understand what this pattern meant, the patient did not get proper therapy that might result in cardiogenic shock, strokes, and even death. The outcomes of such patients would be much worse. The quality of life would deteriorate. You can see here EKG changes, and you can see Well, our specialists, our teachers just talked about high-risk patterns that were described in the past. Here you can see the 2023 guidelines. They were written into those guidelines, and right now we must focus on them in our clinical practice. There are also recommendations for STEMI, non-STEMI patients, and you can see patterns shown here on ECG. Well, as for STEMI patients, everything is quite clear here. We will just focus on these patients, even if we do not know the site of the lesion, but we're interested in ECG patterns corresponding to non-STEMI patients. And as for these patients, we can miss a big area of ischemia or myocardium, and we can just miss such patterns and do not provide assistance to patients with massive infarction. These ECG patterns can be another instrument for patient triage, especially when we're talking about the first medical contact. In the cardiological department, I'd like to draw your attention to this particular study, and this person, Henrik Valens, a cardiophysiologist who described changes on ECG of the ST wave, and they just followed the destiny of these patients. They were unfavorable patients. They did not get surgery, and usually their life was very dramatic. They had MI developed, and most of these patients died. Autopsy revealed, well, subtotal occlusions of the proximal segment of the anterior intraventricular branch. Well, it was the Valens syndrome. This syndrome is very widespread. 20% of patients with ACS have this syndrome. 75% of these patients usually have undetected pattern, and if they do not have a coronography done within the next week, well, they usually have the massive MI. By the time the ECG is done, most patients usually do not have any pain syndrome. Many local protocols in our inpatient hospitals assume that if there is the troponin A elevation, the patient must be sent to the pharmacological test. There is the subocclusion of the anterior intraventricular branch. There is an ST elevation, and there is the threat of death. Well, there might be a death on a treadmill, for example. There are two models of T wave anomaly. You can see there are two types, type A and type B, but that's the evolution of the same process. Short-term elevation and the resolution of the ST sigma segment. And later, they evolutionize into the, well, negative pattern. So this T wave shows us that this is the high-risk patient in terms of the massive infarction development. This slide shows that type A and type B patterns are the evolution of the same pattern in the basin of the intraventricular branch. We should pay more attention to these ECG patterns because thus, knowing that we can prevent sending a patient to different types of diagnosis, which is unnecessary in this case, but cardiologists right now, on the basis of angiography, can send patients to specific procedures when they detect such patterns. Here is an example. A patient was hospitalized while the patient had no pain syndrome. Suddenly, the ICU cardiologist rushes into our room, and we will just measure troponin A level first and foremost. Look at this pattern. Well, it looks like the situation is bad. We do the coronography, and there is a subocclusion of the AIVB, and again you can see, well, as for grace, it's 140 points. The patient should be sent to cardiology and put on a treadmill. And so after this, the patient turned out to be on the operating table. Here is another clinical example, a patient with more significant changes to phase T wave, and you can see the ICU specialist thought there was the involvement of the AIVB. Occlusion was detected, coronography was done, and on the basis of the changes, there was the high-risk pattern detected. The patient remained stable. Well, that's not an elevation of the ST segment. Nevertheless, according to resuscitation specialists, the patient needs early invasive strategy in treatment. So take-home messages. The knowledge of ECG patterns in case of ACS allows us to send the patients to direct angiography with revascularization in the future. ECG patterns can be used for triage of patients in the emergency room, as well as during the counseling. Information about ECG patterns in case of STEMI patients allows me, as the head of the department, to make a decision regarding the necessity of using specific interventions and send the patient to my colleagues who can cope with this task, such as the posterior function, AV block, etc. Thank you very much. Thank you. Well, an endovascular surgeon is talking about ECG patterns. Well, but the Valence syndrome is very important. And in fact, we must think about this all the time when there is the T wave, for example. That means the subtotal stenosis of the AIVB. And there was another pattern which was on your slide, but which you didn't mention because of time. That's the changes on the ECG, typical for the left main lesion, when there is the elevation of the ST segment with many depressions of basically ST segments. These are the most dangerous patients with the worst prognosis when they are in the cath lab. Well, according to our experience, unfortunately, the situation is so that patients who are in the cath lab can be divided into groups, like, for example, with STEMI patients, non-STEMI patients, and there are patients who should be considered as STEMI patients. And recent guidelines, European guidelines and American guidelines, basically prove that with such patterns, the patient must be brought to the cath lab as soon as possible to make sure that everything is all right and to respond to the situation very quickly. Unfortunately, the outcome is much worse in such patients. Let's move on. The next presenter is from St. Petersburg, Mikhail Tugbaev, application of the combined thromboextraction technique for massive thrombosis of the right coronary artery. Please. Well, good afternoon, dear colleagues. I'd like to apologize. My voice is a bit hoarse. Well, you have to bear with me and with my hoarse voice. Well, a patient was hospitalized to our clinic, 63 years old. You can see the clinical picture here, cardiogenic shock according to ECG. Well, a STEMI patient. Well, the patient is on neurotropes, and the patient was brought to the cath lab. Well, coronography was done. Well, you can see the left coronary artery, no changes. As for the right coronary artery, well, you can see the massive thrombosis was detected here. Well, narrow lumen, basically subocclusion. Also, there was the expanded lumen of some arteries up to 6 millimeters in some areas. So in this situation, we had some doubts in terms of standard aspiration catheter use, like 6 French, that we have at our disposal. And since we are dealing also with the treatment of acute ischemic strokes. Well, we decided that we use aspiration catheter 6 French that we usually use for thrombotic extraction in brachycephalic arteries with the internal diameter 0.071 inches. Right junctions, 8 French without side holes. When the guide catheter was placed, well, we used A2BB blockers, then aspiration was used, back lock syringe, and the vacuum pump. Double aspiration is always used in case of ischemic strokes. It proved its efficacy many times. The idea is when there is the jailing of the aspiration catheter in the lumen with the thrombus, and we do not know where the thrombus is, at the tip of the catheter or in the lumen, we are thinking at the tip. And when it was placed in the guide catheter, there is a risk of thrombus slicing. That's why, to avoid this, we do the second aspiration on the guide catheter. Here is another patient, massive thrombosis of the internal carotid artery, and I would like to show you the way it looks like. Here is the video, a real-life video, and you can see there was the jailing of the guide catheter, 6 French. Destination catheter was used here. Well, jailing by the thrombus, it had to be removed from the body, so we used the introducer. We used the vacuum system for that. Well, then the aspiration catheter was used. We did some pullbacks. Again, you can see the part of the thrombus was removed twice. Well, there was the jailing of the guide catheter with the thrombus. It had to be removed from the orifice of the coronary artery. Well, during the extraction, the thrombus basically flew into the Y connector. So thus we managed to remove most of the thrombus, but part of the thrombus went into the distal part, and any other attempts of aspiration were inefficient. So we made a decision to use a combined thromboextraction with the use of a stent retriever. For that, we placed the microcatheter behind the occlusion zone with the imaging of the distal part to determine the landing area of a stent retriever. It was opened. Well, again, you can see using one of the techniques of combined thromboextraction, the remaining thrombus was removed. So thus we managed to restore the integrate the blood flow, to remove all emboli from the artery. Hopefully we did not have to do balloon angioplasty, and we didn't have to perform stenting. In the early post-operative period, the patient was stable, the sinus rhythm was restored, he was discharged on day 11. Thank you very much. Thank you. Just one question, if there is any. We're pressed for time. Thank you. No questions. Okay, let's move on. The next presentation is from Samara. Guide catheter aspiration, a method of choice or an act of despair in coronary thrombosis. Well, good afternoon, dear colleagues. We know that thrombus as aspiration is not recommended in coronary thrombosis, but sometimes when we cannot cope using the aspiration catheter 6 French, the question is how to provide assistance for the patient, to place it like this or to come up with something else. There are specific methods here, for example, aspiration using different neuro instruments which may not be available. Guide extensor is another method. So we decided also to use a guide catheter, 6 French, the usual 6 French guide catheter. Well, we did the comparison of internal lumens, and we decided that we will develop our own method to effectively and safely do the thrombus aspiration in case of massive thrombosis. And we got a patent for this method. Well, here are the indications. Well, again, STEMI, non-STEMI, massive thrombosis. Well, useless attempts to do the aspiration using aspiration catheter. Well, the diameter of the target vessel at least 3.5 millimeters. Here you can see the methodology of performing this method. Well, infusion to B3A, also the guide placement, and again, we rotate the catheter according to the anatomy of the vessel by bringing it to the place of the thrombus. Then we use the aspiration syringe to perform the thrombectomy with the negative pressure. Over a 2-year period, we've done more than 250 aspirations, mostly men, mostly STEMI patients. And again, usually we do it in the right coronary artery. And you can see also in the AIVB and also in the circumflex. As you can see it here, but with the circumflex, it was very difficult to place the guide catheter there. As for complications, well, you can see slow or no reflow. Well, distal embolization in 3 cases out of 72 patients. Then we did the aspiration with the usual catheter perforation, just 1 case. And we can see that it was in the circumflex, and it was quite an aggressive procedure. We tried to use the anchor balloon to place the guide there. No wonder there was a perforation. Here is one clinical case. You can see the right coronary artery is intact. The embolization in the proximal segment of the AIVB. And again, there was an attempt to do the aspiration using the usual catheter. Well, it was unsuccessful. Judkins got to the lesion. We did the aspiration, and you can see we performed the stenting. That's what it looks on angiography. Well, here is the second clinical case, a more interesting one, the embolization of the right coronary artery. Other arteries are intact. Aspiration was performed, and we did not see the substrate before the stent implantation, which is quite good, I should say, because often when we try to do the revascularization, balloon plasty is done, and that may lead to dissection, and the operator will have to do the stenting, although it may not be needed. Here is the third clinical case. Again, aspiration was performed. Again, STEMI up to 12 hours, and there is the 1-day infarction in a young man. Multiple attempts of aspiration, then multiple aspiration with a guide catheter. In fact, the entire trunk of the right coronary artery was filled with thrombotic masses. Then aspiration was done. And after the stent implantation, we did the pullback. And on CT, you can see there are some remaining plugs, but in general, the result is quite satisfactory. Well, the operator was the only one. He was on duty at that time. In general, we were quite satisfied. Well, thus we believe that this patent method in general is safe, can be used in those cath labs where there is no possibility of using neuro instruments, and in most cases we have cath labs like that, especially in the regions. Thank you very much for your attention. Thank you. May I, if I may, just a brief comment. The first cases using the aspiration with the guide catheter were used by our European and Japanese colleagues way back in the 1990s, in early 2000. Well, they started using D.Monosov systems. Mother-child system, for example, as an alternative to the aspiration with guide catheter. So small wonder this method got a patent. Well, before we get down to questions, well, please raise your hands of those who believe that guide catheter aspiration is an effective and safe method. In case of MI, please you raise your hands. All right. These are your people, right? Thank you so much. May I make one minor comment? Yes. There is an alternative to guide catheter. That's the Terumo company. I have no conflict of interest. They have a 5 French catheter, 195 millimeters. Well, they use a 6 French guide. We use them all too often when we have massive thrombus. Well, this Terumo catheter is very efficient without any problems. We can use this catheter for the circumflex, well, without any risk of perforation. And, well, it's cheaper. All right. Okay. Use a microphone, please. It's important for simultaneous interpretation and for our live feeding. Please turn on the mic. It's important for the live streaming. Often, lesions in case of coronary syndrome are of diffuse nature. How many cases of dissection of the coronary artery did you have? And when you do the aspiration, you prolong the stenting area. You didn't have any dissection shown on your slides. Well, there was 1 or 2 cases of dissection in case of distal embolization, as in one of the cases. This patient had the stent implanted, and we had the proximal plug. There was the dissection. We had to implant an additional stent. Thank you. Dmitry, before you announce another speaker, I would like to say a few words on my behalf. This method has the risk of perforation. It cannot be safe by definition. For me, that's my opinion. You may disagree with me. Thank you very much. Well, Dmitry Monosov, St. Petersburg, experience in the treatment of ACS in elderly patients. Thank you. Well, good morning, colleagues. Elderly patients, well, with ACS, I will be talking about different instruments used. No conflict of interests here. Well, again, and elderly patients, I think we treat elderly patients, but again, you can see like patients from 75 to 90 years of age. We'll be talking about them primarily according to the WHO characteristics. Here are the major problems. Well, I worked in 4 hospitals. Well, they have such problems as access, calcium, compliance, and new technologies. As for access, well, the patient may have a PCI done, atherosclerosis. Well, you can see uncorrected hypertension. And last year, we saw that patients have problems when we use the right radial access, we use the guide, we use 1 diagnostic catheter. Well, then the second catheter goes into the descending aorta. When we try to rotate or something else, well, there is pain in the shoulder. You can see the catheter here at this point, and then it doesn't move. What should we do in this case? The catheter got stuck, jailed. Well, we just do the rotation. We use other standard technique. Nothing works. Well, no problem with the guides. The guides are rigid. No problem here. Well, so the major thing is when we do these manipulations, well, nothing happens. Everything is jailed. But the problem is atherosclerosis of the brachial artery, and maybe because of the spasm after the first catheter got passed. And you can see, again, with such plugs, well, the catheter cannot just move. Well, so we cannot just move forward. What can we do in this case? Again, the first option is the use of bilateral catheter when we can just use the diagnostic catheter, 5 French, also NGL, introduction, 50% of success, and also we can just change access from left radial or left brachial. If the change of access is impossible, you can rotate the catheter counterclockwise without moving it forward, and again you have to do it like for 15 minutes or something like that. To do rotations within a 15-minute period in order to get to the aorta, and then you do coronography. Well, let's go back to the issue of access. A man, 87 years old. Well, again, you can see CABG was performed. Well, the patient was a non-STEMI patient. You can see left radial access, and you can see through the left arm. It's impossible to do coronography. There were multiple attempts performed. Then we used the femoral access, and then we were looking for shunts. We detected the right coronary artery stenosis. Stenting was performed successfully. It took us about half a liter of contrast media, 11 catheters. Well, the diagnosis itself took 2 hours. And again, we used outer-masked tensor stent. We did the dilatation. Well, I understand it looks horrible. Well, half a liter of the contrast is horrible, but you can see 3 catheters broke when we tried to do the catheterization. 8 catheters were used just to identify the shunts for this access. Here is another problem. Calcium, a woman 92 years old. Well, she had the CABG, repeat CABG, well, 12 PCI, 11 stents, and again, you can see transitory elevation along the side wall. You can see the picture here, and again, there was just 1 shunt, and again, you can see subocclusion of the 1/3 of the artery. The stent was placed, critical stenosis, and in 3 hospitals, they didn't manage to do anything.
Next, lung and heart predilation of this calcified part. 9 balloons, 8 balloons just got blasted. It was just a nightmare. Each time when we had the balloon rupture, we thought, now we'll go to the cardiac surgery. And what helped us, put nice stent from the second attempt, passed through the zone with a little bit of physical force. And after the implantation post-dilation, we got good angiography result. And the patient didn't have the angina relapse. And this is my favorite man, 88, came for stenting. He had the relapse of angina. He's not taking any drugs. He is smoker, heavy smoke with obesity. What we found on the subocclusion of posterior ventricular branch, and we see the filling of right coronary artery through this branch. Very severe surgery. There were attempts to recanalize the native flow, but it didn't happen, and it was decided to stent retrogradely the ostium of posterior intraventricular branch with severe difficulties. It took us few hours, but we managed to do it, and we implanted it after all. So it is suboptimal, but still a result. Intraoperatively, we explain to the patient what he has to do. He says, nothing. I'm not taking anything. Everybody talked to him, but we were told that big pharma bought us all, and the result is suboptimal. There was prevention of nephropathy. We recommend recanalization of right coronary artery. The patient is discharged. And now the second part. 10 days. A call. We are having a clinical death. The patient discontinued all the drugs. STEMI, atrial fibrillation. He's accepted to the OR. And what do we see? Well, it's all obvious. The stent is full of thrombus. We managed to change the corsar configuration, and we performed the second stenting. But we used the other stent, and here is the angiography result. Use patient good. He promised us to quit smoking. Why it's bad for our patients? Well, this is the patient 76. The stenting of right coronary artery was performed then TAVI, and he came with acute coronary syndrome without ST elevation. The problem with this situation, catheterization of coronary artery with TAVI, it's a particular thing. When we try to introduce catheter, we cannot catheterize the ostium. The catheter attaches. You cannot take it out. Actually, I don't know how it works. We introduced the stent not in the mesh of stent, but between the wall and aorta. Nobody can say actually what resolute was implanted. Here we saw that the residual stenosis is still here. NC balloons were used for post-dilation, and perfect angiography result we have here. Well, what do we need? We need to use CT coronarography and stenting because it is time contrast. We can preserve the kidneys. All the catheters should be used. We need to have new catheters for subclavian arteries and for patients with TAVI. And of course, we need to have more disposals actually, and use it more efficiently. Thank you. Well, you don't have lots of requirements. Question, short comment. Well, the older the patient is, the more problems we have. Well, this is a common situation, calcified lesion, just few issues. If the patient had aortocoronary stenting, lots of clinics perform CT. For 6 years already, we started doing it. Because ACS, pain syndrome, why do we do? But when we perform CT, we understand where cabbages are, and sometimes we see it really well. You do not even perform angiography. Understand, you just don't need to touch it. You don't need to even touch it. One more comment. When you tune it for 30 hours, when you tune it and tune it and tune it, in some cases, it's easier for operator to change access, for example, for femoral access. In some cases, I see that the operator thinks that it is kind of lack of honor shifting to femoral access. I think if it is difficult access, we have better to go to the femoral access. Sometimes it's the only way to do it. Any more questions, please? Question? No. Talking about access shift, access change, I'd better do femoral access, then I'll go to the left hand. It's easier, it's faster, and especially if you have suturing device. We don't do it quite often, actually, and we don't see big complications in these cases, so I don't think it's a problem. Well, let's proceed. Would you please also announce postponed PCI in complicated myocardial infarction? Hello, dear colleagues. Thanks for passing me the floor. I'm from Kurgan, we're a regional center, and we help the patients with acute cardiology pathology and acute issues with cerebral perfusion. We have patients with acute coronary infarction that are admitted later than 12 hours. We have 10 to 15% of these patients in Kurgan. The number of these patients is about 27%. Myocardial function treatment, it is still a question of the patient with stable picture, asymptomatic patients. The clinical guideline tells us that first 48 hours for PCI is not indicated, especially for the stable patient. These guidelines were based on a number of studies. This is the information from French register that demonstrates that selective PCI decreases the myocardial necrosis compared to conservative therapy. In stable patients with traumatic occlusion, in 3 hours, according to OAK study, there was no clinical benefit compared to conservative treatment. The Australian study demonstrated the patient who underwent late PCI had higher mortality rates than those undergoing a pharmacoinvasive strategy. In 2023, Korean study was published, and it says that early delayed PCI for elderly patients with STEMI who present more than 12 hours after symptom onset is not associated with better long-term clinical outcomes compared with the delayed PCI 44, 28 days even. And we see the results quite clearly here. One of the reasons that we have here is the symptom of no reflow as the result of distal thromboembolism that leads to bigger infarction volume, ischemic injury, reperfusion injury, individual susceptibility, and so on. So what do we do here? If the patients are admitted during the first days to have unstable hemodynamic, the guidelines say do the stenting. But I think many of colleagues had this situation when we performed the surgery in stable patient, and after stenting, we see no overflow, and the patient becomes unstable, though he used to be stable. Based on many studies and guidelines, the following tactics of patient treatment is: if the patient has non-occluding lesion of the artery, notwithstanding time, we perform PCI. If the patient is not stable and he had thrombotic occlusion, we perform PCI in certain amount. And if the patient is stable with a good feeling of distal bed, we do perform PCI, we consider postpone delayed stenting. One of the clinical cases is the patient with acute myocardial infarction. According to the cardiography, we see that the ejection fraction is preferred. At coronarography, we see significant lesion of descending artery, good feeling of the distal bed. On selective angiography of right coronary artery, we see thrombotic occlusion and the stenting is performed associated with the following recommendations. That was performed with the clinical of stenocardia. Echocardiography data was the same. On control angiography, we see that occlusion is preserved and antegrade right coronary approach was used. In 2023, we had 12 of these patients. The median time was 36 hours on average. These were mainly men, 60 years and older, mainly with right coronary artery lesion. A secondary catheterization was performed in 2 months. Antegrade approach was always used, and bilateral contrasting. Nearly always you use microcatheter. In 11 cases, recanalization was successful. In 1 case, we did not perform it at all because it was technically not straightforward occlusion. And we decided just not to perform any surgery. In stable patients with thrombotic occlusion, we have to consider PCI in delayed regimen. This is our suggestion. Thank you for your kind attention. Thank you for a wonderful presentation. Thank you for the presentation. So what's the principal difference between your concept and world concept, and why do you not like the usual concept? Why do you need to suggest this new? In the guideline, it is written in 48 hours PCI should be performed 2A. And we think that even if the patient is admitted 24 hours later, if he is in the stenting group, it is the experience that we have with our own situation. We used to perform, we got complication, now we decided to postpone, and no flow number was lower. The recommended practice is based on 1,000, and yours is based on the personal observation. Well, I'm from the city of Tver. You suggest a new concept. You contradict the Russian guidelines. Do you have a local protocol and approved it? How do you do it? I would just remind you that in Russian guidelines, the delay for the patient is not foreseen. We've discussed it at different cardiologist sessions. Why? Why so? It's interesting even to know how you got to this scheme and acting clinical guidelines in BRAVE 2 study that demonstrated the advantages. Only in 5 years' time, the strategy of early coronarography, and in 40% of the patients, the artery was open. But if the artery is closed, there are no studies, and the Americans still, for them, 48, they do not use, they still have this 24 hours. Our algorithm is about asymptomatic patient. Yes, that's the point. If it is asymptomatic patient, well, asymptomatic patient with ACS, well, I think that, yes, there are weak presenters, just the shortness of breath, and the patients who refuse their admission, and then they call emergency in 24 hours, but they had symptoms. So they are not asymptomatic. There are no signs of ischemia. That's probably the story here. Do you want to open artery? Yes, selectively. We are behind the schedule and we have to go forward. Thanks for your wonderful presentation. And Larissa Vladimira will demonstrate the clinical case of rupture of a coronary artery aneurysm. Distinguished colleagues, I would love to demonstrate to you a very interesting clinical case of rupture of a coronary artery aneurysm in patient with ACS. Well, aneurysm is dilation of coronary artery more than 1.5 times. For the first time, it was described in 18th century. It is not common finding in autopsy, most commonly in men in the right coronary artery. Systemic analysis of papers from the database demonstrates that up to 12% of cases demonstrate their coronary artery aneurysm. Mainly they are asymptomatic. In 0.2%, the rupture is the complication. The main reason of aneurysm forming is atherosclerosis. Inherited aneurysm is up to 30%. All the rest is inflammatory genesis, as systemic vasculitis, collagenoses after post-traumatic, and COVID-19 issues. The problem is that we see atrophy of connective tissues and vessel tissues, and the main mechanism of dysplasia is hyperactivity of matrix metalloproteinase as a result of the genetic disease. The gene mutation is seen. Cytotoxicity of COVID-19 leads to ultrastructure changes in cells and endothelial dysfunction. And after PCI, the polymer that stays in the vessel leads to hypersensitivity that leads to dysplasia. When the prongene substances are released, that can lead to inflammation. Aneurysm can be classified differently. Mr. Bugov suggested his own classification. At the moment, there is no generally accepted recommendations for the arterial aneurysm rupture. There are three variants of the treatment: conservative, implantation of stent, and open cardiosurgery intervention. The data is very contradictory. There is very few information that says what we can do to treat aneurysm treatment. A man 70 years with myocardial infarction of the side wall. He had COVID pneumonia in 2021. Then endophthalmite was treated again in the hospital, and he is admitted with STEMI. We see elevation on ECG. We don't see any structural changes, no hyperkinesis. He was getting the medical treatment. The pain syndrome was arrested. Troponin was negative. On coronarography, the patient has the sac aneurysm in anterior descending artery. The high risk of intraoperative complications and negative troponin led us to consultation with cardiosurgeon about open surgery. Next day, the patient has atrial fibrillation paroxysm. In 12 hours, paroxysm repeats, but we see the hypertonia trend appears. Next day, the patient is weak, he is anxious, but he does not complain any pain. ECG does not demonstrate any dynamics. In 1330, we have cardiopulmonary resuscitation due to the cardiac arrest. We see pericardium separation, and in 30 minutes, the resuscitation does not lead to any result. On autopsy, we see the rupture of the aneurysm. This case describes the possibility of clinical picture with development of coronary artery aneurysm rupture. Probably it was COVID-associated provocation of the process. Aneurysms are not described in current coronary artery disease guidelines, and we need to draw more attention to this issue. Unfortunately, in cases when we think it is an everyday situation, it is a tragedy, and in any unstable situation, we have to be very cautious and make decision timely. Thank you so much. Questions, please. Was there an attempt to perform draining of pericardium, and were there attempts for grafting, or was it agonine patients? There was an attempt of drainage, but it was without any success. As for grafting, we don't have them. And, well, that was what was decided. Well, there is a why didn't you fire from cannons? We didn't have bullets. Well, I think that stent would not save the situation. Well, I think that in one case we cannot make a conclusion. What do we know about aneurysm? We know the risks of visceral or spleen artery. We know it's a terrible story, especially in young patients. We know what to do with cerebral aneurysm, but there are also risks of rupture. What do we know about coronary aneurysm? They nearly never rupture. It's very rare story due to the vessel wall structure. We know the cases of ruptures as septic. There is a case when the stent is implanted. But, well, what's our attitude to the sterile situation? Nothing will happen. When I came to the Netherlands and asked, where do I take off the shoes? And I went in my street shoes to the catheter. But if there is septic aneurysm with a rupture, well, there are cases. In most cases, we do nothing. We just do nothing. And we know that aneurysm of coronary artery, it leads to ischemic picture. Either we have a distal embolism. It's an interesting case. You have to describe it for society. In the tactics, the patient with aneurysm for open aneurysm. Oh, it was a discussion that surgeons, I don't think that surgeons would help here. Well, it would be the allegation of artery stenting, infarction. Well, retrospectively, it should be stenting. But how do we find this patient? We will ultrasound. There is risk of rupture. the risk of rupture is not decided based upon ultrasound. The permeability is quite low, and it's a very interesting case because aneurysm we usually see with thrombocytes. Talking about rupture, if you don't have the graft, next time you see the same situation, what will you do? What will you do? Well, we're treating on conservative therapy, but the aneurysm is big here. We can see sometimes this kind with this big volume. I don't know. Well, we do perform stent graft, and I think it would just graft will not be enough for all the patients. So you'll just get thrombosis and infarction. I had a patient with a rupture of aneurysm. It was an elderly lady. She came with STEMI on the lower wall and thrombosis. Guideline, expert stent. Then thrombosis, locators 2B3A. It was probably the most nightmare thing. It's kind of volcano, and it's just blood that goes out like lava from volcano. I remembered that probably we can set on the expanded stent. I put 4 stents, nothing. I called sandwich stent. I tried to perform stent grafting with balloon, but I didn't have enough of fine motorists. The patient was sent to the surgery. They sutured the ostium of right coronary artery. There was infarction of right ventricular, and that was it. Well, if we talk about cabbage, it does not appear always. It does not appear. It can be an alternative. Well, probably it's ligation. We have big massive of artery, and bypass will not help here. Bypass will not save us. Yes, we proceed. Larissa, we're inviting you one more time.
Right. Our next speaker is online, right? Yeah, please continue, and then there will be an online presentation. Distinguished colleagues, let me share our experience, what we do in those situations when we have to treat cardiogenic shock, but we don't have ECMO. Cardiogenic shock can lead to 10% of complications. In case of MI, the mortality can be up to 50%. In most cases, we deal with shock stage C according to Skype classification. Here are the clinical signs of shock. They are shown here. I'm not going to go into detail. The first diagnostic task is monitoring of hemodynamics, including the invasive one, assessing the lactate level and gases in the arterial blood. Well, echo CT with the annual diuresis and monitoring of the patients. Well, the major technical tasks in treatment of shock is the stabilization of hemodynamics due to the respiratory vasopressor support, also mechanical support of circulation or circulatory, mechanical circular support, also the restoration of the myocardial contractility, revascularization of the infarct related artery, and complete the revascularization in case of left ventricular insufficiency or electrical instability. The stabilization of hemodynamics can be done by using the existing inotropic vasopressors. Well, all these drugs have their advantages and disadvantages. We prefer to dobutamine or a combination of dobutamine with noradrenaline in minimal possible dosages in order not to deteriorate the tissue perfusion by excessive vasoconstriction. Non-randomized data allow us to use levosimendan in case of cardiogenic shock. Levosimendan showed its efficacy in patients who were on better adrenal blockers. And thrombocytic therapy is of great importance, but opioid-induced, esophagus motorics is leading to the poor effect of P2Y12. Here we need to talk about 2B3A blockers. Here you can see the results of two major analyses showing the reduction of the risk of death during 12 months when we use 2B3A blockers when they were added to standard therapy. Analyzing our data for last year, we came to the conclusion that despite the fact that the number of patients with shock remained the same, we had a larger number of people who got to B3A blockers due to the intraoperative indications of thrombotic complications. And here, since our algorithm of care did not change in patients for shock, we didn't have new devices for mechanical circulatory support. We can say that this group of drugs could make a positive contribution. Here is the clinical case. A man 67 years old was admitted with the acute MI, with the ST elevation, with the low ejection fraction. Coronography was done, occlusion of the anterior descending branch, again, to B3A blockers were admitted. The blood flow was restored. The patient was brought to ICU on day 2. The patient had ventricular tachycardia. After the cardioversion, the rhythm was restored. Again, there used the AFib, and then we started seeing problems. Well, you can see ventricular insufficiency. We started the non-invasion ventilation of the lungs with vasopressors. The patient still had bradycardia, also ventricular paroxysms. Again, the pulse therapy doesn't allow us to increase the dose of vasopressors. Refractory shock, the heart index 1.6. Well, as for the heart index or cardiac index, well, we can use a simple formula for calculation here. It is shown here. We should increase it, and in fact, we should increase, the cardiac output. Well, again, increasing the output will lead to the reduction of coronary perfusion pressure, also the stroke volume, and we must think how to increase the stroke volume in patients. Intuitively, assistance should come from outside. Mechanical circulatory support is the way out of this situation, and hypothetically it should help us. However, today, there are contradictory data of different studies comparing mechanical circulatory support and again, IABP can reduce perfusion, but increase pressure on myocardium. Clinical guidelines cannot allow us to use AABP in routine practice because it didn't show efficacy compared to medical therapy. Recently, there are contradictory data. IBR compared to ECMO has a lesser risk of complications and can actually improve the survivability of patients. Our patient has all the indications for mechanical circulatory support, but we cannot not do VA ECMO here, so we use those things that we have. The patient had the hemodynamically important bradycardia, electric instability, so we must think about how to increase his heart rate. Well, we can use, again, this method, and we can use clinical guidelines on treatment of tachycardias. And as a result of that, during the first day, paroxysms were coped with, and again on day 2, non-invasive ventilation was stopped. Shock was fully stopped. Again, on day 10, the patient was transferred from ICU with ejection fraction of 36, heart index 3.6. A combination of VAX and IABC in patients with cardiogenic shock, can lead to the situation where the combination of IABC plus VAX can be used in case ECMO is not at hand. It can restore the cardiac index. The results of new trials can lead to a better understanding of using this method and to reduce the number of patients with cardiogenic shock. Thank you. Colleagues, any questions from the audience? Why didn't you do the revision? The stent revision, the repeat chronography in patients with ventricular tachycardia. Well, because the ST segment was in the same position, the patient had no pain complaints, but it was an urgent situation, ventricular tachycardia, well, practically clinical death. But not all patients with VT can be sent for this procedure. Well, in most cases we do it, but if it was an instant thrombosis, our method wouldn't have helped us, and there were changes on echo CT. Well, when we see clear indications, then the patient is sent to the cath lab. Electric instability as a reperfusion syndrome is still being used in patients who had myocardial infarction. I would like to support you because one of the criteria of suspicion for ACS of high risk is also the left ventricular insufficiency. And also, this is one of the conditions to have suspicion of problems with coronary arteries. That's in non-STEMI patients, so coronography should be done in this case. May I ask you again? Well, actually, 2 comments. Well, this topic was very interesting, and it was a wonderful presentation, wonderful trials, important trials. But we, the Moscow clinic, have been dealing with shock for too many times. This is one of our main specialties. Well, just a couple of comments. Well, 50% of deaths, that's quite good in such severe patients. But there is a hypovolumic shock, well, refractory shock, mechanic shock, and the real mortality rate can be high here, especially the true cardiogenic shock. Here, the mortality rate is 90%, 90, and you had 50%, which is nice. And of course, you can use only mechanical circulatory support here. So mechanical circulatory support should not be discarded in this case. And well, you can see a big difference between mortality rates here, and those patients who were switched to ECMO is the means of last resort. Also, the patient you've shown here, after the rhythm was restored, and because of bradycardia, well, I think the shock was arrhythmogenic here. It was mixed shock, arrhythmogenic first and foremost, and so I noticed that you had the ventricular rhythm violated, then the cardioversion was, the patient was rhythm competent, and catecholamine vasopressors dose was administered. Yes, everything happened very quickly. So brady flutter before the rhythm of catecholamine and vasopressor. When you think it's a true cardiogenic shock, first you should do, according to the guidelines, is to put the ICD, right? Temporary ICD. The doses were not quite large. Yeah, first ICD and then small doses. All right, as for cardiogenic shock, well, cardiogenic shock has many phenotypes. That can be a different story. Cardiogenic shock does not require catecholamine to stabilize the hemodynamics. If it's a relative hypovolemia, 200 millimeters of saline solution stabilizes hypodynamic. If it's Betz-Yarish reflection, atropine solves the problem. If it's arrhythmogenic shock, which is related to tachyarrhythmia, cardioversion solves the problem. No need of tachycholamines or vasopressors or counter pulsation balloon or ECMO or impeller, nothing like that. That's important. First, diagnose the reason for shock and then start the treatment. When we see that it's true cardiogenic shock, then we can think about vasopressors, catecholamines, and the mechanical circulatory support. You don't have ECMO, right? But do you have the opportunity to look look at veg pressure. Well, because it depends on how we're going to work with the patient. We do not do it all too often. That's very important if you don't have ECMO. If you have a patient after ACS with low pressure, like especially in the ICU, what should you do in this case? Using more saline solution or noradrenaline dosage or dobutamine dose or dopamine dose should be increased. So if we see pulmonary veg pressure, then we can use, for example, the saline solution. Well, trials in the 1990s showed that routine catecholamine administration, that was the idea way back in the 1990s, increases mortality. One more brief question and we'll move on. All right, the initial sinus rhythm was right. No, that was atrial fibrillation initially. All right, initial atrial fibrillation. What would be the tactic if you had the initial sinus rhythm? Would you try to restore it? For example, there was the fib, or at the stage of Brady, you would. Well, I think we would probably do the same thing. All right. Well, again, this can lead to the reduction of the stroke volume due to asynchronism. The stroke volume can be decreased. Do you change the position of electrodes? Yes, there is a person who can do it, and we change the settings of the ICD. Well, and what about the position of electrodes or the position of leads? Yes, we can change the position of leads. Thank you very much. Colleagues, let's move on. We have a presentation from Naberezhny Chelny. All right, we're pressed for time. Let's accelerate our process, and maybe questions will be asked during the break in private. Thank you very much. Well, I should share my screen, I guess. Yes, hello. Hello, we're all ears, please. Dr. Zagidulin, Naberezhny Chelny. All right, dear colleagues, allow me to make a presentation experience in the treatment of cardiogenic shock using mechanical circulatory support. The arsenal we have at our clinic, we have counterpulsation balloons, ECMO, machines, also lookers, 2 machines lookers, and also the apparatus for short-term support such as ICD. Well, I'm not going to go into details, but let me just say a few words about ECMO. Well, ECMO is very efficient. We use the cannula to draw blood, then we just bring the blood back to the arterial cannula. The blood goes out of the left ventricle, then it is oxygenated. And however, I'd like in my presentation to describe the tasks that the cath lab specialist has besides revascularization when ECMO is used. First and foremost, visualization of the access for placing cannulas, angiography of lower extremities veins, also function of different peripheral vessels using IVUS, integrate assessment of the blood flow in low extremities after the cannula is placed, also placing the cannulas into different chambers of the heart using echo CT. Here is the angiography. The patient is on the operating table. We must assess the diameter of iliac vessels and their patency. Phlebography is done, but not all too often. Again, you can see the function of the peripheral vessel. We place the guide, and using IVUS, we can puncture and restore the integrate introducer and cannula, place it into the femoral artery. And again, this is done routinely under IVUS control because we must get into the femoral artery to achieve a perfusion of lower extremities. And again, Well, the puncture must be as high as possible, closer to the place where arterial cannula was placed. This is necessary to reduce this dead zone area, to reduce the possible thrombus volume formation, so that we could have, during the cannulation, no case of distal embolization. Here is one of the clinical examples, which is very interesting. Angiography shows that on the right of the iliac artery, there are critical zones, calcinated stenosis on the left of the iliac artery. Sorry, the sound is gone. Sorry, let's just try to reconnect. Or maybe we'll start the next presentation. All right, the next presenter is Furkat Gafurov, Yegorevsk, the Moscow region. Please. Well, good morning, dear colleagues. Today we're discussing primary ICD or stent placement in patients with acute MI. Well, we had the patient hospitalized, 62 years old. Well, again, you can see the fit patient. He had some complaints such weakness, headache, and loss of consciousness. As for the family history, infarction, diabetes mellitus, nothing like that. Well, but had hypertension, but the patient was not monitored by doctors. Again, hepatitis C, he is a heavy smoker and drank a lot of alcohol. As for the debut of the disease on January 24th, the patient felt bad. He lost consciousness twice, but did not ask for help. On January 25, he felt bad, but he continued to celebrate. He drank alcohol. In the evening, on the 26th, he felt bad. He called the ambulance, and, well, in the morning, he was hospitalized to the rural hospital, poor heart rhythm, and on January 26th, he was hospitalized to our clinic with the diagnosis, poor rhythm. And again, well, let's look at his family history. You can see ECGs. I asked from my colleagues who first treated him. Well, he had an ECG done when he was hospitalized, the nodular rhythm, bradycardia, and resuscitation specialists, and, well, injected dopamine. Well, the AF was launched, but he had a systole. The patient felt bad again, and on the lower wall of the left ventricle, you can see some changes of the ischemic nature. However, well, we had no doubts about his infarction, and again, the patient felt bad. The calderon was injected 2.5 hours later. Well, parasystole was detected. The next morning, well, at 9:30, well, the cardiologist connected with me. Well, there was a need to install the ICD. Well, the patient was hospitalized at our clinic. You can see the ECG, complete block. Well, and also changes of the lower wall. Well, again, Q wave changed. Well, perfusion. The patient had no complaints. He was stable. ECG shows atrioventricular block type 3, AV block type 3, myocardial infarction along the lower wall, and signs of reperfusion. Inversion of T wave according to ECG. Well, the ejection fraction is preserved. Well, pressure 115/70, saturation is more than 90%. Well, cardiac enzymes are elevated. Well, since the patient has the AV block, well, again, if we had no MI, we do coronography. Again, we usually place a pacemaker, and here we did the coronography. Please launch the video. Help me to launch the video. And you can see here temporary pacemaker was installed. The coronography was done according to the protocol. You can see the blood flow is not bad on the left. Well, you can see there is isolated stenosis of the block, about 80%, but the patient had problems not because of this. The right coronary artery, again, launch the video. You can see the acute occlusion of the right coronary artery. And we want to do the stenting, but there was the question about the timelines. We didn't have the clear understanding here whether to do the stenting or not. It was a difficult situation, and it was a danger here. And again, you can see the danger is on both sides. What to do here in this situation? So we would like to ask you a question. How would you vote in this case? Let's finish the presentation and then we'll discuss it. All right, 3 options. What to do? Well, placing a stent in the right coronary artery with the temporary ICD, also monitoring is the second option. We monitor the patient. If the AV block is not resolved, then the patient will be discharged with a stent. The second option, well, temporary ICD and then 3-day monitoring, and also number 3 is permanent pacemaker without stenting. So again, we looked at the ESC guidelines of 2023. If the infarction lasts more than 48 hours, well, routine PCI is not recommended. Well, but the evidence level is very low. As for pacemaker, well, the evidence is high. Well, pacemaker should be installed due to MI. Well, again, the patients are severe, the patient is old. Well, the patient cannot be just in 10 days in ICU with the lead. Well, of course, it's not so easy. So it was very difficult to determine what should be the further tactic. At our Russian Society of Cardiologists, well, there are data that patients with MI, well, in this case, during the first 5 or 6 days, we should place the temporary ICD. Well, and well, that's what we did basically. Well, here is the patient with the stable condition. Well, he was brought to the recovery room. Again, you can see the electrocardiogram. However, the patient wants to be discharged home. Well, again, we removed the lead asystole. Well, we tried to resuscitate the patient. We put the lead once again, but no success. So the patient with myocardial infarction and AV block needs an individual approach. There should be specific stages of treatment. Well, PCI or implantation of the pacemaker. Also, the patient must have the devices installed for permanent electrocardiogram stimulation. Well, temporary pacemaker, according to the guidelines, may not be a guarantee of safety for our patients. Thank you very much for your attention. Thank you. I think you should have opened the right coronary artery and to keep the patient in the ICU so that he would not just pull the pacemaker. Unfortunately, death was due to the loss of poor electrocardiogram stimulation. You should probably call a psychiatrist in this case. And the question with stenting of the right coronary artery is quite arguable according to the guidelines. Indeed, we are absolutely right. Recanalization of this artery in case of there is no repeat ischemia, well, like like signs of angina over the last 48 years. Well, in this case, it's not indicated, but you can use additional methods to assess whether myocardium is viable. In this case, if there is a total scar, well, maybe you should not open the right coronary artery if myocardium is viable and a good ejection fraction, left ventricle ejection fraction, and just as a small left-sided lesion, then we could consider the recanalization of the right coronary artery. Well, permanent pacemaker probably should not be installed right now, but maybe later. Well, it was an accident. Yes, the patient died. All right, so let's move on. We have the last presentation. Hoang Truong Huy, Ho Chi Minh, please. Type 2 myocardial infarction. Where we're now. Can you hear us? Dr. Huy. Good morning, distinguished colleagues. It's a great honor for me to speak at this Congress and to speak on this subject. I used to study in Russia, and with great interest I'm following what is happening in this case. I'll be talking about the type 2 myocardial infarction, where we are now. And I think I will be speaking in Russian.
Yes, we are ready for English. Go ahead, please.
According to the for universal definition of myocardial infarction, as you know, the criteria for myocardial infarction is with the present of the acute myocardial injury detected with abnormal cardiac biomarker in the setting of evidence of acute myocardial ischemia. So for the four universal definition of myocardial infarction, we classify with several types. As you know about the type 1 MI, it results of a blood rupture or erosion with the occlusive thrombosis, with or without occlusive. But for type 2 MI, it may be it results from supply oxygen supply and demand imbalance. So in this context, the myocardial infarction may be results on the atherosclerosis, or maybe without atherosclerosis, or maybe another mechanism like vasospasm, or maybe myocardial dysfunction, or maybe non-atherosclerotic coronary dissection. So for angio or interventional cardiology is a phenomenon very common when the cath lab. For this universal definition, they follow the criteria, but that is detection of right for cardiac troponin with evident imbalance between myocardial oxygen supply and demand. But pay attention that this is not related to coronary thrombosis. So another criteria is very typical for the type 1 myocardial infarction. So it's very difficult in clinical practice to differentiate between type 1 and type 2 myocardial infarction. Let me explain why. Today, in this slide, we have a context of myocardial infarction. It is secondary to another unisys, and for mechanism with you can see here for several mechanisms. For example, on the basis of oxygen supply and demand imbalance, the patient maybe have fixed atherosclerosis, or maybe the result from coronary embolism, or maybe coronary artery dissection on the basis of sustained tachycardia or severe hypertension. That this condition trigger or provoking myocardial oxygen supply and demand decline. imbalance. So in clinical practice, we have another definition of myocardial injury. It is elevated cardiac troponin value, upper 99 percentile, upper reference limit. But without, if the patient with the evidence of myocardial ischemia, so we call it myocardial infarction, but without it is myocardial injury. So it's several mechanisms related with that the cause myocardial ischemia. Maybe is it due to oxygen supply and demand. For some condition with reducing myocardial perfusion, for example, myocardial artery sparse, or another condition with increasing myocardial oxygen demand, like sustained tachycardia, or maybe severe hypertension. Another cardiac condition like heart failure for myocardial injury, myocarditis, cardiomyopathy, or Takotsubo syndrome. So it is very commonly caused the increasing the cardiac engine. So it is there also for universal definition. So if we approach the patient with elevating cardiac troponin, we observe the dynamic of firstly, right, the troponin rise or fall with or without it. Without it, we call acute myocardial injury. The cutoff for that condition by universal definition is 20%. But with acute myocardial ischemia, it's called myocardial infarction. So it is so on the basis of coronary angiogram, we have maybe the patient with atherosclerosis plus thrombosis, or maybe without thrombosis. So it's called type 2 MI. And for another condition like myocarditis or on the basis of chronic myocardial injury, so example for that condition. So we have a very similar by the type 2 MI and acute myocardial injury and chronic myocardial injury, because so patient in the emergency department, the symptom very similar. So distinguish between myocardial infarction patient have or not, or maybe the patient only acute myocardial injury. It's very difficult. So there are some difficulty in distinguishing the various entities. First, the interpreting ischemic symptom. Another interpreting my ischemic ECG changes. For example, tail waist inversion. And as coronary artery disease very common in myocardial injury as well as in type 2 MI. And another problem is that how severe must trigger factor to be caused ischemic necrosis in type 2 MI. And also it depends on the degree of underlying CAD or whether several triggering factor coexist. So it's more and more questionable about troponin elevation ways reflect irreversible myocardial damage. In this study, it's very recently published in 2022, include 8,064 consecutive patients with screening to identify type 2 MI. The results of this study show that in 100% provisional diagnosed with type 2 MI, 93 patients with adjudicated diagnosis with type 2 MI after that. So 7% maybe with another type of myocardial infarction. And on angiogram, we have almost 1/3 of patients maybe have normal or non-obstructive or obstructive coronary artery disease. So in this study, 42 patients had imaging evidence of myocardial infarction, and only 10% had normal study imaging. So from that etiology, we have another approaching for management. So in real practice, myocardial injury is with is in the framework of microinjury and myocardial infarction that we classify type 1, type 2, and 3, and also another condition. So the caution and thorough clinical examination very important to differentiate this condition. So how common myocardial injury in clinical practice? It depends on the various studies. So reported from 30% to 60% of myocardial injury. And for type 2 myocardial infarction also, the prevalence it varies depending on the study. The main causes is right now we don't have a specific or criteria that adopted by the current guidelines. So every study use, for example, some specific criteria to diagnose with type 2 MI. For some study, they use broaden for defining, for example, hypertension, for example, for the cutoff value 160, or maybe some another study 180. And as you see, a baseline characteristic of patient with myocardial injury and type 2 myocardial infarction is very similar from the age and also demographic characteristic, and also cardiovascular comorbidities. But for the prognosis, as you said, right, type 1 MI, they have a very good prognosis compared with type 1, type 2 MI and myocardial injury, and another also chronic myocardial injury. For it is the result from meta-analysis for 1 year mortality is favorable for type 1 MI compared to type 2 MI. And also prognosis for in-hospital between type 2 MI and myocardial injury is very similar for in-hospital. For 1 year follow-up, its trend is very generally observed that the type 1 MI have a good prognosis for 1 year compared to type 2 and another myocardial injury. And it is also result from the survival for 2 year follow-up that favor of type 1 MI, for which 60% survival after 2 years. And another also for the another study show that there is no difference between myocardial injury and myocardial infarction for long-term follow-up. For long-term, for example, for the research with the median 4.5 years, almost type 2 MI and myocardial injury, they have a worse adverse outcome compared to type 1 MI. What's the causes the patient they are dying? For example, when is a cardiovascular non-cardiovascular causes during long-term follow-up. So type 2 MI and myocardial injury, they are more likely to be done by the non-cardiovascular causes compared with the type 1 MI. They have also for another cardiovascular, so very similar for cardiovascular causes of the mortality. And this is so the rate of myocardial infarction, heart failure, and cardiovascular mortality between myocardial injury and type 2 myocardial infarction is very similar. But the problem is that when the indication between type 2 and myocardial infarction, it depends on the observer. For example, when for first reviewer for type 2 MI is only 158 patients have diagnosed with type 2 MI, but for second reviewer it's only another number. It depends on the criteria. So the agreement between observer is not it's not high, which kappa value is 0.55. So there is some causes without atherosclerosis. For example, type 2 MI is reserved for coronary intrahematoma or maybe coronary spot or musculovascular dysfunction. So it is a prevalent of coronary artery disease among study. So it's from 30% to 70, maybe 75%, depend on the study and depend on how angiography using in this population. So recently, in 2017, we have a scale that includes three parameters: that female sex, radiating chest pain, and baseline troponin, that can differentiate with AUC only 0.71. So for that condition, we have with the patient, we only predicting the presence of type 2 MI without with or without angiography. I mean, before angiography. Patient with a myocardial infarction for type 1 MI is urgent angiography. And for type 2 MI, right now, the current guideline treatment the underlying causes. And this is a summary from the clinical approach for patient with ischemic presentation. So we have a suspected STEMI for immediate emergent coronary angiography, or maybe for according to the recently ESC 2023 for acute coronary syndrome. So depending on the results for coronary angiography with the help of intravascular imaging, for example, IVUS or OCT, we can identify the cause of myocardial infarction, and therefore we also identify the patient with high risk of adverse outcome according to type of myocardial infarction. Thank you for your attention.
Chong, thank you so much for your excellent presentation. We congratulate you, and I hope we'll see you in Ho Chi Minh soon. Thank you so much.
Что, мы закрываем сессию?
Thank you. Thank you one more time. Thank you. We're wrapping up this session. The number of people in the audience says that the session is over. and embolization to stop bleeding in this type of patients. If we dig deeper in this history, our compatriots were the first openers in this disease. Professor Grexov, for the first time in history, used embolization of upper artery and internal iliac arteries in rectum cancer in bleeding tumor. Our colleagues who are dealing with embolization in hemorrhages demonstrate their results, and Professor Zakharchenko, Professor Shansky put their input into this problem. The anatomy of rectum allows to perform endovascular intervention, chemoembolization. It is associated with the fact that the blood supply is going through 3 arteries and it is full with collaterals. And having studied anatomy, we confirm that in most of patients, the blood supply in rectum is performed by the rectal artery that in 80% of cases is leading, but in most cases, the blood is supplied from rectal artery. Our colleagues say that in embolization, it is performed in 20 to 30% cases. In our cases, the first type of blood supply is in 86% of the patients, when the blood supply is associated with superior rectal artery. But there are such particularities when patients have 2 superior rectal arteries. Sometimes they have overflow, sigmoid part that prevents embolization. When we have the embolization, in this case, we see overflow in sigmoid artery and the occlusion develops. That can lead to the ischemia and prevent operative intervention. We suggest combined method when we use preoperative oil chemoembolization of superior rectal arteries. The main purpose is total devitalization of the tumor, prevention of local relapse, and hematogenic metastasis. The technique is similar to chemoembolization in liver tumors and ischemia. Embolization at the very beginning was performed with the mixture of lipiodol with mechanical occlusion of the artery trunk with chemostatic sponge and spirals. Further on, we used the microspheres. The selective catheterization of a low mesenteric artery with a super-selective catheterization of suprarectal artery in most cases are hypervascular. They accumulate oil embolized. There were particular cases with the introduction of the drug. Sometimes we added SEMA infusion into the artery, and the trunk of the artery would be closed mechanically. On control, we see overflow into medial artery. Embolization would be performed alone with microcatheters that help us to achieve these vessels. Our experience, about 100 patients to whom we performed chemoembolization. After surgery, we performed CT, where we saw the accumulation of the chemo, and in 2 to 3 days, a total thrombosis could have been seen, and the upper rectal vein. In morphological study, we see obvious accumulation of lipidol, and we evaluated the concentration of the drugs in the tumor, which would be about 50-60 times higher compared to intravenous injection of the drug. Pathomorphosis was detected, so we saw tumor devitalization. During the procedure, we faced also a few difficulties. If during the embolization the occlusion happened due to overflows to sigmoid artery, it would lead to complications. Especially, the risk was high if the superior rectal artery with mesenteric artery together with sigmoid and left colon artery and the reference of embolizates can go to the left circumflex artery. But for that, we saw the fistula with significant blood leakages. These situations are really lead to the risk of thromboembolism. In acute bleeding, if histologically the cancer is proven, we would perform chemoembolization. You can see here extravasation of the blood flow, but it's not quite common case. The blood flow would be restored in these patients, and the patient are prepared for the radical intervention, compensate anemia without the relapse. The difficulties here, it is when we have more than one branch of lower mesenteric artery, and we need to perform quite thorough embolization of all of them. Atherosclerosis, when we need to shift to the radial axis, if there are fistula, embolization of fistula with sponge or microparticles, and as a result, in most of patients, they have post-embolic syndrome and tenesma, which our colleagues who deal with embolization in hemorrhages, they do not talk about. There are dysuric issues. We compared oral chemoembolization and embolization with saturated microspheres. The result was more or less equal, and we need to compare long-term results to see what is most efficient. Visually, in the embolization of microsphere, it doesn't look as bright. Also, we saw one article when we saw the gangrene of the perineum that happened due to the microsphere embolization, and so we have to be very cautious about embolization with microspheres. It was not purposeful embolization, and the patient who had hypotonia had the rectum necrosis and perineum necrosis. Few more illustrations from the literature. It can be a necrosis of the rectal wall. It happens. My colleagues who deal with hemorrhages have lots of procedures, but they can be avoiding these issues. Especially we should be careful with their thrombophilia or autoimmune diseases, evaluate anatomic particularities, and probably, if we talk about small particles, we should be very careful. We should not be captured by the virus. And for that, we need to use all the possibilities and be very cautious.
All patients who had embolization as planned, there were different surgical treatments, including plastis requiring mobilization of the left parts of the circumflex. We had some problems related to poor anastomosis, as you can see it here, and again, total embolization may be risky for surgical treatment in the future. Well, no significant changes in the frequency rate of sphincter resection and R0 resections and embolization of microspheres. So right now, these are quite equal methods. Follow-up period is rather long. Well, local relapses 4%, well, remote metastasis in 10% of patients, and high 10-year survival rate. The procedure is rather safe. We did not see any severe complication. We can achieve a high level of pathomorphosis, a high degree of radicality of the procedure. What are the prospects? Our colleagues have already proven that patients with non-resectable rectal cancer, well, chemoembolization leads to tumor reduction. It becomes irresectable in 33%. Also, our colleagues have said that you can use the prolonged chemo radiation therapy. 1/3 of patients have total pathomorphosis developed, and the tumor disappears. This is a high level of efficacy of the treatment. You can combine chemoembolization before radiation therapy or after radiation therapy. The efficacy remains very high. Right now, there hasn't been a randomized trial confirming this data on a large number of patients and could compare the efficacy of such methods. Thank you very much. Thank you for this interesting presentation, colleagues. Any questions? Thank you. Just one question. Well, you had a category of patients who had rectal cancer in operable patients, usually after chemo radiation therapy, or slides showing them. So the anatomy is very distorted here, and especially the mesenteric artery is involved. And again, you look at the rectal branches. So the picture is very sad. So your experience of work with this category of patients, well, how do you manage such patients? What are your results in general? It would be nice if you could say about that in a nutshell. We encounter such patients. It's a big problem. Sometimes it's impossible to help such patients at all. Thank you for this question. In case of local cancer, when we use a chemoembolization, we can see the tumor reduction. The tumor shrinks, and in some cases, we can do the radical procedure later. And we don't have a lot of data, unfortunately, so it's very difficult to make any conclusions right now. Thank you very much. Sergey, just a couple of words. We've been dealing with this issue as well. We're from Nizhny Novgorod, and as for the alternative is in neoadjuvant therapy, but sometimes it's also impossible because of bleeding. In this case, we can operate on a patient with this patient. So it's not an alternative to neoadjuvant therapy. Well, yes, combined treatment should be used in general program of treatment using the standards. If the patient has radiation therapy indicated, it should be done. Of course. Let's move on to the next presentation. Andrei Sirogin, well, HIPAA and HEPA methods in tumor cancers. There are not so many people in the hall, but nevertheless, over the last few years of work, the picture hasn't changed, and our oncocardiology hasn't been developing rapidly. I am from Nizhny Novgorod, the Transvolga Medical Center. I'm head of the department. I've been working in this area for 37 years. The last 16 years, I've been dealing with oncocardiology issues, and I would like just to tell us what we are doing, because when you come somewhere, you have options how to do this procedure. Well, and of course, I should say it's a federal center, and we do not have a mandatory medical insurance. We don't have infusion. So that is why I'm not going to talk about that. Maybe my colleagues will talk about this later. I'd like to say what we are doing and what we consider some kind of achievements, especially over the last 16 years. So this problem has become very relevant. 3% of hepatic primary tumors, well, 30%, well, you can see metastatic liver diseases, and out of these patients, only 15% of patients can be sent to radical surgery, especially when we have solitary lesions. 80% of patients need palliative anti-tumor therapy. And of course, my opinion is we should take active part in treatment of such patients. That is why indications are quite clear: inoperable patients with primary or metastatic hepatic lesion. Our idea is to prolong patients' life and to improve their quality of life. Some patients can become operable and can be sent for combined treatment, well, embolization of the portal vein or using duplex therapy together with the chemoembolization of the lesion. Contraindications are shown here. When we're talking about the poor renal function, we should pay attention to liver enzymes. As for the limit of NOMIT is bilirubin more than 40, leukocytes less than 3, platelets less than 60, hemoglobin less than 80, and so these are contraindications. Well, I should say that our department is quite peculiar. We have beds, and well, so our X-ray surgeons, well, are also oncologists. So they're also operators. They are attending physicians. On the one hand, this makes our situation easier. We do not lose the patient after the first procedure. We monitor the patient. Well, the patient comes to us after all these procedures, and the doctors, well, follow up with the patients. Everything is quite well ordered. And creatine, also the thrombosis of the trunk of the portal vein, is also of the contraindication. Anatomical peculiarities of blood flow to the liver. Recently, Balakhnin wrote a very good dissertation. Out of 4 options of normal anatomy of the hepatic artery, there are 100 subvariants, and in my case, there was a subvariant when the trunk and the hepatic artery were going from the same place. Dissemination of the tumor process. Well, here there are some nuances, but if the patient has a dissemination into the bone, into the lungs, well, we should control the volume of liver damage. Our goal is not to cause a hepatic insufficiency if there is a massive tumor lesions, arteriovenous grafts. Well, here we are talking about a lot of different instruments that help us go through all these difficulties and to do the procedure without any problem. Well, you can see the advantages. The procedure is minimally invasive, local anesthesia is used, the selective catheterization, less systemic toxicity, and of course, we change the time of hospitalization. Usually hospital stay is 3 to 4 days. That's our pluses, minuses, difficulties of super-selective catheterization, congenital or acquired anatomical peculiarities, and the mobilization syndrome. Well, chemoembolization method can be divided into 4 stages. First, a geographic study, which is a must, and if you know the patient and he visited us several times, his anatomy changes. Usually the anatomy deteriorates in terms of the blood flow in the hepatic artery. Diagnostics is a must, also super selective catheterization. Also, you must prepare the right suspension and also thorough hemostasis. Such complications do occur. Hopefully, they're not fatal. As for myself, well, Cobra is the main catheter that I use, and it's the Cook company product. I have nothing to do with the Cook company. There is no conflict of interest. These are just visceral catheters, very convenient for use. So I recommend you start with the Cook catheter in this case. So what do we see here? First, we do the diagnostics and we understand clearly what kind of tumor we have, even if we do not have histology results. So here you can see the semi-rectal metastasis along the periphery of the blood flow. There is necrosis in the middle, and there is the hypervascular tumor near hepatocellular carcinoma with a large number of vessels involved. That's important for us. Once again, let me make a caveat here. There was a rectal cancer metastasis, and you can see large part of the liver involved. We're not miracle makers, but if we treat this patient, if we realize that this tumor is sensitive to chemotherapy, we can inject the drug into any place to achieve a good therapeutic effect. 2 months later, before the second course, we can see this particular picture. It's quite indicative. Primary liver tumors, usually well, there might be cirrhosis, though the liver function is deteriorating. Well, any drug can cause liver insufficiency, so we must be very careful here. We do the selective embolization, Cobra as the guide catheter, then microcatheter, the 8th segment of the liver. Again, the chemical drug is introduced. We try to preserve the blood flow of this right lobe of the hepatic segment. We do it very successfully, and we get a very good effect. There is also a group of patients, and unfortunately we don't have oncologists, but we have neuroendocrine cancers, especially young people. Like this patient is 42 years old, metastasis of the neuroendocrine carcinoma, histologically confirmed without the primary source detected. The patient is disseminated. The patient is sent to treatment to the cancer center. No surgery is indicated here. We try to help such patients. There are quite a lot of them. Say a patient comes for the first round of therapy in the right lobe. There are huge metastases into the liver. The patient comes 2 months later for the second round of treatment. A positive response to treatment. That's the left lobe. The same situation in the 4th segment, a huge lesion. The entire left lobe is covered with tumor. But the response was quite good. We had 3 courses of therapy with the interval of 2 months. Well, then the second PET was done. We found the primary source, the tumor in the mesentery. Well, we removed the tumor. The patient has been alive for 10 years already. Well, neuroendocrine carcinomas and metastasis into the liver, we can help patients like this regardless of the site. So this tumor can be treated very well using our methods. Here are the efficacy criteria of chemoembolization. Patient comes to us and says, "Doctor, I feel much better. I eat normally. I have an interest in life." And objective criteria, well, such as biochemical criteria, well, oncomarkers that have different degrees of reliability, and the results of the radiation treatment. We can do IVIS, or we can do CT or MRI. Well, the criteria are quite clear here: stabilization, complete response, or progression. Well, radiologists assess this in percentage. And, well, you can see, as for chemoembolization of the hepatic artery, more than 3,000 procedures. You can see the breakdown by men and women, two almost equal groups, and the first three courses are done during the first 2 months. If we have stabilization of the positive response, then we continue we prolong the interval between courses, and we had patients who had the same neuroendocrine metastasis who come to us once in half a year, which is not so bad for patients. We control the lesions and we can control the blood flow. Usually patients with colorectal metastasis, primary liver cancer, breast cancer. By the way, patients with breast cancer have a very good response to our treatment. If there are even liver metastases, if we're talking about post-embolization syndrome, these are not complications. That's the consequence of the procedure we have done. So the task of our chemoembolization is to introduce the drug and to cause tumor ischemia. Of course, the pain may be present. The patient suffers during the first day, so use specific analgesics. Do not save money on this. The patient must have nausea, vomiting. Well, usually a drug is admitted on demand. In this case, as we write it down, hepatoprotectors can be administered here in order to wash hepatocytes from the drug to avoid liver insufficiency. When we're talking about chemoembolization, we must remember that complications can occur after our embolization, but they are not fatal. Cholecystitis, pancreatitis are usually due to the use of the chemical drug. And of course, be very careful here. One patient unfortunately died of liver insufficiency, and that means in general, out of 300,000 patients, that this procedure is very safe. Well, abscess is a problem, but in the past it was a metastasis that was growing and could lead to liver insufficiency and kill the patient. Yes, we do the drainage. We manage the patient conservatively. There is a scar. It's a rhetorical question whether it's bad or good. And the false aneurysm of the femoral artery. Again, there are problems related to hemostasis. As for the efficacy of our chemotherapy, everything depends on the degree of the nodes of vascularization, isolated liver lesions, and of course we do not want to say that we're the best. We don't wear a crown. We are ready to cooperate with medical oncologists in managing patients. For us, the most important thing is that patients should be sent to us. Well, the prospects are clear, but in oncology, in treatment of colorectal cancer, adjuvant colorectal cancer, usually FOLFIRI schemes are used. They are 40 years old. Now there are new drugs on the market, but there hasn't been a rapid progress. We still use old methods, and sometimes the response is not quite good. Well, we have two carriers. Well, Lipiodol. And you can see it here with doxorubicin. There is a mixture of lipiodol and doxorubicin. We introduce the drug. We close the artery with a sponge so that the drug could cause tumor ischemia. The second option is hyperspheres, saturated hyperspheres. I started using hyperspheres in 2009. We had several patients. And also we borrowed this experience from France. You can see saturated spheres with doxorubicin. So hyperspheres, well, should not be used with salty water. Again, you can see new drugs and old drugs. Again, in fact, we have two drugs, doxorubicin and irinotecan, carboplatin, mitomycin, and other drugs were administered. Well, if you ask the question, what happened to the patient? Why the patient died, God forbid. Well, that means using drugs off-label. Think about it twice before you take risks. Well, again, using hyperspheres, the idea is ionic interaction, also doxorubicin absorption. Molecules of the doxorubicin will stick to hypersphere. The hypersphere will increase in volume. Well, why hyperspheres are good? Because all spheres can be squeezed. There is a vessel, and they get into. And if we want to have a complete total embolization, we'll get it due to hyperspheres because they will get into the vessel. The plus is that being inside the vessel 2.5 centimeters, as you can see it here, of the surface of the sphere. Well, on this surface, doxorubicin will be eliminated if the sphere is inside the tumor. We have the large impact on the tumor by doxorubicin up to 2 weeks. Well, you can see it here, the tumor tissue and spheres are filled with doxorubicin. We conducted a clinical experiment to see when and what should be introduced and when, what carrier should be used. This is a clinical experiment when the patient is operable. That's the way hepatocellular carcinoma looks like when practically the doll was isolated, the arterial vessel, the ligated vein. We used the particles of metal, 50 microns, like a hypersphere, just to see the distribution of these particles within the tumor vessel. And they are everywhere inside the tumor, inside the vessels. If we measure the distance between the particles inside the vessel, well, they are close together, so the impact on the tumor will be quite good. So you can see hepatocellular carcinoma can be treated very well using this method, and the Barcelona classification proves that that's the colorectal cancer metastasis looks like. A lot of necrosis. In the periphery, there are vessels, large distance between them. If we use hyperspheres here, we get nothing here. In the best case, there will be a minor ischemia, but there will be no impact of the chemo drug. Our effect will be 50% less. And of course, here, the procedure should be done by those people who have a special training here. We have such a concept as oncocardiology, and more and more people are talking about oncocardiologists. Well, there are people who are oncologists and they know what they need to do. Well, of course, the attending physician should be at this procedure. If it's an in-hospital, in this case, he will have a better understanding what we are doing and what to do with the patient next. Of course, the fluoroscopy should be used for control to introduce the suspension. There is an anesthesiologist inside the cath lab. If we're outside the comfort zone, we stop the procedure. Well, this is the scheme, treatment of this syndrome, the way we should do our algorithm, and we made the following conclusions. Lipiodol works better if we have hypervascular tumors or we have metastasis, such as colorectal cancer, and hyperspheres. Well, when we have hyperspheres with the drug inside the vessels, we can have a very good clinical response. In conclusion, I'd like to say a few words about the Declaration of Helsinki. Why don't we have so many patients? Well, I talked to doctors from different cities today, and chemoembolization is on the decline. Well, there is no feedback from oncologists. Unfortunately, oncologists do not understand us. They say it's not in clinical recommendations, then hence we can't do it. Well, why not? Well, these things are not in clinical guidelines. Why? So what? Why not use this method anyway? You can see the Declaration of Helsinki here. It was developed by the World Medical Association in 1956, if I'm not wrong. Item 37, unchecked interventions in clinical practice. If, for example, there are some interventions that hadn't been proven, you can use unproven interventions. We're talking about clinical guidelines. We don't have them on colorectal cancer. If the doctor believes that the use of this method can save the patient's life, restore his health, or alleviate his suffering, yes, sir, we must discuss this kind of intervention later when the procedure was done, and this is a good answer to our oncologists regarding what to do. In conclusion, I'd like to say that intervention radiology should not be ignored, especially when it can be used as the only alternative. Use a multidisciplinary approach. It's the best option to treat a patient. Thank you very much. Thank you, colleagues. Well, just a question. At the start of your presentation, you said that you are using embolization of the branches of the portal vein. Well, how often do you use this method, the embolization of portal vein branches? Well, there will be a special presentation on this. As for our practice, not so many procedures of the embolization of the portal vein branches. Well, there are surgeons here. Well, they say, well, we're not doing the right thing. Well, they do ALPS, and they don't come to us all too often. We have about 10 to 15 procedures per year. Embolization of portal vein sites. We usually use spirals for embolization. We started then using spheres, hypospheres for embolization, but that costs money. But again, you can see that the number of patients is increasing. And now, besides embolization of the portal vein, we do the embolization of the primary source in the right lobe. We wait until the left lobe grows, sometimes not so quickly. If it's 2 weeks, it's one, but if it's 2 months, it's another story. We are afraid of the intrahepatic dissemination, so we try to suppress the tumor. The lobe grows, and there is no metastasis, which is nice. Well, recently I talked to our surgeons, and I came up with this idea. Well, there was the drop in the ALPS procedures, and because endovascular specialists switched over to other procedures. Yes, you remember my last slide. Well, we have patients, we have doctors, different doctors, oncologists, surgeons, medical oncologists. Let's get together and discuss a patient. Choose the best option. We're ready to help anyone. Right? Yes, I agree with you. Well, it should be a multidisciplinary approach. Surgeons are ready. What about medical oncologists? I think they're not ready. The major problem is with medical oncologists. They're not ready for this, and we should break their stereotypes. All right. So they look down at us. All right. So what are you going to embolize? They say. Well, where is it written? In the guidelines. Well, but that's the wrong argument, I guess. I agree with you. Well, so we live in a different era. We need to break those stereotypes. We have 10 people here because medical oncologists are not here with us. Thank you. Thank you very much. Thank you. Of course, we need randomized clinical trials. Then not a single medical oncologist would not be able to say no or something like that. And let's move to the next presentation. Well, Sergey Arentyev, intra-arterial therapy of metastatic liver damage, the embolization of the portal vein. Let's discuss the issue of the portal vein embolization and the problems of the ALPS procedure. As for liver surgery, trend is we use more and more extended liver resection, and the major limiting question is the small volume of liver parenchyma left, and if we do not increase it, this will lead to the patient's death. How can we increase it? There are 3 major methods. Well, PTPE, preoperative portal vein embolization, and ALPS methods and other methods of 2-stage liver resection. Of course, the preoperative portal vein embolization during the last 20 years, more than 4,000 publications in PubMed, and also, well, this procedure is being used more and more intensively. We are expanding indications for portal vein embolization. The number of procedures has increased by 2-fold over the last 10 years. There are also fresh guidelines recommending the wide use of portal vein embolization as the preoperative preparation before extended liver resection. That's the Japanese Association of Interventionist Radiologists who have the greatest experience in the use of this method. Why this method is being introduced more and more? Well, it's less traumatic, highly effective. The ALPS procedures are accompanied usually by a large number of complications and the high mortality. That is why, well, people are a bit dissatisfied with this method.
Of course, there is unresolved issue of embolization, and it is associated and there can be severe complications such as hematorox, portal vein thrombosis, contralateral intraperitoneum bleeding. By the way, in some patients we don't see hypertrophy of parenchyma of liver. It depends on the methods of embolization, from 10 to 35%. Well, we're expecting for hypertrophy. In certain patients, we see the progression of tumor process in liver, or these can be removed metastasis. So resection stages are not performed everywhere, and ALPS methods are not used for all the patients. Not all the patients have hypertrophy, and full-scale treatment is not always possible to be performed. Our experience is not quite vast, but we compare these methods, mechanical embolization and oil chemoembolization, that we add to prevent the progression of local growth of the lesions in the liver. When do we perform preoperative portal vein embolization? When we see metastatic injuries, when we plan vast resection, when parenchyma is planned to be resected, if there is diffused injuries less than 40%, if the patient doesn't have a decompensated liver cirrhosis, and only one chemotherapy line before the surgery. The methods of embolization, in literature we have the discussion. Some surgeons choose ipsilateral approach, where there is a lack of risk to injure their residual liver, but it can be problematic due to tumor, and in this case, portal vein is difficult to be achieved. Contralateral approach is technically simple. Punctuation is simple. It's easier to catheterize for a segment of the liver, but the risk of the development of complications of this hypertrophic part decreases the value of all these advantages. There are rare types of advantage of excesses. Spleen excess is very rare. You do not harm the residual liver, but the spleen bleeding risk is quite high. But to catheterize and puncturize it, we need to have the micropunction sets and microphilic catheters. Microguide allows to make it less traumatic. The second approach is transigular. We do not use it quite often. It is safe in multiple metastases, but the procedure is more difficult and it requires transangular approach for stenting. This approach becomes more important now for simultaneous puncture and embolization of portal vein and liver vein. It is one of the directions that allows to improve the efficiency of the procedure. If we talk about big branch of portal vein, the small vein is subsegmental and it is safer. You can use here the sets of micropuncture, but the risk of damage of liver artery is high here. So we need to punctuate it more peripherally. If we embolize the next segment, it is not always comfortable. It requires additional time, and hypertrophy of the second and the third segment of liver is happening here, and we need to embolize this segment. But it increases the risk of portal vein, and it is, of course, not good at all. And there are technical issues when embolizing this segment. How to embolize? You can see the whole range of embolizers that we can use here for interventional radiology. International authors use ethyl spiritus, but the procedure is quite painful. And most of complications are performed if we perform scleral obliteration with spiritus. We know that there can be cardiogenic shock hypertonia even with mortal end. The methods described now, double embolization, peripheral and central, with occlusion and plugs and glue. The methods are highly inefficient, technically can be complicated, not always performable. But we'll see if it is prospective. We use a very moderate variant for portal vein obliteration. It is safe compared to ethanol. It closes small veins well. If we talk about chemoembolization, we can use oxaliplatin as well. If we talk embolization of puncture channel, some authors say that it decreases the risk of bleeding, it decreases the risk of subcapsular hematoma, but there are also voices against it, saying that it increases the risk of a left portal vein thrombosis. There are technical issues. And if you use 4 French catheter, you don't need to embolize the punctional channel. There are not big studies that can compare embolization of puncture channel and not, but there is a big study that evaluates the risk. The percutaneous biopsy for 18G needle is used. Embolization decreases 2 to 3 times the risk of intraperitoneal bleeding. But if we see if the liver artery is injured, the embolization will not save you from bleeding or vast hematoma. How to embolize the channel? We can use the spiral, the sponge. Somebody suggests the glue. Here we can see the embolization of the portal vein. In 3 to 4 weeks, we see that parenchyma, liver parenchyma increases, and on puncture place, it did not influence the growth of parenchyma. And why there is a lack of hypertrophy? These are either patients with cirrhosis who were preparing for the surgery, the patients after few courses of chemotherapy, and sometimes this is just particularity of portal vein embolization. So what do we do? We prefer secondary embolization of portal vein, and the hypertrophy was due to embolization or new collaterals that appear for secondary embolization. And these patients had good effect. For recanalization or collaterals, we can see on CT angiography, we see CT volumetry, and if we see that there is recanalization, we can perform secondary recanalization. Talking about severe complications, we haven't seen any. They were subcapsular hematoma, preportal fibrosis, but all the other complications did not influence the life of the patient and the state of the patient. Of course, we did not manage to perform the resection of the liver to all the patients. Some patients were lost. Either there was not enough of hypertrophy or the disease developed, but in most patients we still performed the vast dissection. Why we did not perform the resection? The reasons are the following: concomitant pathology, hypertrophy, lack of hypertrophy, progression out and in the liver itself. If we achieved a good treatment, the frequency of complications was same as in the patients for whom the embolization was not performed. So, when do we perform the portal vein embolization? What are the criteria? The volume of residual liver parenchyma should be evaluated. If it is less than 60 centimeters per square meter, in 100% of cases there would be liver failure, and these patients should have been embolized. In some patients, the volume of the liver is enough. Why? Why does that happen? Because functionally hypocytes are not quite functional, and this patient need another test. CG test allows to evaluate adequately and find the patients who needs the following embolization of portal vein. That's why we combined volumetry and evaluate the liver function This is an illustration. The patient with preoperative embolization, hypertrophy is enough. The patient was operated. Further on, the adjuvant chemotherapy was performed. The patient lives for 5 years, no liver failure, no relapse. One more patient with colorectal cancer and multiple metastases in right liver lobe. Embolization was performed in 28 days, adequate hypertrophy in parenchyma, and the dissection was performed. It was also performed in hepatocellular cancer with the embolization of portal vein with hypertrophy, and good result of the treatment. What are the perspectives of portal vein embolization? This is one of the pictures, as I mentioned already. When proximal and distal embolization of portal vein are combined with plug, occluders, and glue, this is quite tough method for embolization, and it allows to evoke bigger hypertrophy. And one more direction that appeared and used widely, popularized, it is simultaneous portal and hepatic vein embolization. Thus, the blood flow is fully blocked, and it leads to hypertrophy. It's performed transegular or transhepatically. And occlusion is performed of the hepatic vein. You can see here the occluders are in the hepatic vein, and glue is added sometimes that allows to stimulate the growth of liver parenchyma, but unfortunately it can be associated with severe complications. Preoperative embolization of the portal vein can increase the plast post-resectional volume of the liver. And this is a very nice picture. Prometheus, we want to achieve hypertrophy of the liver. Interventional radiology can help us significantly. Well, we are behind the schedule. Probably we will discuss everything later on. Now we have online Mr. Alexei Polikarpov. Possibilities of regenerative chemotherapy in patients with chemo-resistant metastases with colorectal to liver. Do you hear me? We are happy to greet you here. I hope you see my presentation as well. Yes, we see it. All is good. I can start. Well, hi everybody from sunny Dagestan. We were talking exactly now. They have the plan of hepatosurgeons. These are people who evaluated the possibilities of this type of intervention, and they cooperate with us quite well. Let's talk about particular category of the patients, chemo-resistant patients, or uncontrolled systemic chemotherapy. Actually, it was discussed already. What happens, what we have. When we were dealing with these technologies, we were checking whether there is an effect of first patterns or not, if we have then chemo infusion, if we were introducing technetium, we were performing scintigraphy in certain infusion regimens. It can be. We resolve the hematological toxicity is possible. And if we talk about randomized studies, everything exists, everything is there, as presented by our colleagues. For today, we have 342 randomized patients in 49 clinics where the regenerative chemoinfusion efficiency was checked compared to standard chemotherapy. And what turns out? It turns out that survival median is high, nearly 2 times, compared to systemic chemotherapy, and the frequency of hematologic hypotoxic complications is lower. It was also discussed. Classical chemoembolization. This is how oil chemoembolization looks like. And when we have hemostatic sponge, same for oil chemoembolization, there is randomized controlled studies. There are more and more of these studies, by the way. But the main conclusion of all these studies is that it works. The response to the criteria to the treatment in nearly half of the patients. And we see that there are standard drugs such as doxorubicin, carboplatin, and this suit is very simple. We have good standardization, and it can be demonstrated like this. And the effect of the therapy in granuloma, you see that it has steadily and it decreased. And this is the partial response according to RECIST criteria. All the methods work. All the methods work if we perform that regularly and control the situation. Then the life median and the patients who died as the most honest figures, we have 2 years. And we can treat our global situation. As for clinical guidelines, in Europe, our procedure is already in all guidelines. Starting from 2019, Russian Oncological Society also included different embolizations such as arterial chemotherapy. And if we see metastatic disease, if the possibilities of systemic chemotherapy are over. So we can combine this therapy with the first line. After first line, we see the progression. If we talk about metastatic liver state-resistant, non-controlled, when at least 2 schemes, including target therapy in specialized medical institutes, and then either patient has monotherapy with carbocetamine, and most often these patients just disappear. They just disappear. We try to take these patients on our patients. On average, in 12 months, they don't want them anymore. We perform the schemes in regional cases that were most efficient, and the reserve was doxorubicin if no shim helped. Usually, chemoembolization with chemoinfusion was used. This is a clinical example, big metastasis. The patient had systemic chemotherapy, progression, and the patient got gemcitabine. She came to our center. We performed. It was back in 2017 when we performed chemoembolization of these big metastases with saturation irinotecan. The remission lasted for 3 years. We see that metastasis disappeared, decreased. Then the patient progressed, but we combined systemic therapy and chemoembolization. And even after the discontinuation of the therapy is 36 months. The next clinical example, young patient, only 3 metastases, but all on the ostium of hepatic veins. Surgery can do nothing here. The patient was prognosing. It was not even a drug. We fulfilled few cycles of chemoembolization with spheres, with chemoinfusion. We got partial response and ablation. We had 6 months of therapeutic vacation of remission. When new metastasis appeared, we repeated 6 cycles with bevacizumab, and the survival was 46 months after the patient was rejected in anti-treatment. The survival median here is 23 months after this therapy. So it turns out that after oncologists reject these patients, our methods, safe and sound, allow us to add 1 year of life, whether it's a lot or not. And the last retrospective multicentral study where we compare the patients who had maintenance carbocetamine therapy. The patients were stratified according to PAR method. The ECOG status is absolutely same. And we see that all the patients with the left localization of the tumor are all simultaneous. The patients are absolutely identical. After cycles of regenerative therapy in the group, their frequency of response is 2 times higher compared to the systemic therapy group. And survival ratio is significantly higher. So the results of our regenerative chemotherapy in patients with chemoresistancy, not controlled chemotherapy, allows to improve total survival for 1 year after the systemic therapy is discontinued. We also have a reserve such as radioembolization and it is proved by the control chemography. And now we have these methods, and it should be implemented more in clinical practice. Chemoembolization of colorectal metastasis in liver allows to achieve local result and partial response in 20% of the patients. Local treatment can be added. And to our mind, chemotherapy should be considered as the method of choice in this situation, but we should not wait when patient is ECOG 3 or leukocyte 1 thrombocyte 40, but to start the therapy as soon as the patient progresses. Interventional radiologist should turn on, and we can have sometimes therapeutical vacation 4 or 6 months allows to restore them clinically, and then we can continue systemic therapy. So we need to work together with oncologists, not contra oncologists. And we hope that we will have same understanding as we have today. Thank you for your kind attention. Thank you. Thank you so much, Mr. Polikarpov. And I see you. We're behind the schedule significantly, sorry. And dear colleagues, I want to present my presentation, the experience of simultaneous use of transarterial chemoinfusion of malignant tumors of the colon or rectum with chemoembolization of liver metastasis. Metastatic deposits of colorectal cancer and liver significantly influence patient. This type of cancer is one of the most widespread, and these patients regularly are seen in our everyday practice, not by oncologists only, but by other physicians when patients come at the later stage of the disease. Surgical intervention and systemic chemotherapy are the methods of treatment of the first line. Of course, it depends on clinical conditions, the patient's fit. But if we see metastatic deposits, including chemo-resistant deposits, interventional radiologist can suggest here good help. Due to the character, colorectal cancer is common cause of death in patients, and the metastasis to liver are the serious factor that limits the patient's life. During long period of time, interventional radiologists suggest different types of local treatments such as cryoablation, radiofrequency ablation, and chemoembolization. There are very good data on technical success of this intervention, and most of studies are not randomized. Of course, we would prefer to see more randomized multi-central studies. The new method, including transarterial introduction, can and already play very good role. At the moment, we see here the standards of International Radiology Society. The indication for transarterial chemoembolization is primary tumor and metastatic deposits. In 50% of patients with colorectal cancer have liver metastasis. Sometimes people come with fourth stage already, and unfortunately, the task there is not very typical. We performed prospective analysis of chemoembolization in simultaneous use with chemoinfusion and chemoembolization of hepatic artery. We have analyzed 95 chemoinfusions and 95 chemoembolizations in 76 patients. In the intermediate period, we performed either maintenance or full-scale chemotherapeutic treatment.
For the preliminary assessment, we used a CT and MRI with PrimaVist, the specific contrast media, which allowed us to make decisions on an individual basis, and they were more correct. A young patient, 55 years old, the hepatic angle tumor with the metastatic liver involvement, 2 lobes, 2 lesions. Here you can see the selective catheterization of the targeted zone. Chemoinfusion was done here with the further catheterization of targeted hepatic arteries using the microcatheter with saturated microspheres. Irinotecan was used here. Catheterization was done stage by stage. Again, you can see the tough feeling and the partial washing of the contrast from the left hepatic artery. Here is another example. Well, chemoinfusion of the right of the rectum, catheterization of the left iliac artery, and then catheterization of the right lobe of the liver, right hepatic artery, with the use of saturated microspheres. Here is another clinical case, a female patient, chemo infusion of the right intestinal, catheterization of the right hepatic artery. You can see the hypervascular metastatic deposit of the colorectal cancer using a microcatheter. We selectively introduced the microspheres. It was a success. The patient has been stable for more than a year, and the patient is treated by us and by medical oncologists. Well, after the embolization, 35 patients had the stabilization of the process. 9 patients had the positive dynamics. Unfortunately, in 32 patients, there was a progression. It's because many patients were chemo-resistant. They had chemo-resistant deposits. Several lines of therapy have already been conducted, but nevertheless, this method is highly efficient in clinical practice, and there is a need to use the multidisciplinary approach when we can manage such patients together, chemotherapists and radiation therapists. Thank you very much. Questions, please. Well, Robert Pavlovich, did any patients have a radical procedure done afterwards, like a resection of the rectum or the liver or whatever? Only a small number of patients, yes. This was the first clinical case. After 3 courses of chemoinfusion and chemoembolization, there was a removal of the tumor of the hepatic angle, and the percentage is very small because usually these patients came to us very late. All right, they all came very late. The final presentation of this session, the effectiveness of flat flat-detector CT in the treatment of hepatocellular carcinoma and metastatic colorectal cancer. Diana Sidikova, please. Dear colleagues, the theme of my presentation was just announced. We'll be talking about CT and the hepatocellular carcinoma and the metastatic colorectal cancer treatment using the flat-detector CT. What do we know about the flat-detector computed tomography? This is a very specific technology when we use the detector and the source of irradiation using the C-arm of the angiographer. We know that there are different synonyms for this term. Usually we use CBCT, cone CT. In Russia, we usually say flat detector CT. There are also different commercial names depending on what angiographer you have in your facility. As you know, patients with primary liver diseases are subjected to screening by a multidisciplinary team. Later, these patients will be sent to TACA or radiation therapy. And what are the major difficulties we encounter when we use FDCT? First of all, the involvement of non-hepatic arteries in case of hypervascular tumors. And in this case, well, FDCT helps us detect and show, using the arterial phase, what vessels feed this particular tumor. Later, this makes our task easier to selectively catheterize patients and introduce the drug. Second, there is no need to use the contrast media in case of parenchyma involvement, and here FDCT can solve the problem with parenchyma. We can see the tumor regardless of whether it is hypervascularized or not. Also, we can say that this technique, two-phase FDCT with contrast, is a must as far as these patients are concerned, because here we can cover different issues and resolve specific tasks. Well, as for one-time contrast, here we can get two data of FDCT. First, the early arterial phase and the delayed parenchymal phase. The patient holds breathing for 6 seconds when we get the image. As soon as we see the certain level of involvement of a patient, we use the certain amount of contrast. Usually it's 2.5 millimeters per liter is the speed, and with the delay of 5 seconds. Usually we do the exposition after 8 seconds after injection, after the injection, after 30 seconds pass. We do the second exposure so that we could have the visualization of the delayed phase. Also, the image must be as approximate as possible in order full contrast enhancing, while the point where gastroduodenal artery goes out. You can see here the images, the right arterial phase, also parenchymal phase, and also we're summing up both images, well, the artery and the parenchyma images. In conclusion, I would like to say that this two-phase FDCT is of great importance. These two phases allow us to see the contrast in the bed, but also we can have a good image of parenchyma. Thus, we can control the amount of contrast introduced. we reduce radiation burden. And another important factor is that at the preoperative stage, we sometimes can miss some of the tumors that should be embolized. And FDCT allows us to see these tumors, at least more tumors, as compared to what we saw before. Thank you very much. May I ask you a question? What is the resolution of FDCT, minimal resolution? What can you see on PDCT? 2 millimeters, 3 millimeters? The idea is to see lesions that cannot be seen on CT, on the usual CT. What's the resolution? How many small lesions more can we see? Well, you should ask our oncologists. We as interventionalists just support them in doing their job. Thank you. Thank you for this presentation. One more question. Sorry, the question is off the mic. The answer is, I think these two things, can go together. Well, one thing should add up to the other. Thank you very much. Any more questions from the audience? Well, we're wrapping up this breakout session on time. The previous session ran over time, but we are very precise so that the next breakout session could start also on time. Thank you very much. them. The first presentation, CT diagnosis for central vein lesions. What does a surgeon need? V.L.Soroka and Sh.Assadulaev. Well, the evolution of methods of this pathology developed from surgical methods of bypass, which had no alternative, to the new methods of choice that we have now, and vascular recanalization, angioplasty, and stenting of central veins in some cases. The high level of azotemia is not a contraindication for CT because the patients are on renal replacement therapy, and only allergic reactions to contrast media is an absolute contraindication for CT diagnostics, which is very important for preoperative preparation of such patients. I'd like also to say that if patients should have the vena cavers involved, the interdialysis interval should be rather small. And in this case, Russia is a vast country. Patients may come to you from different areas. So first we do the dialysis, then CT, and then the dialysis again. And this interval between CT and dialysis should be increased. Often, X-ray specialists do not know which zone should be studied. What is important in terms of surgery planning? What zones should be scanned? Despite CT accessibility, imaging of jugular veins is of great importance. Also, occlusion of jugular veins, the character of such changes in the subclavicle axis, and also submuscular veins changes should be detected. Bringing to bear that in case of recanalization, we use the double axis, the fistula axis. We should know the conditions of the basin of the low vena cava, and we need to scan two basins. In this case, we should have one study using one contrast media and to detect the venous hemodynamics and calculate the time parameters. We can scan superior and inferior vena cava. Also, X-ray specialists ask us, should we do the arterial phase? Should we scan the arm on the entire length? Well, ultrasound is a good method of diagnostics, and CT angiography will be quite good in a situation when there are different interventions expected, especially when due to scars or several prostheses. Well, it's difficult to assess the condition of the arm, especially in the area where the vessels or veins were drained. In this case, CT can give us additional information. Also, the condition of the arterial bed and the interaction of veins at the level of the chest can give us information about the vasal compression in this area, which is very important. But we must remember that often these patients have a one-sided lesion, and we cannot just have a large amount of contrast here. And also we must remember that patients can have prosthesis in the arm, and often, the medical nurse tries to put a catheter in the area where there is a prosthesis installed, and the patient can have a study with the arm raised, and the patient will not fit into our gantry. So there will be just the study of one arm. Well, the archive can help us. Well, for example, you can see the left brachiocephalic vein is closed. There was a study done through the permanent catheter. Right now, the right arm is not functioning well, and I can see that in this case, if you inject a high-speed contrast, it will be impossible to do the proper scanning. Well, you can see patients with metabolic disorders. The venous vein has a very good imaging due to the contrast. Should we do the raised hand study here? Well, in terms of the functional test, CT diagnostics is a must. So in this case, we can assess extravasal compression, especially in the subclavicle segment, and not just its presence, but also its character. So the main component of the extravasal compression, the bone component, the ligaments, muscles, and as we plan stenting in the future, we can see where the possible compression in stent may occur. Also, during the examination, there might be such finds, such as para-articular or extra-articular growth, which may be the cause of extravasal compression. Even in case the recanalization and angioplasty are successful, well, they can be predictors of free stenosis or repeat thrombosis due to extravasal compression. You can see the data, X-ray data, 3D reconstruction of the same patient, which you see on the previous slide. You can see only CT shows us extra-articular and para-articular growth, compression in the subclavicle vein, and you can see the surgery was successful, but the clinical signs still persist. It is also possible to have extravasal compression at the left vein. So the compression occurs at the brachiocephalic trunk and between the trunk and the anterior wall of the chest. It can lead to the stent compression during implantation. This is the nitinol stent, and in case of repeat implantation using the balloon expandable stent, there was the stent compression, full stent compression. These patients, well, are difficult. You should have a clear understanding how to raise the patient's arm. There might be false positive results if you're interested in two arms. Well, in this case, well, be very careful with this intervention. And you can do the contrast through arteriovenous fistula, where you can calculate the timely parameters. The results of the study are quite good. Do not do it through the prominent on the leg because it's similar to phlebography. Well, there will be pain, turbulence, and uneven contrasting, especially in the basin of the superior vena cava. What questions should be answered in case of CT? Well, if there is obstruction or stenosis, the type of changes, level of changes, the length of obstruction, the presence of thrombotic maxis or sclerotic changes in the area of contrasting, access areas conditions which are being scanned, well, whether there are duplicate veins that can be taken for the main lumen and the presence of extravasal compression with the prevalence of this or that component. Venous hemodynamics should be known, and also you should have the good technique of scanning of the venous bed. Since we're pressed for time, let me give you just one example. On the right, you can see the occlusion of the cerebral vein. Well, you can see the stenosis, and also the right side is symptomatic. Using the CT data, well, we can use the fistular axis and additional femoral axis. Recanalization is done, pre-dilation of the occlusion zone, angioplasty. Well, again, the cephalic vein, we prevent the damage to the subclavicle segment on the second guide in the jugular vein, angioplasty of the obstruction zone without the damage to the subclavicle segment. What are the typical mistakes? Well, we can see large collaterals, and operators think that there will be a long occlusion zone, but not the length, which is important, but the site of the occlusion is of great importance. It can be just this particular small site covered by collaterals. You can just miss it easily. And here you can see, well, such defects which are missed. And again, it's very important to pay attention when the tactic is selected. The sign which allows us not to miss it is the delay of the contrast media in the occlusion zone or feeling the collaterals. We can see we did it not through a permanent, but through the arm vein. Using permanent, we can miss stenosis areas. You should mention this to the surgeon. Like in this situation, angiography was done through the venous bed in the semi-vein of the permanent catheter. Sometimes it's not clear whether there is an artifact due to the heart contractility or is it true stenosis according to CT, for example. There are two lesions at the confluence level, in the distant part, angioplasty on the right. The last picture shows here when the balloon is inflated, we have a stenosis in the confluence zone, and in the distal area there is no stenosis when the balloon was inflated. Well, this problem was an artifact due to the catheter and its movement during the heart contractility.
As for previous information, if there are such lesions, allows to get optimal result. As for lumen evaluation, it's important. We have to see how the lumen changes. You see the obliteration with a different filling, and these are thickening of the venous wall. Fibrotic perivascular changes, and we need to understand whether we need to note it or not need to note. The character of changes allows to plan the tactics, whether it is aggressive or softer, and also it allows to use harder or softer tools, so we can make the time of the procedure shorter. We see different thrombosis, rethrombosis. If we have rethrombosis, we have also to understand to avoid the aggressive methods and to avoid the perforation or balloon inflating in non-targeted zone. As for double vein, it's also an important factor because in angiography, if we don't see CT, we have the illusion that this is the main trunk, but it turns out that it is side branch. And while passing this zone, if we inflate a balloon, we can have serious complications. Parallel lumens also can be partially obliterated if it has dead end. It makes the surgery longer. If we have the information about all the excess waste to the main zone, can reduce the time of the surgery. Same as this situation, one channel is calcified and the other channel could have led to the true lumen. Sometimes when we have these collaterals, we can miss these collaterals. It looks like subclavian vein. But if we have multiplanar reconstruction, we can understand very clearly where the occlusion is, where the true lumen is, and what the zone is. This patient is after previous recanalization angioplasty. At coronography, we see such expansion in the subclavian zone, and it turned out to be pseudoaneurysm. And CT can allow us to see collaterals. And again, we reduce the time of the manipulations at this zone. If we have lone occlusion, if we do not use the contrast for the distal bed, according to the CT basis, it will allow us to choose the instrument, and it reduces the time of the operation. The groundings for the following for the second studies. We don't see the clinical regress, not functioning fistula, and new symptoms. This is a patient after recanalization of left vein with lymphocyte after lymphadenectomy, partial regression. In CT, we see After the operation, we see extravascular compression with brachycephal trunk. The stenting was performed, and we had total clinical regress. One more patient. The CT was performed after the operation with a stenosis with stent graft in subclavian vein. On surgery, there were no occlusion, but when there was a relapse, we see that possible we can use a jugular vein, and we could have performed the angioplastic and get a better result. Same data. Thank you. Thank you for the attention. Thank you for very beautiful approach. It is an art, not a presentation. As we plan a prize, please let's ask a question. There would be prize for the most interesting question, so please ask a question. If you have any idea what you want to ask, please do ask. At the end of the session, we will ask one more time. Let's move to the next presentation. Central vein angioplasty in dialysis patients. Dear colleagues, I'll share our experience working on central vein in the patients who work on dialysis. From 2016 till May 2024, we performed this help to 200 patients. We have more interventions, but we have, of course, some limits, financial limits mainly. We're a big medical center in oil and gas factory, and we have lots of people who are retired but are served by our center. And starting from 2016, it started very simply, dialysis center, and other cities started working with us. According to the reports of 2022, we perform lots of this help. From 2023, we don't have the data. In 2016, 17, 18, we did not perform lots of these surgeries because of different tariff. Balloon angioplasty or for extracorporeal dialysis was on the second level of the operations for those for whom insurance, state insurance, and DRG is possible. We tried to show balloon-like catheterization, so there were some legal insurance issues. The idea is by the company BART, and we started cooperating with Ministry of Health, and we managed to make this service as vessel surgery. And in insurance, in tariff insurance, we could have implemented this service as vessel surgery, and that's why financially we can perform it now. Which are these patients? These are patients with functional AVF is venous hypertension, and when they had venous catheter for a long time, and it evokes stenosis or occlusion. Fistula at the hand as a golden standard. It leads to increase in venous hypertension and issues with dialysis. All these patients are searched on their insurance groundings. You know all the signs, stenosis, collaterals. So the problem is here when they cannot achieve dialysis blood flow. Sometimes it's just impossible to set a permanent catheter when there is occlusion. It all makes it important to remove this stent and occlusion lesion of subclavian brachiocephal vein, and it's rare, but from superior vena cava. We work under ultrasound control. I know that there are experts who can use fistula vein. When we work on central veins, the size of introducer that we have to use, it is bigger than dialysis needle. So we try not to injure more fistula vein where it is achievable for dialysis. We control. We have ultrasound. It's either cephal excess or basilar excess. These are main instruments. We prefer balloon of high pressure. And I will explain to you that when patients come with a relapse and you think what we can do, we noticed that when we work more aggressively, the result lasts longer. In our practice, we use a balloon 20, 14, 16 atmospheres, though their choice is wider. It's important to mention that we see pain syndrome constantly. It is important to notice that usually perforation is okay, but the possibility of vein rupture, that is dangerous. We can try to avoid the rupture, but the balloon escalation makes this intervention more expensive. But stenosis success is not problematic. If we have occlusion, it's more difficult. According to the world data, the occlusion recanalization of central vein is from 45 to 100%. And let's talk about complications. Most of the patients, after their help, they'll immediately go to dialysis. All the patients get the dialysis in our dialysis center. It works perfectly. All the main complications that have some issues, if you have some extravasation and it is removed, we do not put it into the statistics. These are main complications, 2.5%. The subclavian vein with hemothorax rupture, the rupture of vena cava, it was with SED, and the rupture of vena cephalica. Balloon hemostasis was successful. Introducer perforation of vena cava, hemopericarд with successful pericard punction, probable iatrogenic IVF, and then probably there was iatrogenic problem, and the patient was sent for a thoracic surgeon. And complications that are not associated with the intervention. There was a patient with a weight 150 kilos without any complaints. He died. On the autopsy, nothing was found, and the patient was not complaining of anything, so probably it was sudden cardiac death. Few clinical cases. Sometimes we need to have few excesses to achieve success. 5, 2, 3, even 4. Sometimes we have to have these multiple excesses. We need to have stable flow from the hand where fistula is. Sometimes, to achieve the success, we have to have non-targeted recanalization. If the fistula is on the left side, and we couldn't pass it after we recanalize the right side, the occlusion was opened, and we managed to go through this occluded part on the right side. Most complicated cases are occlusions of superior vena cava. Sometimes you cannot find here the stump, not from upper part, not from the lower part. And it's important not to think that appendage of right atrium is stump. They can look similar, but appendage is not the stump. And it happened once that there was just an introducer on the level of the occlusion of the vein, and to put it correctly. And please look here. Here, the pictures are quite similar. The appendage of right appendage, it looks up. And the occlusion stump, it is not easy to find it. And it does not look like straightforward. We performed here the successful recanalization, and it allowed us to put the permanent construction here. Well, if we have the situation when everything is lost, nothing is good, this is the additional task. There was the factor of tiredness. Introducer was taken out. All the veins are closed. Everything is kind of blocked. And we tried to recanalize it. We didn't manage to perform recanalization. What did we do? We used the femoral approach. We achieved brachycephal occlusion. We came to the clavicular, opened it there. We dragged through the guide, and then introducer worked well. And it was really a surprise. We changed it in a year or in 2 years. My conclusion is straightforward. Recanalization and balloon angioplasty of central vein is efficient. It is efficient and safe. It can be replicable. It improves their life, and it allows to have better AVF state. Thank you. One question. I'm from St. Petersburg. Thank you for the presentation. But for balloon angioplasty, how often do you use stents and stent grafts in central veins? And, well, we use balloons when we have arteriovenous fistula. I'll tell you about that. Here, I don't know, but I wouldn't say there are lots of big size of cutting balloons. We would love to have cutting balloons. And we can set the stents quite rarely when we have we have unsatisfactory results of angioplasty. If the results of this angioplasty stays for a very short time, like when the patient, and when we understand, we will do the same. So we do perform stenting. You know, we prefer to have the stents. We used to all stent, but and we have special venous stents. Thank you so much. We will have time at the very end for the questions and answers. The next presentation. Mr. Baryshnikov, regional thrombolysis. We wanted to share our experience with regional thrombolysis. What can we do? What can we do here? There are two options that we can perform. We can remove thromb, and to understand what is the reason for thrombosis, we need to eliminate the cause. To eliminate the thromb, we can use thrombolysis. We can use alteplase for now and mechanical removal of thrombosis from what we have. Those that contact the wall and those that do not contact the wall. At the moment, we have only a Fogarty catheter and Yard-Jet, Atororex or Aspirex. And of course, we can perform angioplasty and stenting. As for guidelines, the guidelines are very, let's say, dissolved. European and American guidelines say that we can choose ourselves, depending on the experience of the surgeon, or there is 2A class of the recommendation. Actually, it sounds like choose yourself. It's not clear at all. Though American guidelines say that we can use surgical way if other methods are not way. There are different types of thrombolysis. We can say that there is classical and pharmacomechanic thrombolysis. When we have thrombolytic, angioplasty, and other methods, it can be learned to infusion. When we have infusion, introducer is implanted, and then thrombolytic is infused. There is also a technique, Lees and Way. We prefer these methods mostly. We introduce it into fistula, into protester. We wait till the thromb is destroyed, and then we perform some other intervention. And as you can see here, these are 90s and 80s pharmacomechanic thrombolysis. We should not think that these are some mechanical approaches with V.Jet or something like that. It means that we use the methodics of thromb destruction when angioplasty of distal part of thrombus. When we have anastomosis, thrombolytic introduction, we can use Fogarty catheter, aspiration. These are most common methods. So we can use lytic, and then it would be Lees and Wade, or we use angioplasty. As for evidence base for thrombolysis, it is not very strong. There is a systemic review of 2018. 10 studies, 1,272 patients, and they compare open and synthetic vessel prosthesis treatment. 30, 60, and 90 days results of the patency did not differ, but in 1 and 2 years, there were better results in the open intervention. As for complication, there was no difference as well. If we take this study, we can see the years of the study. So the meta-analysis was performed in 2018. All the studies are randomized controlled studies, but all these studies were performed back in the 90s and early 90s. It was compared to open surgery. It is either flap or reforming of anastomosis, prosthesis, so it is not just thrombectomy. And this the Cochrane study of 2024, 14 studies, more than 1,100 patients. They compare thrombolysis and open intervention, and there is no difference. Again, no difference. We see that there is higher risk of systemic mistake, bad design of studies, and so on and so forth. To understand the results that we expect, that was the results for prosthesis. When we have to compare prosthesis of arteriovenous fistula, cumulative patency can be 75%, and in 5 years we'll see only 25 cumulative patency. And only after the second year we see the difference in the results, mainly in primary and secondary patency. All in all, the results are not quite cheering. We cannot have these long-term results. What can we do in our case? We use Alteplase. We use both Russian and international produced Alteplase. We need to perform VK. In our nephrological guidelines, we do not have anything here. We use European guidelines. We use this standard sheet that we have in our information system, and it is automatically filled in. So the thrombolysis methods, we use. Shamil shared it with us. He said what he does. We modified it. This is the solution. Nobody says how it should be done. Somebody uses 1 milligram of Alteplase. Somebody uses 6 milligrams. Somebody uses heparin. Somebody doesn't use heparin. Everybody uses its own mixture. This is how a fistula looks like. We have stenosis, there is anastomosis. Native fistula has lots of branches. And we need to introduce few excesses because there are lots of branches. The lytic is just washed out. We don't see beautiful lysis. So we use common needle. We introduce thrombolytic. And then under ultrasound control, when we exclude artery embolization, when we see some result in 15 minutes or in 2 hours, when we see that there is pulsation, we take the patient to the intravascular or we set the introducer, and then we follow common angioplasty procedure. As for thrombolysis, sometimes we have patients with long-term thrombosis. This is how thrombosed prosthesis look like. It is usually in the zone of anastomosis. There is usually thrombotic plaque that is not easy to be released. We use the common catheters, and through these catheters we introduce thrombolytics few times. After this puncture, after we have this blood flow, we see good result. Even if we have this needle puncture, after we introduce thrombolytics 1 or 2 times, we perform the control, we check what we have, and take the patient to the cath lab, where we can set introducer nearly anywhere, depending on the results. We check where we have, and then we can use this introducer. For fistula, we do not use thrombolysis if we have thrombolysis for more than 2 or 3 days. If we have prosthesis before 2 weeks, of course we exclude contraindication to Alteplase. It's already obvious now that if we have big, long thrombosis, the results are not quite good. And if we have short thrombosis in the zone of anastomosis, if we have stenosis, the thrombolysis is not that. It is not recommended to use this type of approach. We would not use thrombolytics. And what we had here, we had 27 procedures of thrombolysis in 19 patients. The median time is, observation median time is 10 months. The time of thrombosis from 0 to 14 days. As for serous fistula and prosthesis, you see, that's what we have here. 18 procedures with arterial fistula. Observation median was mainly in thrombolysis. The time of thrombosis is 0.7, 0.8 if we talk about fistula thrombosis. As for prosthesis, it would be 3.7, 3.7. We had better technical success in prosthesis and arteriovenous fistula due to the fact that there was attempt to perform thrombolysis in this big fistula, and when thrombosis was not quite fresh.
The average primary patency in fistula, in prosthesis 6 and 7, in secondary 12 to 6 months. The patency was less. There are additional thrombi. In case of fistula, the patency is the same. Well, the primary patency was not quite bad. As for prosthesis, they required additional interventions. Basically, no serious complications. In 2016, we did thrombectomy with balloon angioplasty. We got very bad results. Well, out of 6 axes, only 1 axis was functioning. So the original results were very bad. Well, conclusions are here. Well, thrombolysis is quite effective. The technical success depends on changes in the fistula vein and its maturity. Vascular processes are very good subjected to lysis, often require repeat interventions. The method is quite safe for the patient. Well, that's what I wanted to say. I know that I overrun my time. How can I put back my last slide? And I will wrap this up. Well, for those who ask questions, may I have my slides back? I wanted to show you the picture we would like to give you as a gift. Where is it? Well, this book and the atlas. So, if you have any questions, ask questions. The winner will get this book and this atlas. Thank you. If there are any questions, maybe just time for one question, please. And use a microphone. Well, as a rule, thrombi occur if distally from the anastomosis there is some kind of stenosis. Well, perhaps repeat thrombolysis or due to the lack of assessment of the coronary bed of the central vein. Yeah, I got the question. Lysis is linked to angioplasty. The central veins, where we start with the central veins, it's a must, and everyone does it like that. Angioplasty is an integral part. Sometimes stenting when there is a distal anastomosis, but that's very rarely if we see that the results are bad. Angioplasty is done always. Well, angioplasty of the distal part of the anastomosis usually has bad long-term results, and the same is true of thrombosis. Any more questions? No more? Thank you. Let's move on to the next presenter. Angioplasty of arteriovenous fistulas in dialysis patients. A.Ivanov from Salyvat, please. Dear colleagues, allow me to share our experience. Angioplasty of arteriovenous fistulas in dialysis patients starting from 2016 and up to now. We've had almost 190 patients. We could have had more patients if we hadn't had strict limitations due to mandatory medical insurance. Well, we also take care of the chemical combine, lots of people who are retired, etc. And what is important is that as for care structure, 47 clinics in Russia, as far as I know, provide this kind of care. Usually we have the so-called detachment. When a patient is attached to a particular healthcare facility, we don't have the system of routing. So what I wanted to emphasize here, and this is a follow-up to the previous presentation in 2018, well, we started providing care for central veins and fistulas, and as for central veins, the costs are very high. As for fistulas, the costs are lower, but we managed to justify our position, saying that for fistulas, sometimes we need 2 balloons, one for anastomosis, one for fistula veins, sometimes even 3 balloons. We need a high-pressure balloon sometimes, or 2 high-pressure balloons. Sometimes we need cutting balloon, or we need a drug-eluting balloon in case of repeats. So we provided the economic justification for our government, and we need to change the situation and also try to avoid situations like that. Some say, well, friends, we have a good tariff formation, and, well, we need just 1 balloon. No, sometimes we need more balloons, and we need to think about our future. Well, here you can see the patients, well, with the basically AVF destruction. Well, the vascular surgeon can do the screening of such patients. As for angioplasty, well, some people say that angioplasty should not be done, but we do it. And when on ultrasound we have critical problems in anastomosis or the vein, and again, we do not have a lot of difference between the introducer and the size of the fistula vein, but we do not puncture the fistula vein. We use the cephalic vein, for example, and the plus here is that there is no hemorrhage with this axis. If we look at the brachial artery axis, there is more bleeding there. Also here, we can detect undiagnosed problems when we move from the fistula vein to the brachial part. So you can see cephalic basal vein axis allows us to have all the advantages, such as to treat the radial artery when it's the donor artery, and also we are trying to do our best, and as the classical endovascular access, we sometimes try to go through the pulsing radial artery. You can pass the guide, the high-pressure balloon, and to do the anastomosis. Technically, it's quite simple, but recently we encountered the ischemia of the wrist, and again, so we try not to puncture the radial artery unless it is absolutely necessary. Here you can see some other peculiarities. We prefer high-pressure balloons, and again, usually these are patients with relapses. If the patient comes back to us quite early with the relapse, we realize that the tactic should be more aggressive. Maybe a balloon of a higher size or higher pressure, or drug-eluting balloon, or the cutting balloon. something should be changed here, and we've noticed that high pressure in general gives us better long-term results. Perforation usually has no significant consequences, unlike the central veins. Ruptures are quite rare here, but later in time, in the place of rupture, which was closed with balloon hemostasis, a neurosmitic transformation can form. Thrombolysis is quite rare. We don't like it very much, and we do it differently. We go through the vein we do the primary balloon predilatation, thus we provide the primary patency, and thrombolysis work not on the border of occlusion, but thrombolysis works on a large area when there is a thrombolytic and the patency is already present due to primary recanalization and pre-dilatation. There is a correlation between success and bleeding, especially severe bleeding. If there is severe bleeding, there is a lesser chance of success, especially in patients on hemodialysis. So as for thrombolysis, it can be successful, but after thrombolysis, the bleeding can be very high, so you don't want to do thrombolysis once again. What else if we do not get an optimal result? We've been trying to use cutting balloons recently, and again, going back to the question of balloon size, they fit in terms of size, and we also use drug-eluting balloons more often. Also, per one procedure, again, if needed, we do both the fistula and the central vein. There are a lesser number of complications if compared to central veins. You can see concomitant cardiac pathology. One man died from progressive heart failure. There was one case of rupture when balloonplasty was not enough. The vein was very thin, it ruptured, and it was impossible to stop the bleeding. So vascular surgeons had to solve this problem. But most patients, have no problems. And let me just go back to the conclusions. Balloon angioplasty can be reproduced many times, and we can obtain very good and safe results. Thank you very much. Thank you for this presentation. Any questions from the audience? Thank you for this interesting presentation. Indeed, I am Sorokin Nikita from Tula. I've got several questions. First, did you ever use the distal radial axis? Yes, I mentioned this partially. Distal radial axis is being used when we do not manage to go through the anastomosis. But we never start with the radial axis. If we failed somewhere to go through the anastomosis, we can do it through the brachial or through the radial axis. Yes, we use the radial axis when we did manage to go through anastomosis first, but we try not to do it because patients with ischemia with black fingers, with the wrist ischemia, there are more and more patients like this. After mechanical recanalization and balloon angioplasty, do patients get any medical support, like to prevent future thrombosis? My personal experience is in the area of anastomosis due to the annulus that happens. You do the balloon angioplasty, and there is some kind of dissection there, and how can you prevent thrombosis in this place? Do you use any medication here? All these patients, have a different tolerance to anticoagulants. Some have a bad tolerance. If the patient is tolerant toward anticoagulants, they can be administered, for some time, but not routinely. No, not routinely. And my third and last question, after What time from the formation of the arteriovenous fistula? Say, half a year ago, the fistula was formed, 3 months ago, it started functioning, and then there was a thrombosis. Are there any time limitations? The minimum time of formation of fistula when plastic can be done? Well, this is in the guidelines when you need to take the patient who has the fistula being developed slowly. The minimum time was 1 month. The lesser this time period, the higher the probability of the rupture of the vein, which is not authorized. We need to exceed the time of authorization, but it doesn't happen in the vein. We try to help. Well, maybe to find if there is a defect when anastomosis was formed. Well, we try to help, but nevertheless, the closer to this, the more danger of venous rupture. Well, so up to 1 month, we do not take a patient. Thank you. If it's not, fistula that is almost ripe. Well, sometimes people say that it's 3 months when the fistula is ripe. Sometimes they say it's 6 months. So after a month, well, you can operate on the patient if there is a reason for not being ripe. And if it's a stenosis of thrombosis, you mentioned thrombosis. If it's a stenosis of the arterious fistula, well, if the fistula is already working, it's another thing. All other things, that's what we call balloon-assisted maturation. We have such a notion. Well, you do not treat the stenosis, but you help the fistula to get mature. All right, thank you very much. Here is a clinical example. Here is a patient. The fistula was formed 1 month later. The fistula got mature. The patient is ideal. The fistula is functioning. And we started to do the puncture, and then the thrombosis occurred a week later. Will you take this patient for plasty with recanalization? 1 month and 1 week, let's put it this way, this time period. I think we should look at the patient individually. What kind of vein we have, what is the diameter of this vein according to ultrasound. 1 month later, can we have the fibrosis at the point of anastomosis? Is there a risk of anastomosis? Yes, the risk is high. Thank you. Thank you very much. Let's move on to the next presentation. A live feed from China sharing experience of ultrasound PTA treatment for vascular access stenosis. Su Chaojiang, Guangzhou, China. Oh, sorry, you're here. It's not the direct feed from China. We have a live presenter here.
Hello everyone, my name is Shu Chaojiang. From the Department of Nephrology, the affiliated cancer hospital of Guizhou Medical University, China. I'm happy to have been invited to attend the annual picture conference. My topic is experience sharing of ultrasound-guided PTA in treatment of vascular access stenosis. Vascular stenosis. Peripheral vascular stenosis can be classified into types 1, 2, 3, and 4, all of which are amenable to treatment using ultrasound-guided PTA. Type 1, IVF juxta-aneurysm stenosis, often accompanied by type 4. Type 2, venous stenosis in the puncture area. Type 3, cervical arch stenosis. Type 4, arterial inferior stenosis. Let's look at the special stenosis, venous stenosis, which can be opened by ultrasound-guided PTA. Significant lumen reshaping was observed following PTA with tearing. Vascular calcification-induced stenosis can also be treated with PTA. Occlusion lesion can also be intervened with ultrasound-guided PTA. Ultrasound imaging revealed vascular occlusion. Retreatment involved the use of ultrasound-guided sharp puncture technique. After segmented puncture and segmented ultrasound-guided PTA treatment, significant effect. Stenosis presenting several intimal hyperplasia represent a particular challenge can be effectively managed through ultrasound-guided PTA, improving drug tolerance. A follow-up examination, one most post-surgery revealed a notable improvement. Thrombosis can also be treated with ultrasound-guided PTA. The ultrasound-guided PTA thromboectomy showed significant effect. This is my new technology. Ultrasound-guided PTA can facilitate the creation of IVF by expanding arteriole with a diameter of less than 1.5 millimeter. After ultrasound-guided PTA, the arterial lumen meets the IVF standard, more than 1.5 millimeter. Establishing IVF showed significant effect. Improve the technique success rate and maturity rate of IVF. Of course, ultrasound-guided PTA can also be applied to small diameter arteriole in children. Significant effects were observed 1 day and 1 month after surgery. The patient has been undergoing regular dialysis treatment for 1 year. It can also be applied to hiding. In this case, the patient experienced numbers and pain in their fingers, with the angiography revealing a lack of blood flow to the sub and index finger. A large amount of blood flow through the palmar artery to the intimal fistula, and the proximal radial artery was occluding. Next one. After ultrasound-guided PTA treatment, the symptoms disappeared and the effect was significant. PTA has a wide range of applications. We will share a case below. Medical history. Patient, elderly male, 66 years old, has been receiving regular dialysis for over 3 years, with intermittent fistula stenosis noted for the past 3 months. 1 month ago, the patient experienced an increases in dialysis venous pressure, peaking at 119. Occlusion of the forearm CV and MCV along with stenosis of the upper arm CV well observed. The accessory CV was unobstructed. The diameter of stenotic upper arm CV was 1.8 millimeter, while the normal diameter is 6 millimeter. Thrombosis occurred
Sorry, you're off the mic.
along the extended segment.
You are off the mic. Sorry. We cannot hear you.
MCV leading to pulmonary occlusion. Allocation of large lumen in the forearm CV was selected as a puncture site. After successful outside-guided puncture, a suprasmall guide wire was inserted into the upper arm CV. This is the upper arm basilic vein. For the reason from forearm CV to upper arm vein, the proximal peripheral vesicular scoring burn catheter travelage 5 millimeter and 4 centimeter was selected. Segmented expansion of target lesion. Post-operation, there was unimpeded blood flow and the vesicular lumen exhibited a healthy structure. For the upper arm CV stenosis, the proximal peripheral vesicular high pressure burn catheter was selected. Prosthesis 6 millimeter times 4 centimeter. Following the surgery, blood flow remained unobstructed, and the vesicular lumen appeared structurally sound. This is the end of my report. Also, thanks for my team. Thank you.
Thank you very much for your very interesting presentation. Если у кого-то есть какой-нибудь вопрос, может... очень короткий.
Oh, probably somebody has very short. Later. We'll ask later. We'll ask the questions later. Thank you so much. Let's proceed as we're behind the schedule. Oh, it's my presentation now. Well, stenosis, venocephalica, Baryshnikov Alexei. Well, I have one more presentation. Well, the problem of stenosis of venocephalic arch. Well, it is not a presentation per se. We have here more questions. Well, if I take the recommendations, if we talk about aneurysm, we'll see that everywhere we have venocephalic. It's brachycephala, fistula. We have many more of them. The stenosis is seen very differently. Sometimes we know about it, and sometimes we don't know about it. We see the development of brachycephal AVF. Sometimes it is the change of the blood flow. Sometimes it's fessy. We have turbulence that is evoked by valves, hyperplasia of intima that is evoked by pro-inflammatory protein, and so on. The clinical manifestation, usually it is aneurysm, extension of the head vein. Usually it is always there, but how to evaluate it? It's difficult. It is aneurysm or just aneurysm or not aneurysm. What's our attitude towards it? How will it develop? It can develop fast with some unpleasant symptoms for the patient, with thrombotic layers of aneurysm, with the skin changes. And it can be complicated by the bleeding, dialysis. We can see the issues during the dialysis, and the dialysis can be inefficient due to recirculation, due to high position. Whom do we operate? If we perform ultrasound diagnostic, usually it allows to diagnose stenosis or hydrocephaly. You see that the gradient, the speed gradient is more than 5. There are different criteria to confirm hemodynamically significant stenosis. It can be gradient, a CTAG, and angiography. Just a regular one. What do we see at CT? We see nearly everything. It is great methods. Do we perform it to everybody? Big question. Here we see an ultrasound picture, thin patient, and his cephalic is lower than clavicular. Sometimes the patient is obese, and sometimes cephalic has very big tortuosity, and then we cannot find it on the ultrasound. Talking about European guidelines say that all the reflows should be calculated in the patients with aneurysm. If needed, we should treat them. And it is better to use stent grafts. But it is all about symptomatic aneurysms. Symptomatic aneurysms restricts the approach to the cannulation zone. They say in Europe it is associated with pain, bad scarring process, and big expanding. This is symptomatic aneurysm, though we know that aneurysm can be 5 centimeters. You can punctuate it, it does not bleed. And, well, I don't know whether it's expansion fast or slow. As for American guidelines, they say that you should not touch symptomatic aneurysm. Same, we need to consider flows and struggle against the cause. Stent graft can be considered as a primary option. And we should not use common stents. And as for endovascular treatment, we have three options here: angioplasty, stent, and grafting. As for studies, we lack in randomized studies, especially for arch, for cephalic arch. And there we see the results between stent and angioplastic. In PTE, there are no patents, and in stenting, only 20% have this patency. One more study, 24 patients, stents against PET. Stent grafts, we see the patency is better. Fistula is preserved, or whether it can be used, or it's 100%, but cephalic arch stenosis does not always lead to thrombosis. It can exist for a long time. Then this aneurysm starts being thrombosed. The fistula is preserved. And meta-analysis, where we study stents, graft, angioplasty, grafts are better than stents, and stents are better than balloons. In 12 months, grafts better than stents and balloons, and in 12 months, stents are better than balloons. So stents demonstrate better results, but in 12 months, the patency between stents and balloons are the same. As for surgical correction, this is the common surgery when we see the suturing into basilar vein on the shoulder. We see the minus, the disadvantage of this method is you cannot perform the transposition. We perform the reimplantation and don't touch the basilar vein, but it's more traumatic. What do we see here? Here is a meta-analysis comparing open and angioplasty, secondary patency. We see on the second curve that open surgery demonstrates better results for secondary patency. But it's quite heterogeneous group of the patient. Which are our patients? Most of the patients brachycephal AVF have fistula. The symptoms, fast growth. Nobody knows what it is, whether it's fast or slow growth. Pain, if it is pain here, pain is a symptom indicating for operation. High resistance on dialysis. It could be 120, 140. 160, the dialysis doctor would say kind of high. Well, 200 millimeters. They say erythrocytes become worse. It depends on the speed. If you make the speed lower, the resistance would be lower. And we see that in no patient the dialysis quality suffered. Though circulation kind of draws to the decrease of it, but aneurysms are small. And we have time to change the blood changes. Recirculation does not appear. What do we say about this type of stenosis? The patient has all the shoulder in collaterals, and we still have these questions. Do we need to operate this stenosis earlier? We have worse long-term results. Should we start it? Surgical intervention. It has good long-term result. Probably we can find some criteria. And the point is, if there is stenosis of cephalic arch, it exists. We can treat occlusions in these patients. For example, there is occlusion from the cephalic arch. It's a rare case when a patient had the edema and he has no issues with brachycephalic issue, high resistance. And we see that 350, 400 millimeters mercury, it is really high resistance. You see the moment of the entrance to the occlusion and exit of the occlusion. Rod runner driver was by Cook. It is very comfortable because its tip is 18 and the guide itself is 35. It is quite hydrophilic. It goes well through these lumens. The angioplasty is performed with 7 millimeters balloon, and we get good result. Well, what's wrong with the second picture? In 2 months, well, the patients again had some problem with aneurysm, with angiography. We see that the patency is still there. Angioplasty was performed again, but we see that there were less of symptoms. Thank you for your kind attention. Questions? Does anybody have any questions here? Thank you. The next presentation, endovascular recanalization when we create permanent venous excess. Dear colleagues, few words about younger patients. They also have the problem with the vessel excess, and they are growing, and when the central venous excess device are set of any excess with whatever cases of hospitalization are there, both in adults, the number of devices is from 5 to 25%, and it increases because we have aggressive therapy in nearly all fields. In 15% of cases, there is thrombosis associated with the devices, with the venous devices, and in about 10% of these children require surgical or conservative treatment. In the last 6 years, we had about 450 children in cath lab who required cath lab to have the central venous catheters. Mainly these were PICC lines or tunnel catheters for hemodialysis and other types of excess. The age of the patient, the children, the newborn 15%, first year 45%, and then we have easier cases from 25 to 15%. So if we talk about venous excess, small age and weight of children, early catheters in history, thrombosis and post-thrombophlebitic syndrome, and the inclusion of superior vena cava. The methods that we use to set the central venous catheters, they're small needles, and introduces up to 0.018 inches, angiography, and for catheterization of central veins and right atrium, the collateral vessels, it's more difficult for children than for adults. For this, we use neurosurgical methods, and microcatheters, and coronary introduces and guides. And recanalization is used sometimes. We have 35 successful recanalizations and less than 10 unsuccessful attempts for recanalization. Coronary introducers are used, mainly we use Shinobi, then either balloon angioplasty or Bouge. Few examples here, few clinical examples. This is an attempt of collateral processing of PIC catheter. This is a 3-month girl. We see thrombosis at the upper part. There is also thrombosis. It was decided to perform recanalization, but it was not successful, and it was decided to use collaterals, to use PIC catheter through the shoulder. It goes to the inferior vena cava. This is a case of recanalization. 1-year-old boy. You see the diagnosis. The central venous catheter were placed here. After the vena basilica puncture, catheterization and balloon angioplasty was performed with the placing of central venous catheter. Here is a more complicated case. 5-month boy, 4 kilos. First attempt was recanalization and puncture for vessel access from the top, right and left shoulder on angiograms on the left. Then it was decided try to go from the bottom. It was thrombosis, and collateral approach was used through vena azigus to the superior vena cava with the catheter. In 2 months, this catheter became infected, and were called to substitute, to change the catheter. And we see here, we performed angiography here. We performed attempt for canalization of iliac segment, femoral iliac segment. We see angiogram with a balloon catheter, and we see recanalized inferior vena cava and iliac segment where catheter was placed. And here is helothorax boy, 2 months from the first day of life. And when he was 2 months, he was thrombosis of the branches of superior vena cava. They addressed us with the attempt to recanalize the vena cava, to occlude helothorax, and to reinduce central venous catheter. We see here a recanalization on the left side, after which we see different stages of recanalization, and on the last place, the result of recanalization, where we see the patency of the next vein, where see the improvement helothorax situation. We see the decrease of helosis in drainage. In few days, we performed recanalization, and it is presented here in the helos. We see 2 interventions. We see the start from the elevation, and then there is decrease. We see the decrease of helos. We treated helothorax, and this is it. That's it. It was really, really good. Questions? These are 3-inch catheters. These can be. These are like oncological. These are peripheral implemented catheters. As I mentioned, these are PIC. These are not for dialysis. This for treatment of different diseases, oncological patients, the patients from intensive care unit, and so on. I'm just I understand. Well, let's proceed. Endovascular intervention with the acute occlusion of AVF for extracorporeal dialysis. Hello, dear colleagues. Let's discuss acute occlusion. Well, we see as we see more patients on hemodialysis, we see more thrombosis of fistula. We see that the frequency is up to 4% in the first 30 days of fistula work and up to 16% during the first year. Why thrombosis appears in remote post-op period is issue with hemodynamic, and we see the stenosis due to hypertonia. It can happen. Some patients during the night have this issue due to pressure that leads to acute thrombosis. Up to now, we have the discussions which tactics should be chosen for fistula treatment, especially for occluded fistula treatment. We know that there are surgical methods, and the success is up to 90%. Endovascular methods, including selective thrombolysis. But now selective thrombolysis is nearly never used. Combined methods are used. Thromboaspiration, mainly rheolytic thrombectomy, but it's quite expensive methods, and it is not very particular situation with the angio system, as it is quite expensive. We see that neurointervention is being developed now. We see lots of aspiration catheters of big diameter that can be used for thromboaspiration, and we're getting good results as the combined methods, the selective thrombolysis and balloon. We use the combined tactics for thromboaspiration and balloon angioplasty. The hybrid approach mainly is used in the patients who has acute occlusion, mainly of the central veins. And first, the surgical method is used to correct the occlusion, and then balloon angioplasty is used for the correction of the central veins. I will not talk too long here, as it was mentioned already. All of the disposals are very expensive and very specific. It is very important to have balloons, high-pressure balloon, cutting balloons, drug-eluting balloons. Sometimes we use catheters, microcatheters, expensive catheters. There are lots of studies that were organized for fistula treating, and there is a big meta-analysis, including many patients. Noting that surgical methods in long-term period is better. But in further randomized studies in 2004, endovascular results, endovascular surgery demonstrates good result. My opinion is it is associated with more modern devices and more endovascular interventions are used. This is a big Sweden study with surgical intervention. It included 9,004 patients, and it is to be noted that initially, after the surgery, there was no difference between surgical and endovascular intervention. In 90% of cases, the success was achieved. But then we see that the patients with endovascular intervention have better result. It is also noted that fistula work after endovascular intervention is longer, though the difference is less than 5%. In our hospital, we're waiting for. We started performing it starting from 2023. Most of the patients come from different regions, from whole Moscow region. In 2023, we had 22 patients, 13 patients with acute IVF occlusion, up to 5 days of the occlusion, 5 days acute occlusion. The clinical aspect was achieved in 12 patients, and we evaluated the patency in 30 days in 10 patients, and the patency in 90 days. Also, it has not changed. And let's see a few clinical cases. This is a patient who came after he came to hemodialysis. It didn't work. He came here. We have acute occlusion. We set the introducer, made 2 fractions, and we got good result. It's the same patient. Here we used guide introducer. We use here radial access. We see here some complications, but aspiration catheter is easier to be introduced here. Well, here the patients have acute occlusion, but also there is stenosis. Aspiration is performed. It removed thromb, and we get good result. And that's an interesting case. When we took this patient, the patient could not explain, and the nephrologist did not explain either. There was an attempt to perform dialysis in 1 day. He came here, and we saw the occlusion. There was thromboaspiration, balloon angioplasty, and big thrombosis was seen. We introduced vessel surgeons. All the surgeons were busy. We don't have that many of them. And we decided to start using inhibitors and wait. And we think that it is a good result. We still have thrombotic mass in aneurysm and fistula. Anyway, we followed it. It worked for the 2nd day, and in 90 days it continued working. Thus, we can say that endovascular treatment is safe and efficient, but the tactics choice should be individual for each patient. We have to have interdisciplinary approach, and in each clinic, most seasoned surgeons need to perform it, and those who have all the materials to perform it. And the tactics would provide us with most successful tactics. Thank you. Thank you for your presentation. Well, the fistula must be saved. The fistula must be saved, but it is not happening everywhere. Any questions here, please? Well, the book is disappearing. Thank you so much. And the last presentation, subsystem. Everything is simple, everything is complicated. Hello, dear colleagues. I'm happy to see you here. It is very special part, and I always say that there are 2 categories of the patients: dialysis patients and onco patients.
So today we'll be talking about the second category.
Просто все так сложно. Вау, простите, чуть не сказала дальше. Я представляю Гусевскую центральную районную.
I represent the Gusev Central Regional Hospital in the east of the Kaliningrad region. Those who haven't been here but who were here a long time ago, like you, Shamil Mugavedovich, welcome. Well, there are many types of ports, different in shape, size, but in fact there are not so many of them. CT MRI compatible, and also the size of the port depending on its height. As for port systems, we got acquainted way back in 2020 when the regional hospital was closed for COVID-19. We were told to make a port. In principle, we looked through the literature, nothing difficult, but at that time we noticed that there is the American and European statistics on implantation of port systems and chemotherapy. And 95% of chemotherapy in foreign countries start with a port implantation. We don't have this kind of statistics, but the situation is diametrically opposed as far as I know. Well, here are indications. Well, we can place a port. Well, you can see relative contraindications depending on the qualification and the wish of the surgeon to participate in port placement. And we started with the implantation of the classical port system using the subclavicle access, which is a classical one. But when I'm hearing hemo or pneumothorax, in case of catheterization of the subclavicle vein, I have a kind of fits of panic. That is why the heads of our X-ray service, Dr. Agarkov, decided to develop angionavigation using ultrasound. We do the puncture of basilica cephalica. We prepared the angiomap. Also, we checked the vessel patency, and then we implanted the port. It was rather simple. We've had 30 situations like that when we came across the first complication. That's the rupture of the tip of the catheter and its migration to the right atrium. Of course, we cleaned up everything behind us, but still we had this situation. We understood that we do not know anything, and we decided that we need to go into details to read more about such situations. And we tried to study different clinical guidelines related to the venous access. There is no consensus regarding how the port should be implanted and what is the best way of port implantation. There is no advantages of any algorithm when we switch over from the subclavicle vein to the jugular vein in case of the high risk of pneumothorax and in case of the use of the venous access for more than 3 weeks. Well, the advantage is given to the jugular vein. Also, in clinical guidelines, well, we found out that the operating room must have the ultrasound and an angiographer. Well, a C-arm is enough, but in some methodological guidelines on the central venous access, the lack of ultrasound in the OR is the contraindication for catheterization. Well, why do we need ultrasound? Ultrasound means navigation. Ultrasound means the venous puncture. Well, the needle and the guide, and if we do this on the eve, well, we can encounter with the thrombosis of the jugular vein. Well, and here you can see it's not just a thrombosis, but also the venous regression of the vein. If we trust ultrasound, we won't encounter such a complication as catheterization of the jugular vein. It ended up well in this case. Well, but nevertheless, this case, well, added up a lot of gray hair, as we call it. Well, you can do it under the control of the ultrasound. So why do we need angiography? Well, in this case, we can see where the tip of the guide is, because sometimes when it can be in the subclavicle vein using the jugular access, oncologists say sometimes, well, the catheter was in the jugular vein against the blood flow, and they just discovered it when chemotherapy started, and when patient had a severe headache, then they did the X-ray. Also, and when we place the guide under the control of the X-ray, we look whether the catheter passed or not, especially from the left axis. You all know the anatomy. Sometimes the catheter doesn't go the trajectory we want it to go. And another important aspect is when we position the catheter, we just know what the length is. Well, we try to avoid tortuosity. And here you can see the permanent catheter. But the X-ray or EOP is needed to see whether, well, it is in this vein or not. And again, well, you can see there might be the preliminary stages, fixation with ligature. And again, here you can see the disposition, and the tip can be in the azygous vein, which is also bad, especially patients with cachexia, with asthenia, with not enough subcutaneous fat also. And I saw it for the first time, and I hope it was the last time, the situation when the port turned over after 1 month after the implantation. That's not bad. Well, you can see the video how we detected this, and again, the X-ray does not show us that the port turned over. Well, another important aspect is the selection of the optimal size. Well, of course, we understand the economic factor. Unfortunately, we cannot have a range of different ports, so we prefer low-profile ports of a small size to avoid the situation such as the sore spots of the patient with asthenia half a year later, as you can see here in this picture. Well, thrombotic complications, remember about them, and also the secondary prevention of venous thromboembolism, especially in patients with cancer. Also, chemotherapists, medical oncologists should use the Haran scale, because the chemotherapy course may end up now, but chemotherapy in fact continues, and oncologists even have such a concept. At the end of the diagnosis, well, they might write down the patient is in the process of chemotherapy. Anticoagulants will be administered for the entire length of chemotherapy, for example. The patient must be properly trained, as well as the medical staff, on how to use the port system. And first of all, you need the right needles, such as the Huber needle with the slanted tip. In this case, the port system will serve longer. And these are very simple rules written into guidelines, and we usually just give the patients a memo like how to use this or that particular system. So there is a brief instruction for the patient. Right now we use the port systems with the heparin lock. And again, we have a lot of patients, and well, if we explain it to the patient how important it is, I think the port will serve much longer. Well, as for conclusions, for successful results, we need the ultrasound and X-ray. Also, we need the proper examination on the eve of the surgery. It's a planned situation. And of course, we must remember that we need the port yesterday, as we say, the selection of the optimal port system. Remember about the preliminary stages. That's why we have, well, ultrasound, X-ray, well, and also try to popularize the port systems among medical staff and the patients. Here you can see a female patient, one day before the operation, 1 day after the operation, and 2 months after the operation. So the snake, the tattoo, did not suffer, as you can see here. How important is this tattoo for you? She said, it's not important. I just did it 1 month ago. Thank you very much. That's our team. Well, and probably I will be punished for this picture. Thank you very much. Thank you for this great presentation. So we decided to ask questions at the end, right? Everyone is hungry, I guess. Well, could you tell me, please, when you implant the port system, the device is small anyway, but you will implant it. Well, do you use anything for thrombus prophylaxis? And do you administer antibiotics? Yes, I administer antibiotics in any case. Any surgical treatment, well, 30 minutes before the surgery, we administer antibiotics. That's a law. Thank you. Do you use Huber's? Do you give patients Huber's needles with them so that they could take them with them? Well, Huber's needles, yes, we did it in the past. We gave Huber's needles to the patients, but right now we ran out of them. We don't have enough such needles, but now the answer is no. But I give them the instructions regarding what to do. All right. Let's say we have a patient with thrombosis of the arm. What is your tactic concerning these patients with the arm thrombosis? Should chemotherapy be continued or not? Well, maybe to remove the catheter. Will you continue with chemotherapy? Yeah, I got you. Well, that's a patient, and you can see on ultrasound that the thrombosis of the jugular vein was above the connection with the subclavicle vein. The port system is patent, but oncologists, well, canceled chemotherapy, but I started the typical treatment in case of thrombosis, but the port was not removed. No, the port was not removed, and the superior vena cava is absolutely intact, right? And well, it's kind of descending thrombosis, so to say. The situation was unpleasant, but anyway, everything was linked to chemotherapy, and, well, maybe they didn't use the coronary scale to do the calculations. And any infections because of ports? Not a single case of infection, not a single case of port-related infection here. So, especially when patients are on chemotherapy, if the port is placed the right way, and if you observe, well, the antiseptic conditions, everything will be okay. We hope soon there will be dialysis catheters that can be introduced under the skin, and then you can cross yourself. Just the last question. It's a practical question. We had a case when the port turned over. All right. Maybe you can relocate the port and leave it in place. And I saw that you have the angiographic control. Do you do it routinely, or you use anatomical landmarks in order to determine the length of the catheter? Only angiographically. All right. In all cases, yes, in all cases, we have the cath lab where I operate, and we use this under the ultrasound and under the X-ray control. I mean the introduction of the contrast. Well, where the tip is located, to find out where the tip is located. I'd like to dye the catheter to see where it is. So I use the contrast media. Well, the contrast is diluted, and I usually do the creatinine test. As for your first question, well, I did not give you a lot of information about this patient. Well, I will do it very quickly now. There was the subclavicle access during the implantation, and the clavicle was damaged. Well, you could see it on X-ray, hyperemia, and of course, we could not talk about any continuation, so we removed the port, and then we did the repeat implantation. So during these couple of days, we administered the antibacterial therapy. We had a breakout session on fistulas, and many speakers said that the major problem with fistula dysfunction are multiple catheters. Well, and well, for you, when you select this clavicle access or jugular access, well, can you just to try to avoid such situation? What access is better? The jugular vein is better. We do not use this clavicle access anymore. In permanent catheters, well, it's the jugular access, not the subclavial access. Well, you can take the guidelines on vascular access. Everything is written there, okay? Where you should do the puncture. Well, we should wrap this up. Thank you for your questions. And just one brief question. Where did you get the clinical pharmacologist? We don't have it. We don't have this person. Okay. Maybe I misunderstood you. Success to your wonderful team. Thank you very much. And let's wrap this up. Well, again, now we made a decision. Could you nudge our colleague? Well, he is the most active participant, by the way. He asked a lot of questions, and he will get the award for the best question. It's the book. We need your personal information, and Extern Media, the company, will send you the book and the atlas. Thank you very much, and good luck. Thank you for this breakout session. Everything was very interesting. Now we invite you to lunch. Lunch is on this floor, and all.
It's just some question that does not require any answer. Well, the middle aneurysm is the neurosurgeon's field. It is neurosurgery, and we will start from the very beginning. In 2011, there was a publication, aneurysm located at the middle cerebral artery bifurcation is still a neurosurgical indication. Later, there was a publication that analyzed several of the information. In 6 years, only 30 aneurysms were treated, and from 1995, there was very severe patient selection. Here we see two issues, two particularities of aneurysm complication. And we see what is the result of the treatment depending on. It's first and foremost the surgeons, and the material should be neuromaterial, not cardiomaterial. After having worked 2 years in X-ray surgery, we have to use neuro and angiography placement, because for today the optimal requirement for neurointervention, we have Philips and Siemens and Shumatsu. We see that they are losing the quality. We see that the visualization improved. We have 3 and 4D. And lots of neuro instruments are developed, stents, balloons, and the systems to set it into aneurysm. And the publications of recent years are changing. And the usage of stent, even in this session, allows to achieve radicality compared to microsurgical clipping, having low frequency of lethality, talking there and about the anatomy. It is the anatomy. They don't know the anatomy of the brain. We want to deal with the stroke, but we don't want to know where it is response from. We see that most commonly these are aneurysm of the body of M1 LSA segment and aneurysm of cerebral artery. We can talk about surgical treatment of the aneurysm of this organization. Microspirals are possible to be used only if we have favorable geometry. Fortunately, most of surgeons don't know that we calculate 2 indexes. We calculate height and neck, it's aspect ratio, and it is the definition of the favorability of the geometry and microspiral. We have 4 main types of bifurcation, because using this point D, we would want to put here the stent, but the stenting here would be associated that on the overflexion 180 degrees, it would not open. Most of the stents are the closed stent stents. And here, it would be the problem with the stent and the problem with the blood flow. If it is M2 segment, We see the stent is introduced into a M2 segment branch. It is a favorable case. We see that depending on the stent structure, with the open cell, closed cell, with its dynanet and so on, we see with the under expanded where we have overbinding, and it influences the radicality of the surgery. It influences hyperplasia. That's why we need to the balloon assisted methods is good in acute bleeding situation. Here is a patient with vasospasm, with aneurysm rupture. We nearly don't see central cerebral artery, severe vasospasm, and we see a small aneurysm. And on this angiography, we cannot evaluate the true size of this aneurysm. When you understand that spasm is so severe that it stops the blood flow in the central cerebral artery, when we perform the dilation, and we see that an aneurysm, and it allows us to close it with balloon assistance without rupture, to perform balloon angioplasty. Thus, we see good angiography result. If we talk about other devices, this is conus, P conus. Initially, the crown is placed inside aneurysm, and further on, step by step, it is dragged to the neck, and the cone stands here, and you see how it moves. It protects the branches. Further on, we see the spirals. And we see that we use the flow changing stents. It is all combined with microspirals. The question is disputable. It is not the method of choice. If we use this stent, nothing will be there. We will not be able to operate. We see the fusiform aneurysm 1M segment that was switched off with the usage of anastomosis, proximal occlusion, and artery. In this case, the catheterization was used. Why am I demonstrating it? Because it's a rare case, not so many. Only a special neuro instrument allows catheterization of this tertiary system to achieve aneurysm and to set stent there. The surgery was performed. We see that in recent years we have intra-aneurysm, different contours. Contours being registered. It stays near the neck. It is presented here on the slide. I also made a picture of this slide. We see here the results of all these manipulations that exist today with the frequency of complication for a long-term period. And all our surgery is, of course, not safe. The middle cerebral artery is a difficult place, and it was decided to set here the P cone and to close on it. And we see here that in this case, there is rupture on implantation. We see how contrast dissolves here in subarachnoidal space. And after that, in this case, to conclude, we see that there is a shift in paradigm of treatment of aneurysm and the developing of 3D technologies. And it allows us to achieve these results. If we don't fulfill it, the result is not really favorable. Thank you very much. It was very clear. The question is of the mic. The question is of the mic. Question is of the mic. Question is of the mic. How many coronoplasty you should do? How many coronoplasty you have to perform? How many? 50. 50 per year. 50 per year. 50 per week. 50 per year or 50? Well, standard multi-profile stationary 1500 angioplasty. 50 surgeries. Okay, 100 per year. 100 per year. It's enough. 50. It's not enough. It's not enough. And there are complications. And there are disbalance in different stationaries where we see it. To achieve some result where endovascular surgeons can do it. There are always some issues, either endovascular surgeons or other surgeons. It's some 100 endovascular intervention. Well, we see plan. We're unique. We're absolutely unique. Our hospital, because we work on neuro, on the insurance base. How? So the question is about the insurance. How is it paid for? It is in insurance. It is in the state insurance. There is certain tariff. Because you work according to DRG, drug-related groups, not insurance tariffs. The question is of the mic. The question is of the mic. Neurosurgeons will not disappear, The question is whether a surgeon can. I'm a neurosurgeon, and within one part in the Polenov Institute, we were clipping, we were embolizing. And I think it is a good idea, it's a good idea. And now we're growing nobody. When you leave your expertise, Mikhail insists. Mikhail couldn't have asked any. We see that there is endovascular disbalance. And there is when we see the losses in the microsurgery, there is certain difference between localizations. Most of the patients in Central Russia want endovascular surgery. It is a method of choice, we see now. There was one more question. The last, please. The question is of the mic. The question is of the mic. Here, together with Sergei, we developed this topic. We have few papers published. Well, what do? Actually, we violated the legal basis of the Russian Federation. If we see that we need to set the stent in the acute state, no other variant, we set microcatheter into aneurysm for stent implantation. Then inhibitors of glycoprotein receptors are introduced in bolus. I introduce half of bolus dosage. Then heparin, 7.5 thousand heparin units for the near 6 minutes. It would be 1,000 units per hour with a total aneurysm closure. And then with the control of prothrombin time and after awakening, the patient gets Berlin 180 milligrams. How do we do it? If it is an acute period, we don't put it on pair. I take responsibility on myself and I write in the protocols that I use the inhibitors of protein receptors. The question is again of the mic. Agrostat, whether it's coronary or neuro, the next presenter is how to cope with a gigantic aneurysm in the carotid artery, or your advice if you are screwed. Thanks one more time that you are with us. At the moment when we see this wonderful aneurysm that you see here, this aneurysm of the left internal carotid artery, there was tortuosity of the artery. I saw a lady, 61. She came to the ENR physician, and patients come to the consultation, and ENT says, you have abscess, we will puncture. They get some fluid into their face and they don't know what to do. Here, ENT doctor was clever. He saw this kind of pathology. When he saw this pulsing bulb, he called his friend. We perform angiography. We see here aneurysm that has two knees. of septal tortuosity with septal stenosis. And here there was a discussion how we remove this aneurysm. If we switch off it from the blood flow, it's obvious. Any type of traumatization will lead to the implantation of the stent, open clipping, or implantation of coronary stent graft. Please vote for the first. Yeah, Mikhail, you had a different opinion, I remember. Second point, open intervention. Open intervention, vote for open intervention. The implantation of coronary stent graft, Bentley. Dr. Kiselyov is too timid. The first question. Yeah, that's expensive. If you see, when you check the CT, everybody says, okay, we will perform wonderful surgery. We will resect the jaw. It will be open. You know, it would be some not aesthetic, but the excess would be wonderful. At this moment, the vessel surgeon became alive. I told everything the patient, and she says, well, I have no choice. And the vessel surgeon, it's so dangerous, so dangerous, so dangerous. So the vessel surgeons were pouting, and I said, okay, let it be stent graft. Cerebral angiography confirms what we had on the CT. I think it was dissection. The lady works at TRAM, so it's difficult to understand etiology. Probably you can say the balloon. Or if you do compression, yes. Mikhail Yurievich has a favorite operation, destructive embolization. So we use Povolodyukhin, and we are sure. So if we compare it to the jaw angle, it's too deep. The pressure probe, it's too dangerous. We know that there is blood supply for the artery, for the cerebral artery. I don't like destructive interventions. I always want to restore as it should be. It should work as it's thought of. So in our case, coronary stent graft, Bentley stent graft. Well, that's what we were preparing for. And you see it got broken very fast on the left angiogram. It's an attempt to set a stent graft. We set the stent graft, and we will have the stent grafting. And it was in the segment where we see aspiration catheter. But to drag aspiration therapy from the delivery system was impossible. We thought that this company of aspiration catheter does not allow us to work. We took the different aspirational catheter. We cannot draw it down. We see here we have 35th guide, and the artery would not straighten. And when we had 35th guides in C4, for example, it was impossible. All our manipulations led just to the situation that Bentley did not survive. You know, spare parts of Bentley are very bad, and we didn't success. So, Chile catheter broke immediately. We used destination. The different introducers with the different stiffness. Coronary graft, Bentley. And at that moment, we decided Bentley is not good. We need to take Rolls-Royce. Vitaly was pushing me towards this type of stent graft. He was suggesting to me to set the full stent there. And Vitaly Sergeyevich has a great experience in implantation, and he said, yes, I will help you with the implantation. Next day, and 30 minutes, our golden key here, aneurysm starts stagnating, no problems. But why I say that the shrewd pays twice? And you remember there was 150 minutes, and after 45 days, you see there is space now, and we see that there would be CT, and we'll see it all on CT. All the tools, if I had all the tools, it would be possible to do it in one day. But, well, it's utopia, but it would be great if I don't think about the price or the tools. So, Minister of Healthcare, don't save your money. I think you asked me all the questions. Well, one question, just one question. At the neck, is it a good idea? It can get broken. Well, we did duplex, no deficit. When we have postponed results, I'll demonstrate it to you. Well, talking about safety, talking about safety of the stents in the neck, the problem is the only one. We don't have enough of the diameters. On this segment, it is very difficult to set the flow stent here. We have 6 millimeter stent, and only Arkansas have this first stent. Well, it allows it to do it somehow, but whatever we were putting there, we had stent migration. That was a problem. That was, and well, as for me, I would insist to set the Kasparov stent. Well, I'm absolutely sure I was there. Wall stent would not enter it. Well, the point is that Kaspar's profile, I don't think it's smaller than Bentley profile. It was overpressed, we bent. If there is some inflammatory reaction in two cases, it would not straighten, and it did not help at all. Thank you. Thank you. When you have this probe, what would happen if it did not keep it? Nothing would change. I think it is just historical case. It's a historical case. Sometimes destruction is the only method. Let's proceed. Let's proceed. We have broadcasting and people want to ask questions. Hello. That was a great presentation. I listened to it. I will not take lots of your time. I'll talking about aneurysm. We have a good experience about 10 aneurysm we operated. As you know, we started straightening them for more than 2 years already. And combined with aneurysm, it can be treated with Casper. It is straightened and aneurysm is closed. And the other stent is carotid stent. And you close aneurysm.
Well, before this, I voiced this issue as well. I don't know if you heard it or not. Well, I'm ready to say with the full responsibility, the wall stent will not just get in there. We have a lot of wall stents in our cath lab. Well, Casper will get in without a problem. We can check it right now. Next time, okay? Well, I think they will prepare the delayed results, and I will show you the results. But we should also compare the passage angles, to what extent the carotid artery is, well, movable or not. Well, we cannot just look back, but we would like to look at the final results of your operations. Thank you very much, but we'll have to move on. When the stent is favored by anatomy, stent-assistant embolization of a cerebral aneurysm. Dr. Kamil Isayev, St. Petersburg, please. Well, good afternoon, dear colleagues. Today I'd like to draw your attention to several cases when the stent-assistant embolization of cerebral aneurysm is being used. As of today, there are different methods of embolization, different instruments. Well, you can see them here, and quite recently there was a meta-analysis published, stent-assistant coiling of unruptured intracranial aneurysm with wide neck. The technical success was about 98%. As for long-term results, well, you can see from 2 to 6 years, well, the aneurysm amounted to 60%, 60. The frequency rate of restenosis, instant restenosis, 1 to 2%. And also, you can see recanalization of aneurysms wasn't 7% in this category of patients. Well, here's the first clinical case. We had a patient with aneurysm, well, of the carotid artery, and here you can see the posterior connecting arteries, which were very well developed. We used them. The microcatheter was placed in the aneurysm cupula, then through the posterior connecting artery. The catheter was placed in the posterior cerebral artery. From that, we implanted the stent. There was the aneurysm, and the aneurysm was removed from the blood circulation system by implanting a coil. Well, you can see also another case. Well, the main artery aneurysm with the wide neck. Again, we did not have such a posterior connecting arteries as in the first case, and here we used the Phoenix stent, Epiconus by Phoenix company. Again, you can see it here, epicone in the form of the flower. The pastels are located in the body of the aneurysm, and the stent body will be extended in the main artery. It was implanted, and you can see the middle of the microcoil. The structure is very stable without any obstacles. Well, the coils were placed and the aneurysm was just removed from the process of blood supply. Here is another clinical case, case number 3. Well, M1, M2 segments, the middle cerebral artery. Here we took a different approach. Stage 1 was stent implantation from M1 and M2 segments, but here one stent was not enough. We implanted 2 stents using the culotte method. Well, then through the stent, a micro catheter was placed, and again, we had a very stable neck of the aneurysm, and then we used microcoils to just switch off the aneurysm from the blood circulation. Here you can see the angiography result. Here is case number 4, the patient with the aneurysm of anterior connecting artery, and here you can see the anatomical peculiarities such as anterior trifurcation. Like in the previous case, using the culotte method, we implanted the stent, and then we switched over the aneurysm from the blood circulation. And here you can see angiography control the picture. The next clinical case, number 5, aneurysm in the area of the bifurcation of the internal carotid artery. And here we used the anatomical landmarks with a very manifested anterior connecting artery. Through the contralateral side, we placed the microcatheter. We implanted the stent from the M1 segment, and then we switched over the aneurysm from the blood circulation. Here is our clinical outcome, and as Vitaly has already noticed, not all endovascular procedures can be without any peculiarities or complications. Like in this clinical case, which is the last one, number 6, the patient had 2 aneurysms, M1, M2 segment, and the bifurcation of the internal carotid artery. First, we decided to switch off the aneurysm of the internal carotid artery. Well, here we used the deroga through the anterior connecting. We planted the stent, and then we switched over the aneurysm. The post-operative period was without any complications. Well, again, you can see a very good angiographic picture when the procedure was coming to an end, when the patient was extubed, when the patient woke up. The patient had a neurological deficiency, weakness in the right arteries, facial asymmetry. Here is the control CT, and this is what is the picture. Well, you can see ischemia in the area of basal nuclei on the left, and we decided that the problem here was that during the stent implantation, the kinking of arteries was quite significant, arteries coming from the M1 segment, but that the patient had been monitored for more than months in our inpatient hospital. When he was discharged, there was a regression of the neurological deficiency, and all that was left is light dysarthria. Thank you so much. Thank you, colleagues. Just one question from the audience, not more. And use a microphone, or the interpreters will be very upset. Thank you very much. Did you use the balloon to optimize the stent? No, because during the implantation, after some time, they will be optimized themselves. They will be fully expanded. And well, so here we did not use any balloons. Well, usually they have very thin cells, and these stents are being expanded very quickly. If I'm right, it was neurophone, right? Yes. With open cells, there is nothing to inflate, right? If you had closed the cells, that would have been a different question, right? Neuroform, right? Yes. We used neuroforms, right? What about anti-aggregant therapy? What is our tactic? These were all scheduled patients, elective patients. Well, several days before the surgery, we use ADAPT, dual antiplatelet therapy, and then we do the intervention after several days. And what do you use as ADAPT? Aspirin plus Plavix, all right? Aspirin plus Plavix. And all right, in this case, is there the possibility of the thrombus formation on the walls of the stent? When you showed us your angiographic picture, it's quite possible, but originally, and that was the last clinical case, number 6, the patient was on Brilinta, on this drug, and, well, like in case with Plavix, it was difficult to check, but in the post-operative period, we are trying to administer DAPT. Well, usually it's heparin and Brilinta, but we didn't have any problem in this case. Well, Camille, well, clamping of the middle cerebral artery is usually done, but why did you decide to choose embolization? Well, as you've rightly noticed, Dmitry is for the neurosurgical intervention, but, well, in our practice, there are cases when a patient refuses it. So it was the case when the patient chose the type of intervention. Yes, because the middle cerebral artery is very convenient in terms of the neurosurgical access, and clipping is more favorable for a patient. All right, let's move on. The next presenter is from Moscow, stenting and the transluminal balloon angioplasty of the venous sinuses of the brain. Daniel Gitozon. Dear colleagues, let's talk about other important vessels of the brain, that is venous sinus. Well, the theme of my presentation is stenting and transluminal balloon angioplasty of the venous sinuses of the brain. You can see D phlebography of the venous sinuses of the brain. That's the most optimal method of diagnosis. We can see stenosis here of the longitudinal sinus. Well, quite recently, way back in 1995, there were the first publications about the first cerebral phlebography by King. In 2002, the first publication of stenting the venous sinus by Higgins. In Russia, we do not do such procedures all too often. So what do we have here? At the initial stage, there is the thrombosis of sinuses, then different infectious diseases or adhesions, when, well, the dura mater can cause the formation of thrombus, or stenosis or occlusion of the sinus may occur, and then we administer optimal medical therapy and do the endovascular circulation, balloon angioplasty and stenting. We use the nitinol stent. Well, you're all aware of them. Most often we use Casper stents, which have already been mentioned. It's mandatory to do the pre-dilatation and post-dilatation of the stenting areas. This slide shows phlebography before and after stenting. I'll try to launch the video. Well, no effect. Okay, you can see the destination catheter in the lumen of the left jugular vein and the staining of the longitudinal sinus. Unfortunately, I cannot launch the video. Well, you can see the results after the procedure. Again, you can see the destination catheter in the jugular vein, the guide. Just a minute. And the implanted stent in the transverse sinus with the transfer to the sigmoid sinus. Just a minute, I cannot just switch slides. I cannot advance slides. Well, a good method is the intravascular ultrasound, IVUS, to determine the stenosis of the brain. At our department, at the Department of Surgery of the Hematology Institute, we've had 44 repeat procedures. And you can see an increase in the number of procedures since 2022. It's because of the spread of COVID-19. All these patients were included in the study. Here you can see the results of our study. We compared only balloon angioplasty of sinuses of the brain and the balloon angioplasty in combination with stenting. The results were quite significant. The differences were quite significant. After half a year, after 6 months, when we used only balloon angioplasty, the patency of venous sinuses accounted for 10%. 10. In stenting and balloon angioplasty, it was 96%. Thus, stenting of the venous sinuses of the brain is a minimally invasive procedure of cerebral hypertension, which occurs as a result of the poor venous outflow. Stenting and balloon angioplasty has advantages as compared to balloon angioplasty only. The use of self-expandable nitinol stents like Casper allows us, good approximation to endothelium, even in tortuous segments. Well, pain relief is important, as well as DAPT, the dual antiplatelet therapy. Anticoagulant and an anticoagulant, it must be administered 6 months before the procedure and 6 months after the procedure. Thank you very much. Questions from the audience? Unfortunately, the question is off the mic. Thank you for the question. As for indications for the procedure, all our patients had symptoms. First and foremost, dizziness, headaches, most of the patients. As for hyperplasia, phlebography, selective phlebography was performed. Of course, we looked at the dominant or non-dominant sinus outflow. If we see the even narrowing along the sinus, it's a hyperplasia sinus. If we see the lumen is good, the good diameter, and there is a critical stenosis or occlusion here, plus the family history, that was a different case. Also, there are different types of measuring pressure. We can measure the gradient before and after, but we don't do it. I have another question. You've had so many cases. What about the clinical outcomes? Well, because you just gave us general results. Well, since starting from 2012, we didn't have a lot of procedures. We had good clinical outcomes, so we continued doing it. And in most patients, up to 80%, there was a reduction of clinical symptoms, and patients returned to normal life. And what about ambothrombolia? These are not patients with acute thrombosis, okay? But did you have any cases with acute thrombosis? No. Did ophthalmologists see a patient? No, we didn't send them to ophthalmologists. That's one of the symptoms, but not all of them have it. MRI, an MRI is done. There is the aplasia of the left sinus in most patients, someone says from the audience. Thank you for your interesting cases. Could you tell me, please, as for anticoagulation therapy, what regimen did you use? Clopidogrel plus apixaban, the same as in case of stenting, clopidogrel plus apixaban for at least half a year. And one last question. What are the stent sizes? How did you choose the size of the stent? Or you used just the standard, 8, 9, 10? Yes, so we used the standard stents. What was the size? Casper 8 and 9. Casper 8 and Casper 9. And what was the length? About 40. Around 40, okay. So that's Casper 8 by 40 is the most widely used stent. Yes, in most cases. After the stent implantation, did patients have a headache because of the stent suppression on the wall? Yes, this thing occurred, but mostly when jugular veins are being stented. As for sinuses, there were also, headaches. But when do pain disappear? After 6 months, the pain dissolves. Well, it can be for several weeks or up to 6 months. All right, let's move on because we are behind our schedule. Mikhail Volotyukin, endovascular treatment of vasospasm in subarachidonal hemorrhage. I'll try to be quick. Well, this issue is very relevant. So what do we do? Endovascular treatment starts only for those patients who have the increase of velocity by more than 50 centimeters per second along the middle cerebral artery, or more than 200 centimeters per second. In this case, there is the indication for chemical angioplasty. Chemical angioplasty is done under local anesthesia, selective catheterization of the internal carotid vein, 1 or 2 milligrams of Nematop, and then the patient will be sent to transcranial Dopplerography. If there is no effect, we do it 2-3 times. If chemical angioplasty has no effect, then we use the more aggressive therapy, balloon angioplasty or stenting. Papaverine is not used in this case because papaverine as a drug is very neurotoxic and can lead to hypertension. A couple of clinical cases, a patient with the aneurysm, of the carotid artery, M1 spasm of the middle cerebral artery, embolization and chemical angioplasty during the procedure. At the end of the procedure, after the embolization, we can see the expansion of M1 and M2 after Nematop was introduced. Here is a more difficult patient, and you can see a arachnoidal hemorrhage. You can see the signs of the intracranial hypertension. Embolization was performed. Several days later, on day 4, the patient has an increase in velocity flow along the middle cerebral artery, which is indication for chemical angioplasty. Angiography shows the M1 spasm of the middle cerebral artery. We did the chemical angioplasty, and here you can see that Nematop allowed us to expand the M1 segment. The patient became a bit better, but then after cerebral transcranial Doppler was done, we can see an increase in the velocity. That was an indication for the second chemical angioplasty. M1 segment and A1 segment here are very well contrasted. No signs of vasospasm. Vasospasm is now in the peripheral arteries. M3, A3 segments. Chemical angioplasty was done, Nematop was introduced, but on day 8, unfortunately, the patient had the ischemic damage of the brain developed due to the peripheral vasospasm. That's not embolism after the first plasty. No. You can see it here. everything was okay, and clinically she was all right. You have to wait for 1 day, right? But during this day, ischemia can develop. Why do you wait for 1 day? Well, but that's local anesthesia. The patient will look at the clinical picture. Well, we did transcranially. If we see an increase in velocity, the patient is brought to the cath lab. All right, maybe it was a slip of the tongue. According to literature, chemical angioplasty is absolutely safe and effective. In most cases, well, we have a very good result, and the neurological improvement occurs only 60% of patients. So in some cases, there is a need to have more aggressive therapy, such as balloon angioplasty. Balloon angioplasty is used only if chemical angioplasty has no effects after 2 or 3 procedures, and if we see that the velocity increases by more than 200, the patient is moved to the ICU. The patient is being monitored. The patient is put on aspirin to prevent microembolization of distal arteries. And only when we have ischemia symptoms in cerebral arteries, only in this case, this indication for emergency balloon angioplasty, if the patient fell asleep and wakes up with neurological deficiency, then we do an MRI on this patient or MSCT in the perfusion mode. If it's ischemic and stroke, the same indicator. If there are no symptoms from ischemia, we do balloon angioplasty. If there is the wide lesion ischemia, in this case, we missed the train. Balloon angioplasty will be useless. We intubate the patient, and the patient is put on aspirin. Also, systemic heparinization, the guide catheter will be placed, and balloon angioplasty with the use of the special balloon catheter, like in this case. The aneurysm of the anterior cerebral artery embolization is done, manifested spasm, several chemical angioplasties, which were not successful. That is why when the patient had the neurological deficiency developed. The patient had balloon angioplasty done of the M1 segment on both sides. Here is another patient. He was hospitalized to our clinic from the vascular center. Aneurysm of the anterior cerebral artery, M1 segment, has a spasm. So because of the vasospasm, we decided not to wait, but to do balloon angioplasty together with the embolization of the aneurysm of the anterior cerebral artery, because here it's difficult to expect any favorable clinical effect from just one embolization. We did 2 procedures. As for the deficiencies of balloon angioplasty, the high risk of artery rupture, it's a technically complex procedure in case of manifested vasospasm. Just bringing the microcatheter balloon is difficult in case of manifested vasospasm. That is why in our clinic we prefer to use the so-called stent assistant angioplasty of cerebral artery using the stent retriever, like the temporal bypass, the temporal shunt. It's a relatively new method. Well, not so many publications on this issue. How do we do it? The same indicators as for balloon angioplasty. That is, the procedure is done when chemical angioplasty is unsuccessful and when the patient has the initial signs of ischemic damage to the brain. Technically, it's done under the local anesthesia. The guide catheter is placed, then the microcatheter is placed beyond the area of vasospasm. Then the stent retriever is placed at the level of vasospasm. Also, in order to enhance the effect, we used the push technique for expansion of the stent retriever. Nematop is administered to enhance the effect of stent assistant procedure, and several minutes after this, the stent retriever is put into the microcatheter, and we do the control angiography. If angiographically we do not see any effect from the use of the stent retriever, we repeat the procedure again. Never done it a 3rd time. So what about infusumab for half an hour? Well, I don't know, using it for half an hour in the cath lab. You have 3 cath labs, yes, but only 2 cath labs are functioning. Well, as for verapamil, we don't use verapamil because of bradycardia, all right?
Well, no. As soon as we have it, we even don't care. A few clinical samples, cases, 36-year-old patient, aneurysm of supraclinoid part of internal carotid artery, control angiography, transcranial Dopplography, 3rd day, 70 centimeters per second, chemical angioplasty is performed. Stent retrieval technologies, to our mind, have very high safety compared with stent assistancy. One fast question. Thanks for... And is it local anesthesia? Do you use local anesthesia? There's not balloon, that's stent plastic. Is that right? If the patient allows, of course. If the patient is adequate. Oh, better is general anesthesia. Better. General anesthesia is always better. You choose Y6, M4. Because? Just because. And we just stop on this word. Just because, Mr. Bolomatov, typical complications of intracranial aneurysm embolization. Dear colleagues, it's obvious that if we have positive prognosis in the patient with aneurysm, any aneurysm requires a surgery. No secret that any surgery can have complications, and there is either complication in place or not. And I would love to think through the complications that we face and how I see them. All in all, we can divide into 3 types: complications, hemorrhoid, ischemic, and complications that are not associated with aneurysm embolization, with a contrast and contrast nephropathy. More severe complications, hemorrhagic, intraoperation aneurysm rupture, arterial perforation and catheterization, bleeding, and the aneurysm rupture. Intraoperation rupture of aneurysm. And it is obvious that if we have extra pressure in aneurysm, it will be ruptured. And if you perform, we'd better avoid this surgery. But if you perform it, better we use the 5th G syringe. The next complication is a trauma with a guide or microcatheter. When you introduce the tool into the aneurysm, it damages artery wall and evokes the bleeding. When you use coils, when it's too hard, excessively hard coil does not take the shape of aneurysm and leads to its shape. Those who knows aneurysm processing, you know that the last coil is either excessive or this is not enough. To my mind, better we have not enough coils, especially if the person is not quite seasoned, and the arterial rupture that leads to the wall rupture. The arterial perforation in catheterization, it is quite rare, and it appears when we have perforation of anterior artery with the guide, or it is a perforation of the distal branches when the tool is introduced. To avoid this complication, angiography should be performed attentively and pay attention where the guide was. If you perforate the distal bed, distal branch, you'll have problems in early post-op period. So you have to keep in mind this complication. The bleeding, due to different reasons, it can be during the diagnostic angiography, or is associated with the increase of arterial pressure and spontaneous bleeding, and aneurysm rupture after the implantation. We have two cases. One is the increase of the thromb during thromb formation and its rupture. The second is firm enzymes lysis and just dissolving the wall of aneurysm. These complications usually lead to the death of the patient. Major bleeding in most cases lead to the death of the patients. To struggle with it, we can use big dosage of corticosteroids before the embolization. On Collins aneurysm, what do we do if you face in the OR this complication? It is the most severe what can be. We should not first be scared and not to do some extra motions, and don't run out of the OR shouting, please call the experienced doctor. First and foremost, do close the defect of the artery. You preserve the principle, one head good, two heads better. If you see this problem, you invite neuro team. In these cases, I suggest always to have the second doctor. Two more hands is always very important. Any bleeding, you always see the protamine reserves, and you always need to decrease if you have any problem. You have the patient under anesthesia, and you see the increase of pressure or increase of heart rate, just perform angiography. It can be associated tachycardia and hypertonia, can be associated with particularities of anesthesia. Nothing dangerous here. There would be no problem, not to worry. If we don't pay attention to the complications, we'll have more complications. But if you perform total aneurysm occlusion, if you have balloon, you will stop bleeding, closing the arterial neck. Then, of course, there is a problem such as aneurysm rupture. And here we have stent graft or total destructive occlusion of the artery with proximal and distal level. Nothing to do. Ischemic complication. Well, they are less severe compared to hemorrhagical. What are their reasons? there can be manipulation, spasm when we introduce the device during the acute bleeding period, thromboembolism from the catheter or aneurysm, or atherosclerotic plaque rupture, artery dissection, stenosis or thrombosis of artery due to the mass effect, and the spiral coils prolapse into the artery. Manipulation spasm is associated. It is the complication that is not associated and thromboembolism from catheter or aneurysm. Oh, here is the question on the ecosystem of washing. If you don't have possibility to do it, you can use regular washing of the instrument. You just use it regularly. Well, if you are not cautious working with the tools, if you damage the plaque or the artery wall, that can lead to the distal branches damage and inadequate heparin therapy. Dissection of the artery when introducing the tool can lead to the carotid artery trauma or proximal parts trauma. When you introduce the instrument into the dissection of internal carotid artery, that appears spontaneously, and we need to press it with a stent. After plastic, I always recommend to perform angiography into projections. Stenosis and thrombosis of the occurring artery of one branches of the artery. First, it is mass effect. During embolization, you have extravasal stenosis of the occurring artery. No protection of the branch of the second line. It would be good to do it sometimes. And the prolapse of the spiral into the lumen of the artery. It can lead to the embolism, and this is wrong projection. When the first coil is introduced, you see on the left slide, the distal part of the spiral drops. Wrong choice of the spiral. Disattachment of the coil and overstretching of the coil. This situation happen. We need to remove, if possible, the spiral, the coil, but sometimes some parts of the coil we can leave it there if it is not an obstacle for the lumen. We can use double antiplatelet therapy, because it would be the same as in stent thrombosis. Stent thrombosis, inadequate opening of the stent, antithrombotic therapy, inadequate blood flow, and stent thrombosis for unclear reasons. What do we do here? To prevent this washing the catheter, to preserve heparin therapy regimen during the surgery, catheter should not close the lumen, the arterial lumen. I had a case when during 40 minutes, the catheter would close the lumen, and it led to aneurysm deficit. We don't have time. We still have 2 more presentations. Please, can you speed up? If you see the spasm, the spasmolytic drugs, maximum we use roadmap system. If you have thrombosed aneurysm, to prevent the dislocation, we can use stent assistance or balloon assistance. After each coil placement, you perform angiography, at least in one projection, to be 100% sure that the spiral is there, that is not in the lumen of the artery. The golden standard, we use 2B3 GP receptors. If you don't have them, you use selective thrombotic therapy. And if the problem is there, you call the colleague. It's a must. If ischemic complication, you evaluate neurological deficiency to understand whether you need to resolve this problem, because this thrombosis can be asymptomatic and it can lead to bigger problems. And the main course to plan our complication, when we plan the surgery, we develop the plan B, always the algorithm for treating of possible complications. You discuss them with the team. I discuss them with the whole team, with the balloons, stents, spirals. Without that, you should not even start. And selective angiography should be performed regularly. Thank you for the attention. Very important topic, very important topic. It's sad that I had to hurry you up. Thank you so much. Well, I hope we need to find a way out of the complication. Mr. Vasilyev is talking about chronic venous insufficiency of the brain in endovascular tactics. Unfortunately, in Kazakhstan, they don't have internet anymore, so we proceed to the next presentation. Dear colleagues, I'll be very, very fast. When I was thinking about the topic of my presentation, I'll tell you how we got here and what are today options that we have. It all started back in 1998. We're trying to treat the patient from a different problem. The patient is still under observation, but we managed to cure migraine. There was a big publication, big paper published. And now about motivation issues. The patients are not happy with the results of treatment, and it led to the fact that we need to go higher. And this is the first result when, from the cephalgia, we treated the patient when we implanted the stent, and we implanted it into the sinus. From one more issue, we performed a section study of different died patients, and it turned out that in the sinus lumen we see different soft tissues such as half valves, membranes. It is kind of a matrix for thrombo formation, and understanding can be there. There was a 3 years difference when the patient was admitted and neurologists did not understand what's happened. In the study, we see that there is lack of visualization of left sinus. Then the patient came with cephalgia, and based on this, we can say that thrombosis formation is also important. 160 angiograms were evaluated, and we pay attention that in 40% of cases we see the visualization. It is either right or left carotid. Sinus is not imaged well, and we nearly don't see it at all. This patient is with the dysplasia, with non-differentiated form of dysplasia. We started collecting the experience, studying venous dynamics. We have analyzed the story of the patient, and according to her state, we understood that there is dysplasia of connective tissue, and I will try to explain why we did it. In 2010, there was Paolo Zamboni publications. He tried to treat multiple sclerosis by stent implanting. There was a need to treat acute thrombosis as a complication of chemotherapy in patients with leukemia. And these are our first results. All of this allowed us to analyze the situation. These are most common places where we see stenosis and thrombosis localization, sinus, sagittal sinus, some blocks on the jugular, internal jugular veins. And this is the slide where we see the reason of the compression, extravasal compression. We see Atlanta. We see different levels of internal jugular vein. Since recently, we perform phlebography. And this is how it looks like on IVUS. You see that occlusion is minimized here. This is a result of stenting, how IVUS look like. Some cognitive issues, dementia, phlebography, stenting, and good result. The patient did not. The patient improved, and she can take care of herself. Cephalgia, stent implantation into the internal jugular vein, Meniere-like state, a kind of vestibulopathy, dizziness, unbalanced gait. We see the treatment with good clinical result. Multiple sclerosis remitting form patient, one of our first patients to whom we performed balloon plastic of sagittal sinus. The patient still had the regular therapy, but this is a supporting technology. It allows to stay in remission for a pretty long time. One more complicated patient. This patient overcame some psychological barrier. She had dysphonia, dysphagia. Unfortunately, the destiny is very sad. The parents were ready for any steps. At that time, we performed a stenting of internal jugular vein, and we achieved the better situation. She got rid of dysphagia and dystonia. We saw some movement in the tours. These are not some revolutionary revelation. This is just a step forward. The patient, again with cephalia, with the progressing, blinding. And talking about neuroautomologist participation, this is the picture that we see on phlebogram. We see hypoplasia on the left side in 2019. Now everything is good and no headaches, and the vision is there. One more interesting patient with the fistula pharyngeal. Embolization was performed many times. We see that here, hemiplegia, metorrhaphasia. After the patient had a quarrel with his spouse, as he says, we see the upper sagittal sinus blockage, and we decided to perform the stenting. Starting from October, he had no attacks. Very complicated patients with dural fistula. You see the picture of phlebography. We performed stenting with 2 stents, sigmoid and transverse sinus. She used to have seizures on monthly basis and cognitive issues, as well as diabetes. But from March 2020, no attacks. She became, as they say, clever, and even her diabetes has changed. Venous dyscirculation is not an isolated disease, but I demonstrate this slide to stress and to draw your attention to the fact that hemodynamic in veins differs from arterial, and it makes us think how to redistribute their blood flow. Classification of chronic cerebral venous dyscirculation exists from 1989 by Berdichevsky. And this is the experience that was analyzed. Actually, we have more of experience, but this is what is included. If we talk about American understanding of idiopathic venous cephalopathy, it is a classical case, and lower I present our understanding. Diagnostic algorithm. First, clinical picture. All the non-invasive technologies to evaluate the blood flow. Venous state, angiography. I think it's quite clear, and this is MRI picture. It was discussed already, and we always remember we have to evaluate the surface. We have to understand how the blood flows, and these are our results. Well, first we were really interested in balloons, then stenting, and now we are more courageous of long-term result till 8 years, and we still have good result, but the worst results in the Parkinson disease patients.
Well, so I tried to sum up. There are different symptoms so that the audience could pay attention to such issues. And again, it can be venous encephalopathy, different complaints from patients, starting from headaches of different type, night headaches, morning headaches, splitting headaches, migraines, etc. Well, also tinnitus, which can be of different nature, such as, well, your ears are clogged, or, well, issues related to vision acuity decline, issues related to sleep disorders, asthenic manifestations, cognitive disorders, syncope condition, well, seizures, and so on and so forth, plus, well, an increase in the arterial pressure, blood pressure after the surgery, also ear rigidity, etc., visual disorder, sclerosis, regressive mental health. And in conclusion, I would like to say that this is a very difficult topic, but a very interesting one. If you make the right decision in terms of optimization of the venous blood flow, we can get very good results. And I think we should use a comprehensive approach. Thank you very much. Thank you, colleagues. Well, we still have 2 minutes before the next breakout session starts, so we finished on time. Thank you for your participation. Thank you for your discussion. Thank you very much. See you next time. Bye-bye. Once again, good afternoon, dear colleagues. Let's get started again. The next breakout session, visualization and navigation in endovascular surgery. The first presenter is Sensor Ibrahimov, the use of medical CO2 in endovascular surgery. Please do not overrun your time because we're pressed for time. Thanks. Please put on my presentation. Distinguished colleagues, again, CO2, medical CO2 in endovascular surgery is the theme of my presentation. Where should I click? I cannot advance the slides. All right. Well, it's open secret that the number of trials using the contrast media increases. Well, in Russia, it's about more than 33,000 cases studied. The number of mutations over a 10-year period hasn't changed over a 10-year period. In case of diabetes mellitus, this figure even increased. Well, as for treatment, we know that endovascular interventions can be used on extremities, where we use the contrast media, and this may lead to CIN, contrast-induced nephropathy. Well, you can see here the number of complications is about 6%. Well, after peripheral angiography, 10% in case of coronary angiography, from 5.3 to 44.5%, depending on the stage of the renal disease. Well, what this complication can lead to? Well, first of all, it means additional costs for any clinic, and also CIN or SIN, that means iatrogenic intervention. Well, you can see more than 1 million cases, 150,000 episodes of CIN, contrast-induced nephropathy, and 1,500 people have additional dialysis. That means increase in the hospitalization stay by 17 days. CO2 is the real alternative for such patients. If you look at the history, well, for the first time, CO2 was used way back in 1928. Well, then Professor Moore showed the safety of CO2 when subtractional angiography was done, the so-called DSA, when CO2 was used as the contrast agent. In the post-Soviet area, well, Dr. Antonov used it for the first time, the first publications by Professor Shipovsky, when he used the CO2 not only for diagnosis but also for treatment patients with vasorenal hypertension in case of the femoral segment involvement and the femoral segment involved, as well as in TIPS procedures. What are the advantages of CO2? First of all, it is not nephrotoxic. We know that CO2 is not nephrotoxic. That means there is no allergic reaction to this CO2 procedure. Well, the solubility is 30 times higher, and if it was transferred in a sealed vial, and also within 1 minute when the procedure is over, the gas can be removed from the organism. And if CO2 used as a contrast, there are no limitations for CO2. The only drawback is that you cannot use the CO2 in the diaphragm. All right, well, here you can see absolute indications. Well, again, it's allergy to iodine-containing drugs, also chronic renal insufficiency and kidney disease. Again, you can see also patients with kidney disease, stage 3, and also like any other drugs, well, CO2 cannot be used in coronary vessels. Here you can see our own experience. I am not going to read everything here, but we start introducing CO2 from 15 to 60 centimeters, 10 to 15 centimeters, cubic centimeters per second. Here is an important table because here we can see the difference between CO2 and other contrast media. costs. In case of gas angiography, there are no significant costs. Again, you can see the difference can be by a factor of 25 in terms of cost in favor of CO2. It is 25 times cheaper. So we started introducing CO2 by hand. For that, well, we use the simplest way of gas introduction. We need a gas with CO2, high pressure line, valves, and the most important thing is DSA mode. Okay, starting from 2022, we have Angio Droid machine. Well, it is very safe, and we can introduce CO2 very safely. Again, you can see the total number of 110 patients. We started to use the filter. Well, the intervention is aimed at restore the blood flow of low extremities, renal arteries, hepatic arteries, and here is the new area of research in Hospital 57. We started doing it in case of aortic replacement. Here are several cases. Well, here is a patient 70 years old. Well, a critical ischemia of low extremity, stage 4. He has a diabetic mellitus, and he is allergic to many contrast media. Well, you can see the popliteal segment. You can see the damage here. Angioplasty was done. Then you can see popliteal artery was involved. And again, you can see the femoral segment. We can see the lack of the femoral artery. Well, the blood flow is quite satisfactory along the posterior tibial artery. Well, you can see what the picture is. Again, the situation was very appalling because my first idea was that there was acute thrombosis. Well, you can see the skin is kind of marmor in type, and again, we decided to do the ultrasound. If the blood flow was preserved, again, you can see the femoral and the posterior tibial artery. What was that? Well, and actually, since the patient had no complaints clinically, we talked to surgeons and sent the patient to the department to monitor. The patient was monitored for 10 to 12 hours. And as for, you can see, well, the skin was no marble, it was regressed. Well, again, you can see I didn't take a picture after this regression, but 1 month later the picture was like that, at slightly longer than a month. In general, as you can see here, the situation has normalized, and I should say that if you have a case like this, well, do not be afraid. Well, it was just the response of the organism to the use of CO2. Well, here is another patient. Well, we use the tips, and again, we use the CO2. The only thing here is if you look at the first picture, the catheter is in the position of wedging of the right renal vein, and there is the staining of the portal system because of the peculiarities of the gas. Well, it should be quite viscous to get into. The second picture is after the stent implantation, and again, you can see that the quality of the picture and the imaging, well, is basically the same as the picture taken with the X-ray opacity picture. Here you can see the implantation of the Kava filter, the renal veins placement, and you can see that the picture is practically the same as the picture when we use a contrast media. In conclusion, I would like to say that today medical CO2 is a real alternative to contrast media. In terms of the quality of contrasting, it's basically the same, not inferior to traditional contrast media. Of course, there is a need to get more information in order to have a clear understanding of the clinical importance of the gas angiography and its use in clinical practice. Thank you very much. Thank you for this wonderful presentation. Colleagues, any questions? The speaker is off the mic. Please use a microphone. Well, That was clinic number 1, hospital number 1. We introduced the CO2 by hand. There is the gas balloon, the high pressure line, and the valves. Basically the same as we do to induce the contrast media. Yes, yes, it's the same thing. Well, maybe not 100%, but we try to do our best. Well, we had more than 50 procedures while introducing CO2 by hand. And I showed you the picture of the first patient. Well, the speaker is off the mic. Thank you very much. That was a very good remark, because this case can discredit the method, which is working very well. Again, please use a microphone, because we are broadcasting this event all over, and we have simultaneous interpretation. Thanks for the presentation. Did you use the special software, or use the standard Visay? We use the standard one. And what was the equipment? Siemens and Toshiba. I know there is also Canon. Yes, yes, there is the special CO2 mode. Yes, I know it. I know about Canon as well, but we use either Philips or Toshiba. So I didn't see any big difference between the machines. All right. I think that's a very arguable question, because when you have the additional software allows us to get angiograms which are comparable to the introduction of contrast media. Not every machine has a DSA mode that can allow us to get very good imaging. Not always. Well, CO2 can be an alternative to angiography, but in most cases the answer is yes. Sorry, it was not Siemens, but Toshiba. All right, Toshiba, okay. Sorry. Let's move on to the next presentation, the use of CO2 angiography in the revascularization of the arteries of the lower extremities in patients with high risk of contrast-induced nephropathy. All right, good afternoon, dear colleagues. It's a great honor for me to speak here. CO2 angiography, the follow-up to the previous presentation, the use of CO2 angiography in our clinic. We know that contrast media tests are done en masse. Usually it's coronary angiography, and here it's much easier for me to speak, because the previous speaker spoke about the relevance of this problem. As of today, we use iodine-containing contrast media, and here you can see the slide prepared by Bagrat Alikan. There is a shortage of different contrast media, especially when we're talking about low extremities stenting. We're talking about the revascularization of low extremities arteries, and here, of course, we are talking about the possible complications due to the contrast media. Here you can see contrast-induced nephropathy, CIN. We must be aware of it. Well, there are different nuances. It happens 24, 48 hours after the introduction of the contrast media. The patient may be discharged by this time, and then there is this complication when the patient is home. The consequences can be very grave. With the lack of risk factors, this complication occurs in less than 1% of cases. However, when there is diabetes mellitus or, well, a contrast-induced neuropathy can occur in 10 to 30% of cases, as well as with chronic kidney disease, CKD. Well, usually this happens when there are different risk factors, such as age, over 75, kidney diseases, diabetes mellitus, anemia, and, of course, factors related to the intervention per se. There is a direct correlation between the volume introduced of contrast media introduced and also the development of CIN, contrast-induced nephropathy. Also a repeat procedure. When 2 days after the first procedure, we introduce another contrast media that might lead to CIN, intra-arterial introduction. Usually we do it intra-arterially when we do the revascularization of low extremities artery, the use of high osmolarity contrast media, and complications during the previous interventions. Well, in this case, like air, we need some alternative method, alternative agent that could allow us to do our interventions. And we have this thing that's CO2, and the previous speaker already mentioned this in terms of the history of the use of this particular substance. Well, first we introduced it by hand. We did have a lot of problems with getting the adequate image that could be comparable to the picture obtained when we use the contrast media. It wasn't simple, and we know how important it is for us to have a good image, and when routinely you use some particular method. And the first step forward was angiodroid. Well, it was like a space, equipment, and it made our life easier. CO2 is biocompatible 100%, and right now there is a lot of CO2 here. You open the window and the gas goes out, and there is no problem, despite the fact that we're breathing out the CO2. There is no toxicity of CO2 on kidneys, no allergic reactions, and basically there is no such a concept as a maximally allowed dose of CO2. As the previous speaker has already mentioned, CO2 is very well elbowing out blood. It has low viscosity. It can get beyond the stenosis. And later slides will show you how we can use CO2 for imaging. This is the angiodroid. Well, the gas balloon inside, and there is an additional connector between the angiodroid and the diagnostic catheter, or the Y catheter. Well, in case of carboxyangiography, all arteries are below the diaphragm. It's the venous system where it can be used. This is a system for the kidney chronic disease, patients with a high risk of nephropathy. And what you can do, well, to inject CO2 into arteries above diaphragm. Well, in case of respiratory insufficiency, grade 3 carboxyangiography lowers the hospital stay. In case of CIN, we know how long the patient stays in the ICU. And then in the renal department, of course, here we can save money for the hospital and for the use of iodine-containing media. Well, in this angiodroid, the balloon can last for several years, and when it comes to an end, you can just find out in advance. Well, CO2 is not under sanctions, and it's not so easy to replace this balloon when CO2 is up. Well, here are some clinical examples. That's how it all started. I don't have a laser pointer, but on the left you can see iodine. That's the classical variant. And on the right is CO2. That's how we all started. We can see white color shows the CO2 gas. Well, and you can get used to it, and this is quite good imaging with CO2. You can see that thanks to CO2, the post-occlusion areas are filled even better as compared to iodine-containing media. You can see also the abdominal part of the aorta and all the manipulations here. The next stage for the use of this method is the appearance of different software. Today I'll be talking about our angiograph, which was installed in our clinic. That's the Siemens equipment. It's very easy to use, and you will see that for yourselves. This is our small robot in our cath lab. You can see the brochure, which shows which particular pressure should be set up, what volume should be introduced depending on the basin. And here you can see the advantages of this ceiling Siemens system. Well, you can see the table doesn't move, only the C-arm comes closer at the angle you need it, depending on the area where you want to do the intervention. Well, right now the angiograph in the initial position, the so-called 0. After this, well, you can see the system is very convenient. Well, you can just move the C arm. We have a Phillips as well. Well, here you can make a small angle, and the detector remains in the same position. The table is intact, only the C arm is moving around or along the table, and you can see the sealing system is very efficient. You can just put the detector above the area where you are going to do the intervention. Well, we set the special CO2 regimen. You press the pedal, then you just introduce the gas, then it goes to the bottom of the screen, then you press the pedal and you can start the reconstruction. You have the imaging, you can start the working, we have the roadmap, we have the reconstruction ready, and all you have to do is just minor things. Well, that's what it looks like. On the left screen, you can see the roadmap, which was developed thanks to CO2, and on the right is the reconstruction. And then you will see clinical cases, the way it looks like. Again, that's what I have already mentioned, and you can see there is no difference in terms of the comparison of two pictures. Well, CO2 gives you a very good imaging, and again, you can see several years ago we participated in the experiment. We did the revascularization of the lower extremities. There was a broadcast, and some of the professors started saying, and where is the CO2 gas? Well, and they said, it's already here. You didn't see any difference at the time. Well, the software allows us to do this quite nicely. Well, again, the image is very good, and everything is very simple. Everything is on white screen. You compile the map, you do the reconstruction. Well, the artery of the lower leg, and again you can see carboxyangiography plus a roadmap. The wire is placed, the pre-dilatation is done, dissection was in this patient. The decision was made to do the stenting. A stent was implanted, again with the use of the special mold, where you can see the metal very well. Again, we are using the Siemens angiographer, post-dilatation, under expansion, but on the right picture you can see the wonderful stent expansion. Again, you can see the volume of iodine containing substance was 0. As for CO2, it was 150 milliliters, and you can see the full report afterwards regarding the amount of CO2 used. Here is the second case, a very good imaging, and here we have the comparison with iodine-containing media and CO2. Again, there is an aneurysm here. CO2 fills in this aneurysm very well, and there is good imaging. Well, here is another clinical case, which is quite complex for CO2, because here it's closer to the abdominal cavity. There are gas bubbles in the stomach. We should prepare the stomach. It's not a problem. You can see that there is the stenosis of the external iliac artery. And again, here is a very good interface, Siemens interface. Well, there is a mask here when you call copy. When you press copy on the right screen, there is usual copy, and here it's roadmap. In case of a lot of bone landmarks, well, you can again do this revascularization without any problem. And you can see the stent was implanted, post-dilatation, CO2 angiography, a wonderful result. The procedure was completed. In conclusion, I'd like to say that carboxyangiography or CO2 angiography is not applicable to 100% of patients. Nevertheless, there are patients without this kind of procedure. You cannot do revascularization, especially popliteal segments are involved in the process. And thanks to angiographers with software, as you have seen it here, this revascularization is very easy. And well, the beach season starts very soon, so I would like to wish you all the best. Thank you very much.
Thanks for the presentation. Do you have any more questions? I have one question. If it is so great, why the headquarters do not use it? Oh, well, because no. It's a different. It's a different. In each method, there are certain limits. You just need to use it due to the indication. We have a prize for active questions. We don't have a lot of time. We will give you a prize for the prize for the best question. Clearstent and Clearstent live systems for optimizations of stenting when we perform coronary intervention for post-dilation. Good afternoon, dear colleagues, dear friends. It is the second presentation today. Probably it was on the previous session, but I think all people have such a system. We have 2 Siemens angiographs. So I'll tell you about our system, Clearstent, Clearstent Live, and H2H. The system optimizes the imaging of stent. How does it work? You take few pictures, use 2 balloons that is introduced into the stent, and you can use the balloon. And we get good visualization of the stent cells. Thus, we can visualize under expansion malposition of the stent. You know, it's very simple to do. You have this pedal, you press it for 3 seconds, and then you have few pictures. After that, they are all summed up. And we get the picture with good imaging of all stent cells. Few clinical cases, my colleagues from the Institute of Therapy helped me to prepare it. This is the stenosis of anterior descending artery. We implanted the stent, set the balloon for imaging on the left side. They performed here Clearstent. It would be post-dilated. And on the next imaging, we used Clearstent Live to the for positioning of the balloon for post-dilation. You see, it's not the balloon moving here as we're used to. The stent is moving. We have 2 markers, and we move the stent, not the balloon. You have to get used to it. But I saw lots of clinics abroad where they use it, and do trust me, the results of stenting are really better. The main problems that we have here, the fracture of the stent, and it is the old classification. We are anxious about 3rd and 4th type of stent fracture. If it is one stent, the edges goes to the different direction. You see it on the lower part of the slide. If we use aggressive post-dilation, we can see also the disassembling of the stent itself, and you can see here the possible results of these cases. And these results are catastrophically unfavorable. This part of stent should be covered well, even if we want to do minimal post-dilation, better to leave 2 to 3 millimeters. As we have aggressive post-dilation now, it's important to choose stent correctly, because we have to know what we are working with, what's the behavior of the stent, what is the optimal stent. science stents behave worse than, for example, Megatron. If it is a big trunk, we'd better choose the other stent. One more clinical case. We stented here right coronary artery before bifurcation and visualized using Clearstent system. Well, open stem cells. Next case. Anterior descending artery lesion. The first stent was implanted. It was long 48 millimeters, and to implant edge to edge, we used Clearstent light. And you see how the stent is moving, and you can adjust edge to edge without any additional effort. And with further post-dilation of the stent happens well. You see the stent is, after post-dilation, pressed to the edges of the artery, no malapposition. You don't need some additional imaging. And intravascularly, we see that the stent is implanted well. The next case, also anterior descending artery stenosis, and we can position stent with a Clearstent Life system. The producers recommend to implant only stent-to-stent implantation or post-dilation. I use it also for common stent implantation. You can use contrast. You can evaluate well the landing zone. And the final result. On the previous session, the colleagues asked me how the system works with calcium, with calcified lesions. In Siemens, the system sees the balloons well, and it is possible to implant it edge to edge. The stents can be implanted edge to edge. Some colleagues are considering whether the dosage is too big, and there is usually new focus. And the main problem with post-dilation at the moment, we have to understand that post-dilation is performed to prevent malapposition. There can be no full expansion of the stent, but post-dilation is performed to have good connection between the vessel edges. And the best pressure here would be 20-21 atmospheres. We can use bifurcation stent life, and for the last angiographs, we can use Clearstent life. But unfortunately, I haven't seen it yet. I haven't seen it in real life. Thank you, everybody. Thank you so much for the very interesting presentation. I have a practical question. You demonstrated bifurcation stenting. If you have 2 balloons and there are 4 markers, is it do you understand what's happening? If you want to perform kissing, you can remove 1 balloon. If you allow me, I would add a few words. We work actively. It is not ideal yet. After cabbage patients, if we have these staples, you have to have the picture thinks that these staples are markers. If we have biomarkers for balloon, it is visualized well. It is quite efficient. Very simple, very simple. Even if you use the stent loop, most people use it, and actually you have this pedal to press, and you get this additional information Of course, it is not IVUS. We do not judge the stent expansion, but it's an easy option for us to understand whether we implant the stent correctly or not. I'm surprised that the dosage is lower. I thought that the dosage would be higher. Yes, I think that with other producers, as for Siemens, I know for sure that it can be compared to stiff stents. Well, next presenter, Ferdas Vahadorovich. Our experience in the use of intravascular imaging in endovascular treatment of peripheral arteries. My name is Ferdas Shukurov from Moscow. We are 500 meters from Moscow, from Kremlin and Red Square. We are always happy to cooperate. It was back half a year ago we decided to start it intravascular imaging when we started using it in coronary intervention. We understood that it changed our mindset in coronary intervention, and we started using it in peripheral interventions as well, because we all know if we talk about femoral popliteal segment, if the first surgery is not performed on high quality level, the patient will have long-term tortures. I think all of you who deal with peripheral intervention, you have this cohort of the patients who regularly call you and they say that they feel unwell, they have a gait or ischemia, and correct diameter and length of the vessel, good pre-op and intra-op managing of the patient. These are key conditions to have good result of our intervention. So, why do we need IVUS? Today, we do not have guidelines for selective usage, for everyday usage, but we understand how to use intravascular visualization. We understand that we can identify eccentric damages if the patient doesn't have computer tomography imaging. We are lacking in this information, and IVUS can change our strategy intraoperationally. If we see calcinosis, and here we will probably shift to the changing of the strategy. We can perform debulking, we can modify this zone. If we need to implant this zone or to restrict, to limit our intervention. Of course, we need to have better lumen with less trauma. If we choose correct diameter of balloon catheters that we use, that will be achieved. The fact that today we have to use intravascular imaging when we are planning to use a drug-covered and drug-eluting technologies, if we are not 100% sure that our balloon catheter is fully opposed to the vessel, then the drug technologies will not work, and we will not get the effect that we were planning to get. We see already a certain evidence base as for femoral popliteal segment. The frequency of the success here, a lack of restenosis during 2 years by 20%, IVUS and angiography improves the result. Tibial artery, there are lots of studies for it, and there are studies that demonstrate that IVUS-guided revascularization decreases time to the wound healing. It is explained really easily. When we use IVUS, we are more courageous to choose balloon with big diameter, to inflate more, and at the end of the day, we get bigger lumen compared to the surgery when we use angiography only. Perfusion increases, the healing is better. As for dissection identification, when we see vessel from inside, we understand the dissection better. Talking about drug technologies that I mentioned already, the recent study that was demonstrated in American Cardiology College, this is a study where our colleagues compared in IVUS-guided revascularization with the drug-covered balloons and also angiography guidance. The patients were randomized 1-to-1. These were quite severe patients with a lesion length up to 200 millimeters, more than 20 centimeters. CD classifications, 80% in IVUS group and 71% in angiography group. These are very severe patients. These are not specially selected results. And now have a look at procedural data. Balloons in IVUS group were of bigger diameter. Dilatation were bigger in IVUS group, and the patency and the lumen was better in IVUS group. And the results you can see. Initial patency during 12 months is 14% better in IVUS group. The freedom for secondary intervention is better in IVUS group, and you can see this is a severe cohort of patient. This CND stenosis. The results are better nearly 1/3. We understand that nearly each third patient, when we send him for the strategy, for the combination with the drug technology, each third patient will stay free of doctor visiting for 2 years. Let's see. We have about 25 patients during these 6 months, and this is the first clinical case. Really calcified plaques. This patient had IVUS to understand where the most narrow places are. We see here how we worked with atherectomy system. We see where there are the lumens. Somewhere the probe is kind of pressed from all the sides. We performed the extreme, then we performed balloon angioplasty, and one short stent was implanted into femoral artery in the proximal segment. Of course, we did not achieve ideal IVUS picture, ideal round picture, but that was not our target. Our target was to restore the blood flow. You see the stent is expanded. Somewhere stent is oval, not round, but we decided that the lumen was enough. And that was the maximum result that we could have achieved. We were happy with the lumen of the vessel. Unfortunately, today there are no IVUS criteria of successful intervention, or there are no criteria for lumen that we need to achieve. They are to be developed. One more clinical case, critical ischemia, acute bifurcation of high aorta. Unfortunately, contralateral access was not successful. We did not manage to bypass this bifurcation. We had retrograde approach through anterior tibial artery. And then recanalization was performed of superficial femoral artery. Subintimally, it was not clear where we got to the true lumen. And IVUS here helped us a lot to understand which segment we need to implant the stent. one more patient with critical ischemia, high bifurcation of common femoral artery. We had two excesses here, distal excess and stenosis of deep femoral artery and occlusion was performed. We tried to perform retrograde recanalization, but antegrade recanalization was used after all, using pedal artery. After that, balloon angioplasty was performed. Here is angiography result you can see. This is the angiography result. We see the dissection, after which IVUS was performed. There was clear understanding where dissection begins, where dissection ends, what should be the length of the stent. We see intravascular imaging. Dissection was okay. It was less than 130 degrees in circumflex, so this dissection stayed here. And probably the most beautiful case, the case that proves 100% IVUS, it was in April. Mr. Platonov demonstrated it. It was femoral artery occlusion, intraluminal angiography, and we have absolutely marvelous result. The lumen is good. There are some dissections, but they do not bother us. Just look at this. Absolutely horrible recoil, but recoil was a matter of nerves for us, and we have kind of dissociation. IVUS and angiography had different pictures. In 10 minutes, artery already started becoming better and better. If we use only angiography, the artery would close, and it would close even in the intensive care unit. In near future, the patient would have the relapse and intervention. And to conclude, I would love to say that IVUS cannot be recommended on the everyday basis, but nevertheless, we have clear understanding that the more difficult is the lesion, the more probable we need to use IVUS, and the patients would be healthier. Thank you. Questions? Questions, please. Question is off the mic. Question is off the mic. It is broadcasting, but question is off the mic. The surgeons do not want to use the microphone. Thanks one more time. The question is whether IVUS is useful in intraluminal or subintimal guide passing. If we try to move according to modern trends of femoropopliteal segment, say that maximum important is to prepare the lesion. The lesion preparation is the groundings for the success. If we have IVUS, we understand if we passed intraluminally or subintimally, because sometimes we pass through occlusion and we don't know how we pass it. That's how we get this result. We can have atherectomy. We would remove substrate, and it would be ideal intervention. Intravascular visualization is really good. One more technical and practical issue. When I started using intravascular, ultrasound, when we go through with our guide, whether the probe goes through the occlusion, and what both Boston Scientific and Volcano probes can pass through recanalized lumen. There's no problem with that. And it gives really good picture. This is a technical issue. You should not be scared of it. Thank you very much. Next presentation. The next presentation by Mr. Vitaly Sorokin, Fusion Technologies in Interventional Oncology and Not Only. I'll tell you about my presentation. It is not quite common because I work in Medical Center of Bank of Russia. We treat particular patients. We have patients with absolutely all pathologies. We have to treat them all here. So I'm not talking about endovascular surgery only. Fusion technology, it's all more or less the same. The idea is that we take CT, we perform it either ahead or it can be performed on the operational table. For example, in cath lab, we choose the zone that we need or the device does it itself, and then we choose what we have chosen to scope. If we can use one function, we can learn to use all the functions. In our center, we have a system probably you see it for the first time. It is navigation stereotaxic system. Its principle is based on stereotaxis. This is infrared camera. It's above the patient, reading the data and put the data on computer tomography. It is used mainly in oncology, in endovascular surgery. It can be used for punction, but its main indication, intervention oncology. The manipulation is performed as following. You can see on the slide how it looks like on the patient. These probes are attached to the patient's body. Then biopsy needle or any needle can be attached here with 4 markers, and the punctures is performed. In the OR, the doctor looks at the screen, moving the needle. He sees the trajectory of the needle, the depth where the needle goes, with the correction for breathing. No radiation load. The doctor doesn't need to wear the apron. Once the CT is done, everything rest goes without radiation. It is biopsy, thermoablation, cryoablation, vertebroplastic, drainage. Whatever you need to perform in oncology, you can perform with this system. Here is the real practice case. On CT, you cannot do that because on CT, you cannot contrast the vessel. Well, the contrast can be used, but you will not be able to do the puncture. We kind of froze the image with the contrast. Then we push the needle further on. And here we were punctuating small pelvis, and we bypassed all the branches of the artery. Same we can do on our neck. It is not normally very easy to perform it. Deeper structures of para-aortic lymph nodes, intraosseous punctures are very comfortable to be performed, any ablation. And the main, of course, we are talking about the lungs. We do not perform the puncture of lungs under CT and ultrasound guidance. It's easier to perform it like this. Here we're in the OR. No negative dynamics. You have less radiation load, and all in all, the results are the same. 9% of complications, but we had the learning curve at that moment. Thoracic surgeons wanted to learn it. But all in all, in diagnostics of the lungs, the information is less than 80%, even in the punctures. But for stereotactic navigation, we use fusion in the common sense. For angiography, we have the segmented areas. And from interesting cases, I don't think that lots of you have seen it, endobacteria cryobiopsy. When the patient is under anesthesia, we perform CT and choose the zone of interest that we need to biopsy. Endobrachial, we see it with a blue ball, like a blue ball, and after that, on the right side, you see how bronchoscope goes through.
We use the cryobiopsy device, and the bronchologist is trying to get into the center of this blue formation to do a biopsy. Well, you can't do this kind of biopsy using this method only when you use FDCT endoscopy. Aortic aneurysm, again, Siemens angiographer, well, can allow us to do that. I don't like this function very much. It does have some limitations, but over the last several years, I have preferred this kind of technology. That's that's a special navigation system. It can be connected to the C-arm or an angiographer, and so you can just acquire this additional piece of equipment and you have this function. CT data will be uploaded there. On the right screen, you can see the SCOPY imaging with the shadow of vessels. The difference from Philips is that this particular system can predict the way the shadowing area will change if you use the rigid guide there. We use it for the puncture of femoral arteries. Well, you can do it without ultrasound. You can also do it without the contrast media. Again, you can do fusion. And again, it's before TAVI. You can embolize the internal iliac artery without contrast media. Here you can use CO2. And again, fusion technology is very efficient. Well, you can see the coaxiality. And so that's the way it looks in the cath lab. Well, doctors just look at the arm. And again, they also look at the screen. Well, these are the low extremities. Fusion is good for low extremities as well. And we also use fusion technologies in arithmology. Well, we have a person who is responsible for radio frequency ablation and the placement of ICD. Again, you can just fuse the contours of the left ventricle, and in this case you can have a better understanding of what the situation is, and you have a clear understanding where ligatures are, where specific arteries are where the outflow from specific veins, etc. And here is one of the last slides. That's my favorite function. During embolization, of course, it's nice to get into all intercostal arteries, but not everyone has this kind of skill. So before the procedure, I do the drawing for my doctors. Well, I just show them where the outflow of arteries is, and we just press the button, do the scopy, and using, well, our equipment, you can see all these green points, and you know where the catheter should go. Thank you very much. Thank you, Vitaly, for this interesting presentation. Well, question, to what extent it's well, should you use a fusion in terms of time during the intervention? Well, if you have a T angiographer, the POC system, in order to do the fusion, well, and there are two ways. Well, using the rotation and using the two projections or two views, 90-degree views, it takes a minute. So try it 2 or 3 times, twice or thrice, and then you'll be able to do it within a 1-minute interval. It's very convenient, a very convenient option. Even the umbilical arteries, we can do this for umbilical arteries. Why not if it takes just 1 minute? Well, let's say the patient is on the operating table, right? And maybe it's not just the straight line. Will the angiographer do all the necessary changes? Well, the patient should have a very good prone position. Well, if the position of the patient is not good, then we will just use the typical CT, placing it on the image. But we don't need the super exactness. Well, we just make sure that the young doctor did not make mistake sometimes. Well, when we embolize the left ventricular article, well, it's not the process of embolization that is difficult, but getting into the target vessel. Any more questions? Yes? Sorry, the question is off the mark. The answer is, well, the last picture I showed you with fusion, well, it works with the C-arm, and it captures the image from an X-ray machine. Well, there is the artificial intelligence used, and there will be the fusion of the images. So it's done by the artificial intelligence, yes, by the AI. Well, it's the synchronization of the system. Well, the machine must understand how we can basically use the scopy bones and the angio bones, and so we should just remove the bones, and there will be vessels left. And if you change the angle again, the bones will be combined with the bones on CT, and then they will be removed so that we could see just the vessels. The next presenter is from Moscow, review of the latest technological solutions in Canon Alphenix and geographic systems. Vitaly, we don't have the last presentation. Yes, yes. You can. We have limited time. All right, we will see. Maybe we'll have a discussion instead of the presentation, which is not going to take place. That's the last presentation in this breakout session. Colleagues, dear friends, thank you very much. I will be showing a lot of interesting results, and it will be more like a marketing session, and then maybe we will have a discussion because, well, Oleg Nikolaevich was unable to show up. So maybe I will just speak for 5 more minutes as the official sponsor. Canon is the company established in 1930 in Japan. As of today, It is represented in 150 countries. The headquarters is based in Japan. Well, this is our motto, Made for Life. You can see the head of Canon Incorporated, well, is holding this slogan. We have a big team of colleagues working here in Canon, but also there are a lot of people working as technical support and the development of technologies. Some more historical facts. Canon was #1 in terms of the number of patents and #3 in the US in terms of the number of patents for new technologies. So these are the data for 2017. Canon Jung was #2 in terms of the number of patents for different technologies. So the company promotes its technologies. We develop our technologies and manufacturing. We have our own manufacturing sites, including angiographic equipment, different motherboards, etc. Lots of research centers in different countries of the world. And the company continues to beef up in terms of new technologies. Alphenix angiographer by Canon is our product I would like to talk about today. 3 factors: economic efficacy, second, ergonomics and usability, third, the best imaging. Well, as for economic efficacy, these are Japanese machines. Well, the manufacturing sites are owned in Japan, and the Japanese are famous for their reliability. Japanese cars, well, they are very reliable. You can drive them, well, for millions of miles. So you can see everything is duplicated. Even if there is the surge of the power, well, there are 2 inverters. One inverter burns down. The second continues to work during the operation. You will finish the operation, and you will still be able to use this inverter until the people from the service company will come and replace it. Well, and as for the tube, it can just burn down, and then the second tube will be involved. And also we have a very good service support, nice young guys as well as experienced specialists. Plus, the other side of efficacy, economic efficacy in particular, is that fact that this machine is very practical in terms of service. So it doesn't just break down right away. You won't have the downtime, so that means more money you can get and less money will be allocated from the budget of the hospital. All people like to count money. Well, again, that's the recognition of the clinical community. If you talk to the doctors here, even at this conference, well, of course, the X-ray tube, for example, Canon started using this particular thing, borrowed it from Toshiba. You can just ask those people who are shown here. They will tell you that this machine is very reliable, can work in different conditions, and bring to bear that it's the new tube. By the way, it is very ergonomic. Well, the doctor once came to me, and this machine has been used from 2018, and only one of the node burned down. Ergonomics. This machine is very ergonomic. Those who use the Alphenix, they know about this method of using the hyper handle. You use one handle, and you can just manage the table and other things. The other hand is free. Well, again, you can do it just with one hand. And again, those who switch over from old machines to this new one, well, they say it's very convenient because everything is under the control of one hand. As for the management, everything depends on the geometry. Let me just show you a short video. All right, I will just fast forward it, not to take a lot of time. The system is very functionality. That's by plan. Well, that's the ceiling C-arm and the floor C-arm. It can move backward and forward the radial axis on the left, on the right. Again, you can connect additional equipment in the cath lab. Well, just as it is shown here as an example. Well, again, floor and ceiling machines and different our own technologies of imaging. Well, also, well, easy to handle. That's an integrated system, taking into account the hemodynamics of the patient. Again, you can use one table module to operate the entire system. As for imaging, well, here is just one of the examples. Old and new machines. When we used the old matrix and the new matrix, again, you can see, well, new machines can provide us additional information with the higher resolution. Canon has developed this technology together with doctors and introduced in Alphenix. That's the detector of the new type, high-def detector, which allows us to get imaging with the 2.5 resolution higher than we have on the market now. Well, you can see the field of view, you can see the accelerated video. Well, you can see we can use different fields of view up to the high definition mode when we have the high resolution data, which before were impossible to see, or you will have to increase the dose. But now you can use this just high definition, and using the same dose, you can get a much better picture. Here is the example of the use of our system of Alphenix, allowing us to detect the peak dose here when high-def detector was not used and when it was used, and you can see that even with the high resolution, the dose doesn't increase or even it can diminish. Well, originally, it was developed for the neuro interventions, but later it turned out that Alphenix can be used for coronary arteries, peripheral arteries in oncology, and of course, as for new technologies, well, the artificial intelligence, a lot has been said about it today. Canon is also moving into this direction. These technologies were developed for CT and Canon CT. Well, it's a world-known brand. Canon engineers managed to import this technology for other use. The AI can be used for processing. We just remove the noise, and then we have a high-quality imaging without noise with a lesser dose. Well, you can see here what was done by Alphenix. That's real-time application. Well, we use the AI to get the superb image quality, drastic close saving, workflow improvement, cross-modality. This is Alpha Evolve, which is not registered everywhere. Again, it depends on the region of the country where this technology is available. And here, just an example. I don't know if there is any sound track. No sound track. Okay, anyway. Just as an example, the use of AI, when I wanted to introduce this video, it was in English. The Yandex browser translated this automatically. So AI is being used widely. Those who are not using AI will be lagging behind. So Canon decided not to lag behind, but to continue to develop. And here you can see the chief specialist on imaging, Canon Medical Research USA, who also works on Evolved Edition. Well, and you can see A Evolve Imaging, and just pay attention to the last phrase here. We can improve the resolution of X-rays, and primarily using just X-rays. We're trying to depart from Röntgen angiography, and we can reduce the number of röntgenographic regimens minimally, and especially for patients with poor imaging because of the better imaging mode. And here there are a lot of issues involved. As it has already been said, well, when she got this job. It was pure mathematics, she thought. But no, it's mathematics plus physics. Using this data, we must process a signal so that it will be clear with the low dose. And here we have a powerful pulse. We have the low time of radiation, but the good contrast and good processing. Thus, we have X-ray scopic imaging, which is of very good quality. And this technology can be used in other modes. Again, you can see dynamic device stabilizer, DDS. Well, as you can see it here, and or we can use still images when we use X-ray scopy, so you don't need to increase the dose. What is interesting is that it can be used in your settings, like if your settings are low, you can just use DDS, turn on the stabilizer without changing the dose. Well, here is another example how this technology works. Well, the plus of this technology is that it doesn't require cardiac synchronization. If there are some problems with the heart rate or heart rhythm, the machine will cope with this problem without any problem. Here you can see the doctor's opinions who are using this kind of technology, and here you can see that these technologies together with AR are used to fuse this data like TEE. And again, X-rays. Toshiba didn't have it before, but Canon started using it. And in the second part of my presentation, I would like to talk about 4CT, which is important as a solution which was developed for many years together with the doctors, depending on their demands. Again, you can see angiographer and CT images will be fused. Well, Equiline 1 has some advantages. Well, why do we use CT data? That's the new type of detectors. That is Canon's development, like 320 rows. Again, you can see for one rotation it can get the volume of the heart. If there are some problems with the heart rhythm, you cannot just get this data having a small detector, but with the large detector, it's possible to do it just with one rotation. And again, artificial intelligence can reduce the dose, can reduce the radiation burden, and get high-quality imaging. And most importantly, well, again, I'd like to say these are not the two separate devices, but there is just one solution, integrated solution. So when you get CT data, it will be placed on other data. And again, when you do a CT in one place, the patient can be with his hands up, or in other case, with his hands down. So in this case, it won't be a big problem. The overlay is done right away, so you can use the X-ray data, and again, you can work without any problem. As for the dose, again, we can have a discussion where the dose is less when we use a CT or when we use these methods. Well, you can see the centers where this technology is being used. In Europe, in France, in Germany, there are not so many such machines in Europe, by the way, because it's a very expensive solution. In Japan, there are more than 145, more than 150 centers which have 4 DKT solutions. Well, the Japanese are using it very widely. For us, it's costly, but those doctors who have this thing installed are very happy. Yes, it's a multi-model team. But talking about those clinics that can do everything, we do everything. We have patients, we work on coronaries, on cancer patients. Such solutions are quite efficient. Well, you can see the A.Titov, and here is 4D example. 4D reconstruction in dynamics, the volume in dynamics, and you can see the scenario when it was used. Well, I don't want to speak volumes because my time is up, but here is one of the clinical cases, 4D CTA, complex aneurysm, we didn't understand how to embolize it. We didn't understand from where it fed. Using for CTA, well, we used the dynamic data. We identified the zone of interest and embolized this aneurysm. That's all there is for it. I tried to finish on time. If there are any questions, I'll be glad to answer them. Thank you very much for this presentation. Unfortunately, if just one brief question, because you spoke for 20 minutes instead of 5 minutes. Okay, we need time for Alexey Alenov, 3D visualization in hybrid operations. Well, good afternoon, dear colleagues. The theme of my presentation is 3D visualization in hybrid operations. Well, I've got some problems with the slides. All right. 3D reconstruction is the method of virtual building of volumetric modules of the vascular bed on the basis of the rotation of the X-ray tube. The 3D model excludes any mistakes. We use Artix Q-Zen, Siemens. We use Dyna CT cardiac, valve guidance, and 3D roadmap that we use on a regular basis. I cannot launch the video somehow. Sorry about that. Let down by the technology. Sorry. Well, can you launch the video in this presentation? No? Technical staff? No? Okay. I beg your pardon, we do have technical problems. All right. The idea is that in our cath lab, everything is done well. Again, we have the angiographic system, RTSQ-Zen. We can do the interventions for large-scale cardiographic interventions. The table, the operating table, can move in different direction, even in the Trendelenburg position. The C-arm allows us to do 3D scanning and rotation. What are the pluses? Well, the exact positioning of the C-arm, well, the volume, the velocity, the time of the delay of the injection, optimal catheter position, these are the pluses, but these are operator-dependent factors. In fact, we are using the 3D reconstruction in two areas, 3D imaging of the aorta and the ascending aorta for transcatheter implantation of the aortal well with 3D imaging of the root of the ascending arch and the aorta in order to do hybrid two-stage operations in case of aortal dissection. For transcatheter implantation of the aortic valve, we use the aortic valve guidance, and also, when we didn't have the software, we had the long procedure of choosing the optimal view or optimal projection, selection of the projection. We did it in different views. It took us a lot of time. Well, we had a longer procedure because of this, a lot of contrast and high radiation doses, and of course the high risk of different complications. When we started using 3D reconstruction, the software selects the projection for us, just one scan. Well, the time of the procedure was reduced to 43 minutes, the reduction of the contrast media, the reduction of the radiation dose, and a drop in the number of possible complications. Let me just give you a clinical case. 77-year-old patient was hospitalized for aortal valve failure. The patient was examined. Well, a decision was taken to do the operation, the implantation of the transcatheter balloon. Well, transfemoral access was used. During one standard rotational scan, and I cannot launch the video again, sorry about that, we get a 3D imaging. The minimum contrast media, fluoroscopy 5 seconds, the dose is minimal. So we get a 3D image, and we can easily analyze this information. The automatic analysis of the orifice of coronary arteries. We can do also quantitative analysis using different measurements in order to identify the distance to different segments between the vessels and aorta without calibration, and the sinus of Valsalva in one view.
Actually, in ideal format, we perform 3 scans. First is rotational angiography. The second is angiography during the valve implantation, and third, control angiography. It allows us to speed up the procedure and get diagnostically significant information. The third direction where we use 3D reconstruction, it is the descending and aortic arch prosthesing of this ascending aortic part. Let's consider it on the clinical example. A man, 39 years old, admitted by emergency. CT is performed with intravenous bolus and contrast. We have the diagnosis, the aortic dissection debicki. In our cath lab, on the first stage, we perform supracoronary prosthesis with vessel prosthesis, prosthesing brachiocephal arteries, and endoprosthesing of the aorta with the stent graft with frozen elephantine methods. In cath lab, the second stage is stent grafting and 3D reconstruction. The next step, our patient, we did not perform intraoperation CT diagnostic, and we did not perform a CT. The patient was planned for the next stage of procedure as a selective patient. What are the advantages? Better studies of the topography, we understand them. Better preciseness, usage in the real-time mode, modern interventional instruments, optimal choice, less contrast usage, less eradication dosage, decrease of time, possibility to decide on the tactics. From all the minuses, we can see that only the problem is the patients with high body mass index. 3D reconstruction becomes an important part of any cardiovascular center, and it simplifies significantly the work that we could not have used earlier. Thank you, and I'm sorry for this problem with my video. Thank you so much. Any questions? I have a question then. We work with TAVI, and you have not persuaded me that we need 3D and it would help me. Please do persuade me that we need it. We have TAVI, we have CAT picture, we have CT picture. We measure everything, we do everything. We have coronary arteries. We have different projections. Please tell us about your experience. What was the main result? I didn't understand quite well. Intraoperatively, it is very important we have good, precise positioning. 3D allows us to do it intraoperatively. We use transapical approach. If it is transapical approach, the anatomy and configurations changes. The preciseness of CT that was performed earlier is changed significantly. So for us, 3D is a good additional part for our work. And as we start using it regularly, we're used to this method. For us, it's kind of additional bonus. Well, it's a pity we haven't seen your video. In my view, we have 3D picture, but the heart contracts, and your 3D picture does not contract. Well, it is about Clapin projection, how we have to put the art. So you find the ideal projection. Okay, we have one more question as far as I can see. Wonderful presentation. Why do you perform intraoperatively CT if you have CT and you can perform the reconstruction on the working station and combine this CT and you will have same synchronization? Well, in our experience, we have the certain transapical and femoral experience, quite big, actually, quite big. And the pictures are different. We do it on Siemens. We do on Siemens. We see CT. It seems to us that probably we don't need some additional methods, but we see the 3D reconstruction. We see that there are differences. If we do CT, probably, as the previous speaker said, intraoperatively, probably then it would be possible. It would be possible to perform. Probably. That's what I do stress, probably. But when you work in the OR, when you are constantly in active work, it's important for you to have preciseness. You demonstrate it. Well, this intraoperatively, it is easier for us to resolve it if we have 3D. My question is, can you perform reconstruction when you have the delivery to the valve? When you accept the delivery and at that particular moment you perform 3D reconstruction. It would be super precise, super precise. We'll do it next time, I promise you. Well, one more short question. When you perform this accompanying with echo, you have this echo, haven't you tried to use 3D function? Wasn't it enough for you? Wasn't it enough for you? Well, have you tried? Now, my question to you, have you tried it with echo? Under echo control, can you set the valve? Yes. Yes, under echo control. But you need the CT, right? Is it enough for you, echo and X-ray? This function simplifies our work a lot. Well, look, before we have 3D, the choice of the projection was performed as following. We imagine how we put on the arch to the legs. It was difficult to combine all the signals to position valve correctly. When we got 3D, a computer program demonstrated to us how we put the arch. I hope you understand me. Well, we need to understand that the colleagues have very good experience in implantation. Is routinely? Yes, it has its definitely big advantage. It's pity we haven't seen your video. We would understand better how it helps. And we have no doubt you do it for certain purpose. It's always some serious intervention. Our session was really interesting, and it's demonstrated that the technologies are going forward. We can use carbon dioxide, stand navigation, IVOS. It's all in our hand, and very often it's in our hand, but we don't use it really. CT, we have this possibility, but we don't do it actually. Together with Dmitry, we'll come and try to learn how to do it, and then we'll tell you how to do it in a second, because we have it, but we don't do it. We're always open to help you. What are the main tasks to make the procedure fast and safe? To improve everything that would negatively influence, to decrease the contrast. The faster we do it, the better the result is. Dear colleagues, use all the modern technologies to be in trend. Now we're done here, and it's the time for the next session to start. Dear colleagues, we start our last session. Last but not the least, this is the fighting between cardiologists and oncologists, where we have the third party to participate in this fight. The first presentation, endovascular treatment of severe aortic stenosis in oncological patients. I hope you hear me well. Hello, dear colleagues. Hello, dear moderators. Thanks, dear organizers. One more time, I can present at such a wonderful conference. I hope there are still people online listening to us. And I would love to present to you a presentation dedicated to the problem of endovascular treatment of aortic stenosis in oncological patients. If we talk about transcatheter prosthesis of aortic valve, we see the increase. Of course, there was some drop in COVID years, but the trend is there. We still see these patients increase. We have this financing. There is the percentage of the patients who need this procedure and who get this procedure is still very low. The requirement is significant, and we have lots of patients who get this procedure. But nevertheless, we see a certain experience collected, and we start seeing complicated patients with whom we have to do something. These are patients with a diagnosed oncological pathology. Mainly, these are patients on their CT planning stage. These are asymptomatic patients. According to CT angiography, they have pathology of lungs and kidneys. Here is a nice review that demonstrates that about 4% of patients in CT streaming, we see concomitant oncological pathology. Most commonly, these are GI oncological issues, less often prostate and breast cancer. Today we see 3 prospective studies. When we compare the safety for transcatheter occlusion, and we understand that we have certain follow of further studies, but we know that there is no relapse period. If we talk about early stage of oncological process, we do not see any significant change for long-term survival, because after prosthesis of aortic valve, we have this quite significant treatment and wide treatment. We speak about significant risk of bleeding, risk of thrombotic arteries, risk of thromboembolism of lung arteries, pulmonary arteries, and in everyday practice we see more and more of the influence of oncological therapy. This is the therapy that can influence spastic process inside the vessels, cardiotoxicity, and the limitations that we have in radiation therapy, these open interventions. Well, talking about our results, we have performed 157 transcatheter prosthesis of aortic valve. In most of the patients, for the first time, the oncological disease was found. It was an early stage in some patients, and they were taken for transcatheter prosthesis, and they are still alive because they have had good somatic status. And as for oncopathology and prosthesis, the distribution was as following. You can pay attention here. And talking shortly about these patients require significant attention. We work in multi-profile stationary, and it is our definite advantage. We know these patients totally. Of course, this is an additional load on X-ray surgeon. He is the first one to see them. Of course, we need to agree with the surgeons, with oncologists. This is our distribution of the patients. These are patients from 61 to 92 years old. There were a few patients for whom we could not have performed the prosthesis of their aortic valve, and the patient has already passed cabbage. And here it's difficult to explain. It was December, and most probable there were no quota we found, and in 61 we just treated this patient. The difficulty of these patients, you can see at this case, a man complains about shortness of breath. We see medium gradient, all the indications to the particular intervention. For all the patients at this age, we perform coronarography to exclude the problems in transcatheter prosthesis. Moreover, often they have atherosclerosis of coronary arteries. Particularly, this patient had anemia. After performing coronarography, verification of the diagnosis was performed. The next hospitalization. Then we see the additional transfusion, blood transfusion. The cooperation between the departments is there. The percentage is left here because we have the suspicion of the chronic anemia and possible blood losses if he's on monotherapy on clopidogrel. The third admission to the hospital in 3 weeks. At that time, the quota was accessed. We performed the transcatheter ablation. The fourth admission, again, low hemoglobin, blood transfusion, and we see adenocarcinoma, adjuvant gemcitabine in 4 years. The man is 87. It's all okay with prosthesis. Medium gradient is within 8. We see no relapse or remote metastasis. He lives, he feels well, so it's all okay. The next person is our colleague. He was observed in our stationary, and we could have seen him in 2026 and 2027 with the cancer of sigmoid. The surgeons did not want to perform the prosthesis of aortic valve, saying that using AIC device, the prognosis would deteriorate. The guy is young, with no severe comorbidities. We performed it. It was not a problem. We took the person for the prosthesis. We used balloon, extended balloon, and in 4 months, we saw that everything was based on the time and financing. At the end of 1 calendar year, beginning of the other calendar year, laparoscopic resection was performed. We see good anastomosis, and the person even started backward to work. In this person, man, 85 years, severe aortic stenosis on CT, TAVI was planned, and right kidney by prosthesis, my valve, 26 millimeters. He was admitted a few times to hospital Again, for full myocardial revascularization, we see a few stents here. The patient is under observation with a good result. And keeping in mind his age, he would be under oncologist observation because according to the staging, the tumor is not big yet. And the final slide, CT angiography, plantarity. We see some neoplasia in right lobe of the lung. We perform self-expanding stenting Corval, and in 7 months after our intervention, we decreased one more time the risk of open surgery intervention. We perform the typical resection of the upper lobe with a good result. And this patient is under observation for 2 years already. No relapse, functioning prosthesis. So take-home points, we need to have very serious personal approach, tailored approach. Transcatheter prosthesis of aortic valve allows to perform further treatment. It decreases anesthesiological risks. And here, actually, we need to be very, very involved. We always have to be in contact with the patient to win time for these patients. As for endpoints and stratification of risk groups, we need additional study, but our results are within the meta-analysis that we have today. Thank you for the attention. Thank you very much. Thank you very much. Questions, please. Questions from the audience. The question is off the mic. Unfortunately, the question is off the mic. Question is off the mic. We're waiting to hear the question. The question is off the mic, unfortunately. We don't hear the question. We don't hear the question. We don't hear the question. The question is off the mic. The question is off the mic. Question is off the mic. Question is off the mic. No mic, no translation. Thank you for the question. It is a topical question. We have arithmological service and we just started the new medical record, set the cardio pacemaker. If there is cardio blockage, when we see the decrease of myocardial, and we said they're just pacemaker, there is no problem with this. There are not so many of these patients. We have other techniques such as cascade overlap of the self-expanding valves. The frequency decreased. We see more of this. We have less of this problem in like 10% of cases. It is not even, we do not consider it even as a complication. It's a logical result of the intervention, and these patients know about that.
Well, the question of the comment is off the mic again. The answer is no, none. Well, as for open surgery, well, usually surgeons refuse to do it. Well, but as for the clinical guidelines, Well, yes, asymptomatic patients, in order to treat them from a new pathology, can be subjected to such interventions. There is a comment on the question of the mic again. As for aortal stenosis, we treated aortal stenosis, but without any symptoms. It was asymptomatic. A 6-minute walk test, the patient just underwent this test. Yes, there were indicators for this kind of treatment. Thank you. Any more questions? Use the microphone, please. Any specific complications at the second stage of treatment? You mean after the surgical treatment, after the surgery? Well, this group of patients had no problems because they had the low stage, and 0 and 1 in one case, and there were no problems in terms of the length of the hospitalization, in terms of hospital stay, and we don't have thoracic surgeons. One patient was operated on at the cancer dispensary in St. Petersburg, but we're in contact with all our colleagues and our patients, so we monitor them. They come to us for control tests. Half a year later, all the patients are alive, as far as I know. Any more questions? Well, just one more question. Again, the question is off the mic. The answer is, well, does staging have an impact? Well, we haven't had such studies. We have had only 5 patients, but there will be more and more patients. That's why we decided to make this presentation. I have a second certificate of an oncologist, and I choose people for transcatheter prosthesis. So, well, I can make such decisions. So, again, the comment is off the mic. Sorry. Well, that's justifiable, but again, if we have distant metastasis, bringing to bear that we have problems with financing and quotas for treating such diseases, you have to provide the justification for doing such an intervention. Well, if the patient's cancer can be treated in the future, then a valve can be installed. Well, if it's a stage 4 with gigantic metastasis, no one will be dealing with this patient, and the patient doesn't need a valve in this case, in general. But you can use pembrolizumab, and you can treat the patient. Yeah, treat the patient for cancer first, and then install a valve. We must have a large category of patients and stratify them by risks to answer this question. All right. We have no second presentation. So, Larissa Shenkovtsova, ACS in patients with an acute cancer process, how to choose the best approach. Good evening, dear colleagues. Let's move on. It's a follow-up to the previous presentation, how to treat the patients with ACS who have active cancer. Cancer patients and ACS are the vulnerable groups of population who do not get proper treatment. And we expect that with the improvement of cancer treatment, this population will only increase. The treatment of ACS and cancer patients is a difficult task because we need to have the balance between different risks. Patients with active cancer suffering from cardiovascular diseases pose a serious problem because there are serious problems with evidence, serious gaps in evidence. This group of patients is usually excluded from large-scale randomized trials in case of ACS. As for the scales to assess the risk of bleeding, does not take into account cancer processes. I found only 2 scales which take into account cancer, but without any details. And as far as I know, few doctors use these scales. What are the major clinical scenarios of ACS and a family history of cancer? ACS and active cancer. ACS and active cancer plus the recently performed surgery. AKS and active non-operable cancer. Cancer diagnosed during the treatment of ACS, and the case when the patient or doctor do not know that the patient has a malignant tumor. Plus, patients can be on chemotherapy. In 2023, the ESC, the European Society of Cardiology, came up with guidelines to treat patients with cancer and ACS, and there are 4 types of cancer in patients with ACS. Well, you can see prostate cancer, breast cancer, lung cancer. Lung cancer has the worst indicators. The risk of bleeding is much higher in patients with colon cancer. As for in-hospital mortality, it is higher with active cancer as compared to the family history of cancer. Our guidelines, the guidelines we're using in our routine practice, are just touching on this group of patients. They say that the presence of a malignant tumor is an unfavorable risk factor for bleedings. So here you can see the ESC guidelines for treating patients who are non-STEMI patients. They have a higher risk of bleeding during 12 months if cancer was detected, and in fact there is no more information about what to do with these patients. Again, looking at the ESC guidelines, let's look through the major items here. ASC diagnosis in patients with cancer must be based on the same principles as on patients without cancer. Patients with cancer of the family history can be treated the same as patients with ACS, but patients with active cancer, fall into specific categories that should be taken into category. Stenting of patients with cancer is recommended if the life prognosis is more than 6 months, the survival rate is more than 6 months. If it's less than 6 months, the survival is less than 6 months, there is no advantage as compared to conservative therapy. Balloon angioplasty is considered only in case of severe thrombocytopenia or the need of an emergency procedure. Again, FRA or IVIS should be done if we can consider a cabbage if the survival rate is supposed to be more than 13 months. As for DAPT, it is preferable if it's a clopidogrel as part of DAPT. The duration of DAPT should be as short as possible, up to 3 months. If the patient is needed in NOAC administration, triple therapy will be administered, but aspirin should be cancelled during the first week. Thrombocytopenia occurs in 10% of patients with active cancer. It can complicate the treatment of the patient with ACS, but coronography of such patients can be performed in case they had the thrombocytes received radial approach and thorough hemostasis. As for anti-aggregants, aspirin must be cancelled if platelets are less than 10,000, clopidogrel less than 30,000. Bleeding. These patients have a high risk of bleeding. You should stick to major principles of thromboconcentrate transfusion. Anticoagulants should be cancelled. Antifibrinolytic drugs should be administered. As this slide shows, most patients with cancer, active cancer, will be treated medically. 50% of patients have a coronography done, and only about 5% of patients with cabbage, and 20% with PCI. This study has shown that patients with cancer well, have a lesser number of PCIs as compared to patients without cancer. Well, you can see more than 40,000 patients with cancer pathology were included, and only 54% of patients were subjected to PCI. Here is another prospective study, 13,000 patients included. The investigators assessed the primary endpoint, bleeding and thrombosis in cancer patients. The risk of death from cardiovascular events was higher in such patients, but it was not because of stent-associated conditions as compared to patients without cancer. The risk of bleeding was higher in cancer patients. CABG in cancer patients must be a preferable strategy, especially if they have the complex coronary anatomy. And for patients with cancer, should be subjected to the discussion of the hybrid approach, when we can do CABG and tumor resection simultaneously. There are some non-randomized trials showing that the simultaneous operations are safe and effective when 5-year survival was assessed when there is patients in the chest with a cancer in chest cavity. A female patient, 71 years old, was hospitalized to our clinic. She has diabetes mellitus for 2 years. She was treated from iron deficiency anemia. She had, well, blood tinted stool. Hemoglobin was 60 milliliters per liter, and there was the tumor of the blind gut cupola. Well, she was supposed to be hospitalized, but when she was coming home, she had a seizure. She called the EMT. There was the elevation of the ST segment on ECG. Well, she got assistance, well, depth heparin. She was hospitalized to our clinic. When she was admitted, the pain syndrome was coped with. Coronography was done, and you can see unstable plaque in the proximal segment of LAD, and we thought what to do. Hemoglobin, well, 90, troponin 0.76, well, can the infarction, the patient has the bleeding, well, she will have to be operated a week later. Can we put a stent and administer depth, or should we just wait and see? Well, anticoagulants were cancelled. Well, we administered the maximum dose of statins with izotinib, and we decided to consult with oncologists of the patient. And the oncologist well, convinced us that we can postpone surgical intervention for 1 or 2 months. Well, and so weighing all the risks in favor of PCI, and we had several factors here, like subendocardial, myocardial damage, unstable plaque, a large area of myocardium that could be damaged if there is an occlusion, and a high risk of infarction relapse. So we decided to do the stenting with the cancelling of depth. 1 month later, the patient had PCI done, a stent was implanted. Sorry. After the PCI, we did the anemia correction. Well, there was no bleeding. On day 6, she was discharged from ICU. Then she was discharged on day 15. Hemoglobin 94 grams per liter. In case of bleeding relapse, she can just cancel cardiomyopathy. 1 month later, she was operated on. The right-sided hemilectomy was done with the iliotransverse anastomosis, adenocarcinoma of blind gut or blind intestine. On day 2 after surgery, oncologist resumed the depth. Right now, she is being monitored at our clinic. Very good profile, lipid profile, good ejection fraction. Well, here is the second clinical case. A male patient, 66 years old, turned to the urologist. He had complaints about episodes of hematuria. Well, you can see myocardial function of the lower wall of the left ventricle. Well, he did not take aspirin because of bleeding, he was done MSCT of the urinary tract with a contrast, and the patient was hospitalized to us with a relapse. Well, repeat low wall infarction with the ST elevation, hemoglobin 92, coagulopathy, no coagulopathy. The patient had coronography done, occlusion along the proximal edge of the stent. Thrombectomy was done, stent, well, then depth 10,000 of heparin, but something went wrong 4 hours later. The patient had the hematuria. Conservative attempts to stop the bleeding were not successful, so we decided to do the embolization of urinary vesical arteries to stop the bleeding because the patient was losing blood. Well, embolization was done, the bleeding was stopped. On day 3, he was discharged, and we lost any connection with the patient. As for EMI, well, electronic medical record, EMR, it turned out that there was no repeat procedure, no hematuria. Well, he was hospitalized to our clinic again. He went for the Holter monitoring, ECG. We did the ultrasound of the bladder, and it turned out that there was any neoplasm in the bladder. So what kind of tumor was it, malignant or benign? Well, so we treated not just infarction, but also we treated the bladder. Well, everyone was happy. It was a happy ending. So managing cancer patients with ACS is a complex problem that cardiologists must solve together with oncologists and endovascular surgeries. Multidisciplinary team should be involved, but we should use a more aggressive way of treating patients with ACS and cancer. If endovascular hemostasis can be done, patients with ACS and cancer should be included in future randomized trials to have a better understanding how to find the balance between high risk of bleeding and thrombosis. Well, cancer should be part of different scales to assess patients, and also we must have an in-depth understanding of oncopathology and the cardiovascular diseases, thus minimizing possible errors while making a diagnosis and identifying the reasons for death, which would make statistical data more reliable. Thank you. Thank you for this presentation. Any questions? Yes, please. I have got 2 questions. First, what did you use for urinary bladder embolization? I am not ready to answer this question. I am a cardiac surgeon, not a urologist. Thanks. The second question, we often see patients who are brought with ACS, and they have unstable angina, and they are usually being treated for the main cancer disease, and they get chemotherapy. So should we take such patients for coronography because they have elevated troponin level or not? Well, you know what, our position is as follows. What can patients die of faster, from ACS or cancer? Well, let's say the patient had some complaints, like he is feeling bad after chemotherapy, he doesn't feel well, troponin is elevated, well, unstable angina, etc. So, and they tell us, take this patient. Well, look here, the patient may have MI type 2, myocardial infarction type 2. Troponin can be elevated for different reasons. Well, in this situation, so I would monitor the patient in this situation, stabilize his condition, do Holter monitoring or ECG, well, to find out if he has ischemia or not, and then a decision can be taken regarding coronography. Well, come to us, because our cardiologists do not consider it. And where do you work? St. Petersburg, hospital number 40, because our cardiologists do not think like that. Unfortunately, in clinical practice, they do quite a different thing. That's our approach. Well, and you will have to fight not just common sense, but also, well, with the administration. And with the mandatory medical insurance fund. You have to write a lot of explanatory notes. As for the 2023 guidelines, there was a slide like that. Well, you mentioned non-STEMI. Am I without ST elevation, right? Yes. Yeah, actually, in both cases. But coronography should not be done if the patient has elevated ST, if the patient has the main disease. Well, not to put a stent if we have thrombotic occlusion. Yes, we're doing this. In any case, there is a difference here. It's not feasible to put a stent in a patient whose survival is just less than 6 months. I just provided the excerpts from those guidelines, but my opinion is quite clear what the patient can die of. In case of cancer, well, if the patient sometimes can live for 10 years, but the prognosis was the survival is not more than 6 months. There were cases like this as well. Well, and my second question, there was a clinical case, the patient with ST elevation and ASC. Well, there was a delayed, deferred stenting. When did you do it? 2 days later, okay. And what was the justification for that? Well, the high risk, no, wait a minute. I mean, as for the electronic, medical record. Well, it was written there that there is a relapse of bleeding. that can exacerbate the situation, I think, and in our situation, that means not following the guidelines. We would have been punished for that. Well, we usually treat such patients. Well, thank you. Thank you. Any more questions? Sorry, the question is off the mic. Well, we like this approach, but unfortunately, you cannot do it with our cardiologists. Thank you for your comment. Thank you. Let the lady go. The next presenter, Alexander Vasilyev, acute sinus thrombosis of the central nervous system in patients with lymphoproliferative diseases. Distinguished colleagues, we have the experience of 2 centers presented today. Venous strokes usually occur due to sinuses, and the frequency rate of the disease is very low, less than 3%. But if we go into detail, if we make a thorough diagnosis, it can be in 5 to 10% of patients with acute ischemic stroke and 3 to 5% in patients who are on chemotherapy. And the average age of patients for venous strokes, acute venous strokes, is 74 years. If these are cancer patients from 50 to 74 years, usually such diseases occur in patients who are hospitalized. Usually their strokes end up normally. There might be TIA as a result of the chemo medicine. Well, and sometimes patients are under investigated. Well, patients are discharged, then they come back to us, and they might have severe complications due to early thrombosis and complications due to chemotherapy. Here you can see the risk factors for venous strokes. Well, venous strokes occur more often when there is the occlusion of the brain sinus, an edema is formed, and then there is the hemopenetration into the brain. We can see the hemorrhages, brain hemorrhages, according to CT. Also, we can see early hematomas. At a later stage, the clinical picture is not quite specific. It is kind of blurred for venous strokes. So we can suspect any condition, including cardiac problems. And again, you can see here that there might be seizures included here, epileptic seizures, and different syncopal conditions requiring the differentiation. According to our observations, starting from 2017 to 2023, well, these figures need updating. We have about 300 patients with acute strokes. These figures are a little bit old. And we had 185 patients with acute sinus thrombosis of the brain, also thrombosis of transverse sinuses. Here you can see our observation data. Well, the Institute of Hematology and our hospital. In case of sinus thrombosis, we use thrombolysis, thrombolytic therapy as the first line, or combined thrombectomy, depending on the severity of the condition. Usually we use a thrombolysis, fortalizine or Reveliza. Okay, in case of thrombolytic therapy is inefficient, we use a thrombectomy. Well, that's what the sinus thrombosis looks like on MRI, usually without contrast. And you can see a very good picture here. And let me just show you a clinical case. A male, 33 years old, on chemotherapy in 2017. He had seizures, headaches. A CT was done. A hematoma in the lobotemporal area was detected. Also, an MRI of the brain was performed. There was the thrombosis of the upper sagittal sinus. Since anticoagulants and thrombolytics cannot be administered, thrombectomy was performed. So that's the first patient when we started our surgical interventions for such thrombectomy was done. The blood flow was restored on day 7. The hematoma was shrunk. Again, we had a very good clinical outcome. Again, you can see we used the Rankin modified scale to assess the patient. Here is a female patient, 52 years old. Sorry, there was another data here. Again, this patient was monitored at the cancer dispensary, NIS 165, MRS 4, aspects 10. Again, there were parenchymal patterns in the temporal lobe, and we visualized the transverse sinus on the left. Angiography showed acute thrombosis. Aspiration was done after 10 runs. Again, you can see there was still the thrombotic occlusion preserved. The thrombosis was growing. It was impossible to remove the thrombotic masses right away, so we started to use a retriever. A stent retriever was chosen. It was a CTO 6x44 runs, and we restored the patency of transverse sinus. The patient was discharged without the neurological deficiency.
On discharge, she didn't have any complications. The pattern disappeared fully, ranking 0. Next patient, 49-year-old, with headache, parenchyma 3, aspects 10. In history, acute disease. And now I need a video. Well, that said, I cannot start my video. Initially, there was massive sinus thrombosis. Thrombectomy was performed. We see the residuals of thromb. We tried to aspirate it, but we didn't manage. We tried to push it through stenosis of sigmoid sinus. It didn't work. Catheter, there was an attempt to use catheter, and we decided to use stent retriever. After one passage of stent retrieval, this thrombotic mass stayed there. We decided to use 2 stent retrievers, restored the patency of transverse sinus. The patient was transferred from oncological department. At 1 hour in the morning, she felt acute headache. The patient couldn't remember where she is, full amnesia. She was examined by our neurologist. It was cerebral infarction, thrombosis of left transverse sinus, ranking 2, aspects 9, small lesion. We haven't seen arterial pathology. Now we need video. Acute thrombosis. The aspiration. The reaction was used, but unfortunately not everything we have in market. And let's see the video one more time. This is the final result after stent retriever and aspirator. In this case, there is no symptoms in an hour of under the surgery. She remembered nearly everything, but for the first 3 hours when the acute stroke happened. All the patients have double antiplatelet therapy. This is our protocol to examine the patients, especially those who get asparaginase. We have to keep in mind different factors for the patient who are getting chemotherapy. These are predictors that decrease the risk of thrombotic complications. And to conclude, endovascular technology thrombectomy demonstrates its efficiency in venous stroke, even in postponed period. These patients can be taken for the surgery even on the day 3 and day 5. We have enough of time. We can evaluate the efficiency of conservative therapy. Asparaginase therapy can be accompanied by thrombotic and hemorrhagic complications. One and most proven efficiency in hemorrhagic complication, frozen plasma in acute phase of thrombotic complication. We can use endovascular correction methods with anticoagulant therapy. Thank you for the attention. Thank you for the presentation. Question, yes. Technical question. Femoral access? In most cases, femoral. I like transcubitals. If I plan to implant stent, I prefer transcubital. Have you tried to use transcubital access the destination to perform aspiration? Yes. Yes. Neuromax works well in neuron insult. If there are no pathology of sigmoid sinus, we can perform the plastic. We just use balloon, a 6 mm balloon. Yes, that's the coronary balloon. We use mainly Stirling 5.5, 7. That's okay. That's enough. More questions, please. Did they have secondary cases? In the last patient had the secondary case in a month. At that moment, we were scared about stent implantation. We'll see the residual fibrin in the chronic lesion, and retriever just ruptured it and thrombosis appeared. The patient stopped taking anticoagulant therapy, only aspirin. There was thrombosis. We implanted stent, and then everything went well. So the patient did not experiment with these drugs. Thank you. Thank you so much. And the last, Artyom Mazurenko, vascular surgery in cancer patients. Good evening, dear friends. Thanks for your patience. The best are still here. I want to start talking here about one problem. I can stand like this. I will straight upright. We can start speaking about one significant problem that we have here. We have to deal somehow with this problem and to share this problem with you. And probably you will give me some your opinion. I'm not oncologist. I'm a classical vessel surgeon. Thanks God I'm not endovascular surgeon. Here, of course, everybody you use endovascular surgeon. Well, somebody needs it, but our work is also needed. At the moment, in oncology, we always see, and vessel diseases are leading, is the reason for mortality. And sometimes there must be the intervention on heart vessels and oncological intervention. And surgical treatment with most vessels is one of oncology unresolved issues. What do we do? This is a very famous phrase from Solzhenitsyn's cancer building novel. The patient is sent to the vessel surgeon, and the vessel surgeon says, we don't operate you, you have oncology. And these patients are forgotten. If you live in Moscow, St. Petersburg, when you have lots of oncological centers, it's easier for you. We live in the city of Blagoveshchensk, but we do not have huge centers. All these patients come here. As Mr. Davidov thinks, one of the ways to increase operability of the patients with locally advanced tumors is usage of reconstruction interventions on the vessels. These are vessels fields where we need to work. It is thromboembolic complications, advancement into vessels, selective chemotherapy, primary tumors, and most interesting, simultaneous surgery, oncology, and cardiovascular diseases. Of course, we started with a very simple diseases, carotid hemodictoma. It's oncological pathology. We are not talking about venous thrombosis. We are talking now only about serious oncological pathology. We had carotid hemodictoma, kidney cancer with tumor invasion, and simultaneous surgeries. While collecting experience, surgical experience, teamwork experience, getting certain devices, we started working with bigger volume. Now we're even near the heart. We can If the tumor is localized in right chamber or atria of the heart, we can work with that. There are different levels of invasion. We can even to perform the prosthesis of the lower part of inferior vena cava, superior vena cava, kidney. The renal vein is not a problem at all. We have certain interesting experience. This is thermal laparotomy. And we see different ways to bypass it. At ECMO, we can resect different parts of liver, and we sometimes can perform the resection. We undo picture, and that's why I'm demonstrating you picture. This is the thrombosis of right atrium that appears from iliac vena, right iliac vena through the whole vena cava. We cleaned it all. This gemangioma. We started using different embolization to reduce the bleeding. Simultaneous surgery that I mentioned already, we have certain experience. Mainly these are intestinal cancer, when we use cabbage as well. Acute pathology. We have collected this experience. We perform these surgeries, but we see that there are certain legal problems today. We see the progression, and we see, for example, the bleeding cancer, this locally advanced tumor, prosthesis of inferior vena cava. The girl nearly died due to sarcoma that overpressed trachea. We have this experience, we collect this experience, and we can work. We work in hepatoduodenum zone, liver, artery, upper mesenteric artery. So the vessels do not prevent us from removing the tumor. The question is, who has to operate on these patients, oncologist or vessel surgeon? We're not talking about big oncological centers. I'm not talking about big centers that have vessel surgeons when you can call a vessel surgeon immediately. I'm talking about 150 small vessel departments. Do we need to call oncologist? But how will he be certified if it is written vessel surgery? Or our oncologists need to perform this vessel surgeons, how to certify vessel surgeon? We understand this situation. The next problem is the tariffs. These surgeries, they are quite expensive. So, dear patient people, what do you think about that? Who should do it? It is a discussion topic, disputable topic. Thank you for the attention, and thank you for your patience. Now let's open the discussion. Tell us your opinion. My opinion is confirmed by my activity. We operate themselves. We have oncologists. We have vessel surgeon with oncological certificate. It is kind of legal coverage, legal protection. He doesn't work in any other oncology. His certificate will run out of it, and he will need the update of his certificate. Of course, he will pass it, but it will not be always like this. The situation will change. He doesn't work in oncology clinics. That's the problem. How should it look like? Few times I went to our oncological dispenser when they just started the surgery when there are vessels, and quite often the bleeding starts. We had stroke in one lady. Thanks God, we didn't lose any patient due to surgery aggression, though these were very vast surgeries. Who should do it? Who should do it? That's my question. The team. Which team? The comment is off the mic. The comment is off the mic. Okay, we prognose, we see. What do we do next? What do we do? We're complex team. I work in Blagoveshchensk town. I can come only for emergency. Vessel surgeons. Can you imagine how many things I have in my OR? I have cell several 3 types and prosthesis of 10 types. I cannot take it all with me. You know how many they will call me for venous thrombosis with the 0.25 vacancy. Any thrombosis. So the comment is off the mic. The comment. We're not talking about thrombosis. We're talking about surgery. I operate them myself. What's the oncological situation of this patient? They go to oncological treatment if needed. Our abdominal surgeons perform the resection, kidneys, heart, without abdominal surgeons. It's our. What to do with oncologists? These patients are sent to oncological treatment, and then they are supervised and managed there. They should go to the oncologist first. Oncological board should make this decision. Oncological board should make this decision, not you. Or is there some different approach? No, dear colleagues, I demonstrated to you all the patients with the thrombosis. These patients require surgery. I'm not talking about some blood and light patients. These are patients whom you need to operate immediately. Great. Thank you for the advice. I was approaching this situation. We must send them for oncological commission. We send them and they disappear because they cannot do it themselves, and they send them to the center. For our center is Moscow. That's it. Yeah. Can you imagine? It's not possible. It's impossible to get to Blakhin or Gertsen. They don't know. They know about me. This is policy. Well, dear friends, I wanted to have good discussion. I wanted to hear from you. Well, Moscow and St. Petersburg, it's all the same. When you perform embolization, it's all the same. Trust me. It's off for the mic. Hemodectomies disappear. Oncologists uncover it and send them to Moscow. Nobody goes to Moscow. I'll add a few words from myself. It's a global problem of Russian medicine. We do not have adequate management and communication between doctors as well. We are not taught to do it. We are not taught to perform it. It's off the mic. Well, actually, the communication resolves a lot, but nobody teaches us this proper communication. It's all about personality. That's our life. That's our life. Thank you so much. Thank you so much for patience. We are out of time. We went behind the schedule. A great session. Thank you, everybody. Thanks for participation and thanks for attention.